He's coming in and out too.
Good morning, everyone. We will call our Public Health Committee public hearing for March 4th, 2026 to order. Welcome. I'm Senator Saud Anwar. I'm the co-chair for the Public Health Committee. Looking forward to hearing from people in person and remote. With that, I'm going to have my co-chair, esteemed co-chair, make a few opening remarks. Representative Kristen McCarthy-Vahey.
Thanks for coming, everyone. We're looking forward to talking with you today and hearing from you, more importantly.
And our ranking member, Representative Claire Teacher.
Thank you, Mr. Chair. Good morning, everybody. As always, we look forward to hearing from every single person in the public. Thank you.
Who has registered, that is. Good. With that, I think there are multiple public hearings and meetings happening. So we know that many of our colleagues are online, but also in different rooms. So we will see when Senator Summers joins us, we will be able to have her speak. The first person on our list is Senator Looney. I do not see him here. So when he comes over, I know he's also in multiple different meetings. So when he arrives, we will have him speak. The next person on our list is Boyd Jackson, who will be joining with Edlita as well. So you can come. Welcome. Thank you for being here. We are using a different room. We have another room usually, the 2D, where the room is very personal, but the sound system is not. And now we have the sound system, but the room is a little distant, but you're very close to us. So go ahead.
Good morning, Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claire Detria, and members of the Public Health Committee. I'm Boyd Jackson, Director of Legislation and Regulation at the Office of Health Strategy. I direct OHS's policy and legislative work, the legal team, and OHS's Certificate of Need program. Thank you for the opportunity to speak on the governor's proposal to reform, streamline, and revitalize the state's CON process. Last year, we collaborated to create a new emergency CON process so that OHS could review the transfer of ownership of a hospital in bankruptcy on an expedited 60-day timeline. That process was immediately implemented for the two prospect transactions. Each was completed ahead of the 60-day deadline and approved with conditions to ensure the affected communities would have continued access to high-quality, affordable health care. The emergency CON experience demonstrated what our program can achieve when focused on the right criteria, authorized with the right tools and timelines, and granted the flexibility to move a docket forward efficiently. That experience, lessons from neighboring states, and the past few years of feedback from the committee and stakeholders have informed this bill before you today. House Bill 5045 addresses each and pretty much every element of the CON program to ensure the process is efficient and minimally burdensome while enhancing the state's ability to protect Connecticut residents. More specifically, the bill would reduce the categories requiring CON for lower risk transactions, going from 15 categories down to 7, while expanding certain exemptions. It would expand review to capture transactions that can sometimes evade state oversight, including sales of hospital property to real estate investment trusts or private equity acquisitions of physician practices. It'll shorten and streamline the application process, create an expedited pathway for certain proposals, and sharpen the review criteria to focus on access, quality, affordability, and cost-effectiveness of care. It will replace CON review of hospital service terminations with a notice and wind-down process to preserve access and continuity of care. And it'll authorize the proposed panel over the program to implement policies and procedures so the program can respond nimbly to changes in the healthcare landscape that is constantly evolving. My written testimony provides more detail. I'm happy to answer any questions, but I'll turn it over to the Deputy Commissioner from the Department of Public Health, Lita Orefici.
Thank you. I'd like to thank the Public Health Committee for the opportunity to testify in support of this proposed legislation. My name is Adelita Orefici. I am a Deputy Commissioner at the Department of Public Health. I'm here on behalf of Commissioner Jutani today, who wanted to be here in person. Unfortunately, she had a scheduling conflict. She is in Washington, D.C. with the federal delegation right now, talking through current and future status of public health issues that affect the state of Connecticut and the nation. We have submitted her written testimony for your review. I will say that during our preparations for this hearing, Commissioner Jutani wanted me to make sure that I communicated to the committee her commitment to the successful implementation of the proposed changes to the Certificate of Need program. We do believe that these proposed changes will help to make the CON process more efficient, more predictable, more transparent, and more effective for the state. And we think that the leadership and administrative support from DPH can help do this. I'm happy to answer whatever questions I can alongside Mr. Jackson. Thank you.
Thank you so much for your testimony. I would divide the questions, probably many of us may have, into two broad categories. One is about this transition. The second is about the actual process. And there's a historical concern we have about the process, and then we'll touch on that in a second. But I wanted to ask you some very fast questions and one yes, no kind of answers, which I know the answers to, but I want them to be on the record so everybody knows. For this transition from Office of Health Strategies to the Department of Public Health, would anybody lose jobs?
No,
Okay. Would the budget change, total dollar amount?
no.
Okay. And so that's important to have that on the record. And what would be the 2 or 3 big reasons to make this transition? Because many years ago, this was part of Department of Public Health. It was felt that the bandwidth that was needed and the work that was needed was taking resources away from the Department of Public Health, and it was separated out. So what is different now?
I think the biggest thing that I would point to are some of the efficiencies that will come about. And it's not about doing the same with fewer people or with less resources. It's about doing more with the existing resources. I think one big thing is that we're going to see some economies of scale with the support that the programs can receive. We're a small agency. At a small agency, people have to wear a lot of different hats. As you heard, I wear a few between my responsibilities. Certainly a lot of my staff members are supporting either other programs, certainly the attorneys who support the Certificate of Need program as hearing officers or as compliance investigators also are working on FOIA responses, contracts, data use agreements, our ethics policies. The Department of Public Health has a much broader infrastructure across all of the administrative functions and support functions. I'm sure the Deputy Commissioner can speak to some of the efficiencies expected there. But this is really about making sure that programs are located where they can have the most support and the most success in their operations. As it relates specifically to CON and one of the elements of this bill, one of the concerns that we heard raised last year were when there's a proposal, the number of stops that an applicant would have has grown over time. They have to come to the Office of Health Strategy. They have to go to the Department of Public Health. Often they have to go to the Attorney General's office. There may be other stops along the way. So for example, this process, there's a change of ownership process at the Department of Public Health, and there's a transfer of ownership CON requirement, which currently is housed at OHS. This would bring those two together under the Department of Public Health. And you would have one application with all of the materials necessary, and then it would be on the state to coordinate, integrate those processes and handle them all for you so that you're not having to figure out which papers do I file with which entity, where do I go for these things. It's a much more streamlined process. So as specific to this proposal and the relocation of CON, I think that's one of the biggest effects.
Thank you so much. One of the other parts is with respect to the actual process. I would divide that into 3 broad categories. One is, which issues do we need the CON for to have increased number of or access or increasing services? And the other end of that is leaving the services in some communities. And then the internal part is, how long does that process take? So I think from what I understand from your testimony and our conversations, the central part of the process which was a big concern to many of the public health committee members and the community at large. We have come to a point where the emergency process that was created has shown its results. And thank you for the good work that your office has done for that purpose. The issue comes down to is that for the emergency, for the regular, is it going to be back to the same way of doing business, or is it going to be everything is going to be much more streamlined?
Yeah, I think it's definitely going to be streamlined. You know, the OHS has made great strides over the last few years in our processing timelines, going from somewhere around 300 days on average down to about 180. It's somewhere in the ballpark of 58 to 60% reduction in the days that it took to process the average application. And we're really proud of that. But I think what we're recognizing in some of this legislation and some of what we've proposed in the past is we're bumping up on the edge of what we can do without changes to the law. So that's what we saw with the emergency CO when we needed to change the law to be able to do that process efficiently. And that was really what we focused on here, is what are the changes we need to make sure that we have the resources and the ability to move this along. So one of the things that I've heard from many members of this committee over the last few years has been, Massachusetts seems to be doing it well. Why don't we learn something from their process? Our process as it exists is laid out with significant detail in the statute. Every step that we take through the process is dictated in the statute with a specific timeline. We're given a certain amount of days. Applicants are given a number of days. It goes back and forth and back and forth. And it builds out this process that can take some time. Massachusetts says much more, get it done in this time period. And what you need to do in the back and forth and asking questions back and forth can happen within that time period. And that's the approach that we've taken in this proposal today. It says much more, fill in the application, get it in, deem it complete, and then you have a certain amount of time. You need to do your hearing in there, you need to ask your questions in there, and you need to get a proposed final decision out and ready for review by the panel on a given timeline. We think it provides a lot more regularity, clarity, equality between applications. And so we think that overall that's going to streamline the process and provide the agency the ability to get the job done.
Thank you. I just have one last question from my first phase of questions, and I'll have my colleagues start the questions. And this is for the Deputy Commissioner Orifici. Deputy Commissioner, you guys have a lot of work because of a number of things that are happening in the state, but outside of the state with policies. Is this going to slow any of the other things down? Because you need to ramp up quite a bit, I anticipate.
I don't think so. I think we're pretty organized about doing that. And I think that Commissioner Jutani and her leadership team are pretty committed to making this successful. And I'm not just saying that. I think we have a plan. We've collaborated well with Mr. Jackson and his team. I bring to the table some CON experience from Rhode Island and Massachusetts. So I think that we're pretty confident that we can help the staff successfully transition to the department and to give them the kind of administrative and leadership support they need to be successful.
Thank you. With that, my co-chair, Representative Kristen McCarthy-Vahey.
Thank you very much, Chair Anwar. Thank you both for being here. And I am smiling because we have had lots of conversations about this topic at this committee since I have joined. And I know even before I was a member as well. This is a significant change in the way that we are currently doing things. And I appreciate the ability to have conversation here. And I will just note on the record, after this hearing, I anticipate that we will be having many, many other conversations as well with you, with us, those of us in the leadership of this committee and other stakeholders. So I just want to share that publicly. But one of the questions that I have, just looking at your testimony, Mr. Jackson, the expanded review to capture transactions, and you use the example of the sale leaseback to real estate investment trusts, otherwise known as REITs. And as you know, we have a bill in this committee that has made its way through the JF process. There was testimony on that bill related to REITs versus other financial instruments that might be used. And sometimes here we kind of interchange different things. So my question is, that expanded review and the ability to capture such transactions, would it also cover transactions that were not just REITs, but perhaps other financial instruments, as was referenced in that testimony?
Yes, it's a broadening of the definition of what a change of ownership or control would be. Currently, it's a transfer of ownership, which is tied to specific governance changes. This would expand that broadly for whoever was buying a substantial part or buying the ability to control a substantial part of a healthcare entity.
So just to clarify, substantial control, which would include the land, the real property, and potentially put into effect a sale leaseback.
That's
So
right.
you're affirming that, yes, that's what this language would do.
Yes.
That's helpful, I think, and important, even as we have a parallel conversation in that other bill. The other thing that I wanted to just ask you to do, as you often hear me say, and my colleagues, our fourth grade level is what I welcome. And I think you've done a great job in your testimony outlining things in a very clear way. But the changes, kind of the high level highlights of what the significant changes will be. I know you went through some of them, but there's more in your later testimony. And I wondered if you could just expand upon that a little bit, how the process will change. I know you talked about streamlining, but if you could just give us a little bit more detail on that, I would be grateful.
Yeah, I think one of the big changes to the process is the final decision maker. The final decision currently lives with the commissioner of the Office of Health Strategy, and it has since it moved to the Office of Health Strategy. So the big change is to bring a panel as the final decision maker that would have 3 people as proposed, chaired by the Commissioner of Public Health as the person responsible for the program, who's doing all of the work, collecting the information and doing the analyses. The Commissioner of the Department of Social Services and the Secretary of the Office of Policy and Management. The thought is it's important to bring a variety of perspectives to that final decision. And these are the people in the government who are most closely tied to all kinds of decisions made in the healthcare sector. So with DSS, obviously, over the Medicaid program, Medicaid access is a key part to the CON program. In our existing criteria, there are 12 criteria, and I think 3 of them, so a quarter of all the criteria, reference Medicaid access. Obviously, that's an important part to this whole analysis, and so having their voice at the table to share information would be useful. OPM, obviously, the state is a major payer of a lot of healthcare services and involved across the spectrum. Also, certain elements of OHS are proposed to go to be under OPM as well. And so I think ensuring that we have access to that expertise in the final decision making would be really useful to that process. So that was probably not 4th grade, but the key point is having a panel as the final decision maker is one of the big changes to the process.
Any other pieces that you would like to highlight? And again, with a little more detail is fine.
I'll highlight the change in how hearings are handled in the process. Historically, you could demand a hearing, or the agency could hold one under its own discretion. This would flip that and say, we're going to give a hearing to every application unless the applicants waive the right to a hearing. So it would automatically go to a hearing and have the opportunity to hear that. They can waive that right unless there's an intervener, which is a little different than the current law. Currently, you can demand a hearing as long as I get the numbers flipped. I believe it's if you have 3 people or you represent an organization that is made up of at least 5 members, you can demand a hearing. This would, and it could be anyone. This would say that you have to have intervener status, which is a higher threshold. It's under the Uniform Administrative Procedure Act. It involves articulating how your rights are tied up in the decision making. So it would reduce the ability of someone to force a hearing just because and require that it be someone whose rights are tied up in the proceeding in order to force that hearing. But it flips the presumption and says that applications would go to a hearing. Then it makes sure that everyone produces a proposed final decision. Again, this goes under the Uniform Administrative Procedure Act. A hearing officer would preside over the hearing, collect all of the data and information presented, and issue a proposed final decision. It articulates all of the legal considerations, all of the factual basis for making a decision. It proposes that decision. It could propose conditions to impose on the process. And then all of that's made public. It would be on the website, conveyed to the panel. And then at the panel, they would have an opportunity to hear from the applicants, whether they agree or disagree with the proposed final decision, whether they agree or disagree with any of the conditions that were imposed. And then the panel would take all of that information in and issue the final decision.
Thank you. And last question for now and here at the hearing, not the last question on this, but can you talk about some of the stakeholders who you have had conversations with as you have worked on this proposal, and just share that with all of us here? That would be really helpful.
Well, the first thing I would say is this proposal is the culmination of 2.5 years of engaging with stakeholders. Obviously, I'm here in multiple capacities, legislative capacity, but I spend every day working on CON decisions. So I engage with the hospitals, the ambulatory surgery centers, the behavioral health providers, physician group practices, the radiologists. I'm sure I'm forgetting some of the people I spend every day talking to. I work with them directly. I work with their attorneys who do this across the spectrum. So I hear about what is and is not working every day. As we started gearing up toward this proposal, I met broadly across the government, so that making sure that we were bringing all of our expertise to bear with the Department of Public Health, Department of Social Services. As you know, the Department of Social Services has their own Certificate of Need program. So we compared to say, how does their process work? How does our process work? What can we learn from each other? How can we streamline those processes? Since we've released the bill, we've obviously had a number of conversations with members of the committee, with other legislators who have particular experiences with the CON program, positive and negative, to hear what has worked well, what hasn't worked well. We've met with the medical society, with the ambulatory surgery centers, with the radiologists. I'm sure I'm forgetting several. They're in my notes, I promise, and we are collecting all of that. We appreciate the feedback. I think anyone who's engaged on this issue and looks carefully and honestly, I can identify something that points to every stakeholder that we've met with over the last couple of years and how we've tried to reflect the feedback that we've gotten. I'm certain it doesn't address everyone's concern on every issue, but we've really made an effort to try to take that feedback in and make sure that the process is working for everyone.
Mr. Jackson, I would like to take this chance to say thank you, because you have been in an unenviable position in many ways. It's a difficult task that you have ahead of you. And I think we have had a lot of challenges, and you and your agency they have worked hard to try and address those. I know that this is another step in that conversation, but I appreciate the collaborative nature of the work that you've done with this committee and with those stakeholders. And I look forward to more of that as we go forward in this session. And with that, Mr. Chair, back to you.
Thank you, Representative Claridis Teacher.
Thank you, Mr. Chair. Thank you, Boyd, for being here today, both of you. I know I could probably speak for this entire committee. I hope this is the last time we're dealing, excuse me, with CON, but thank you for all the work you've done. I know it's not easy. You've always been there to answer our questions and our concerns, but a couple of my questions. The first one is, under this bill, what are the services that would be eligible for expedited CON?
So this, the bill would leave the designation of those categories up to the panel. For a number of reasons. We want to make sure that there's a broad stakeholder input on that process. So it would be done through policies and procedures. The panel would be able to designate which categories or subcategories are eligible for expedited review. So, you know, if you take a broad category, it may be that they say one element of those types of proposals would be eligible, but not others, because we've identified a particular need. And so we think that, you know, we want to expedite that as maybe it's an incentive to get people to go through the process, reduce that burden.
Thank you. And I hope this, if and when this bill passes, that the goal is, as we know, access. We want to streamline this process because we know it's been fragmented over the last few years. But another question on the panel, and one of we had talked about maybe considering not having the Office of Policy and Management there and maybe using the healthcare advocate in their place. Have you had any further discussions with anybody in regards to that?
Yeah, I mean, we're certainly always happy to talk about who the right people are for that panel to make sure that we're getting the right voices in the room. I think that OPM has a lot to offer, as I articulated. Obviously, they have a lot of experience in the healthcare sector, and they're going to be inheriting key parts of OHS that would inform that. I have talked to the healthcare advocate about what a role for that office could look like. Early conversations, I think the healthcare advocate will be here later to provide some testimony about the perspective that they could bring. Obviously, they advocate for patients every day. I would like to believe that we all have patients at the center of our analyses, but certainly having a voice in the room could be useful, and we're happy to have those conversations.
Thank you for your answers. Thank you, Mr. Chair.
Thank you. Before we ask Senator Gordon to ask his questions, I just wanted to remind people who are online, who are attendees, when it's going to be your opportunity to speak, you will get a request to become a panelist. If you do not accept that request, you will not be able to testify. So please keep that in mind. With that, Senator Gordon.
Thank you, Mr. Chairman and Mr. Jackson. I know we've had discussions, and as you know, I have a particular interest in this and detailed understanding of it. I've also been a huge public critic of the current CON process and the way, I'm not blaming you, but the way that prior leadership of the Office of Health Strategy used CON, I think completely wrongly, but that we can get into another time. But as you know, I look at the nuts and bolts. I do believe we have to take care of CON. I know I've had proposals, others had as well. I think we need to streamline the process in many regards, not 100%, when healthcare facilities, especially hospitals, want to expand certain services or certain inpatient beds, for example, and really make certain our focus is when services are being cut by hospitals. For example, in Northeast Connecticut, decisions by OHS in the past have been detrimental to healthcare up in Northeast Connecticut, especially women who are seeking labor and delivery services. And that's another matter that has to be addressed. But I have a few questions, and I look forward to having follow-up meetings with you. One I have is, as you know, there's the Rural Health Transformation Program application that the state of Connecticut submitted. Did get approved. The governor signed off on it. And I've read through, I forget how many pages this is, 70-something pages or so. And in there is, I think it's C3, it talks about wanting to make substantive changes to the CON process. That's built in. And so Connecticut is going to be tagged to want to do that. I'm just interested in your understanding and OHS's understanding of, with that application, is it that the state of Connecticut was saying to the feds, give us the money, approve our grant application, and changes in CON would be to try to streamline the process, but not necessarily try to expand it to start getting into folks who are not fully tagged now in the process, such as small group practices of physicians, things like that?
I do know that we made representations about streamlining the process. As to the specific commitments made, I'm not the best person to speak to that. So I am not sure exactly what those commitments were. I do know that we view this as a major step towards streamlining and reforming the process to make sure that we're reducing the burden on applicants.
No, I appreciate that. And the reason I'm asking is I just want to, and I can follow up, Mr. Chairman, officially outside of the hearing, that we just want to make certain whatever's being proposed here and gets worked on does not conflict with whatever, I'll say, promises were made in writing to the federal government in order to get the application for rural health transformation money approved. So I'm happy to meet with you and we can discuss that further. And I'll send a letter to ask because it's extremely important, because if it conflicts, it puts that money in jeopardy and we don't want that. So I think we do need to take a look at that in detail. And one other item I have lots of questions, but I'll just end with this one, is I'm trying to understand what is the reasoning behind letting an applicant waive a public hearing. And then the public would have to seek through an intervener status, which, as you know, is not always straightforward. And most people in the public don't even know it exists or understand how to apply for it, versus just saying, if there's going to be a public hearing, there's going to be a public hearing. Anything being proposed that has to go through CON is deemed in the public interest. Why are we making it more difficult for the public as opposed to waited more for the applicant to say, I waive the public hearing, and thus the public may not even know how to then provide input if they wish?
Yeah, well, the CON process as a whole is the public process. It requires letter of intent. This proposal would require a letter of intent, which would be posted on the website. The quarterly application cycle, we think, will help people be able to track things a little better so that you're not having to constantly refresh our website to see if a new proposal has been posted. There would be a little more regularity. All of the application materials are public. So there's an opportunity to comment publicly anytime. And I know many people on this committee have taken advantage of that. I'm sure many of people in the room have as well. I received a public comment this morning. So there's that opportunity to share information. We've historically treated hearings as an opportunity to pull out additional information that we might have had a hard time getting in written questions back and forth. It can just be more efficient to do that. I think the thought was hearings have an expense that come along with them. And so offering the applicants to waive that, it's really about their procedural rights to have the hearing, to come and present their application to the hearing officer. If they waive it, they also waive their appeal rights. So we think that, that's also a deterrent if there's a reason to have a hearing. But it's really about the cost. I know that applicants have represented that engaging an attorney to show up at a hearing and prepare and do all of that work can be a burden. And so the goal is to offer that kind of that avenue for reducing the burden of applying by saying, if you are satisfied with what you've submitted in your written application, again, the burden is on the applicant to demonstrate that they meet the criteria. So if you're confident that you've demonstrated that and you don't have a need to present publicly, then you can waive that right. Public is always able to comment in writing. We get voicemails left. So we definitely want to hear from the public. It just may not be at the hearing, which history says is not where most of the public comments have been made.
No, I appreciate that. Thank you. And I look forward to following up more on that, including about the rural health transformation, because I do think what was put into that conflicts with this proposal, and that's a serious concern. I'll just end saying that if we're trying to make the process better, we should not be expanding unnecessarily the time, resource, and financial burdens on small physician and healthcare professional practices who are struggling already in Connecticut. And this proposal trying to tag them more I think goes in an opposite direction. And I believe based upon that and the wording of the governor's application to the feds for the rural transformation funds conflicts directly. So I look forward to having further discussions and also here in this committee. Thank you, Mr. Chairman.
Thank you so much. I just wanted to make a quick little comment. So when we have this confirmation, because we, as the leadership of the committee, would be very much interested because we were also approached to see if the C1 process would be streamlined, and this federal grant is a multi-year grant, and we do not want to lose any funds for technical reasons. I wanted to leave you with a thought, and I know one of my colleagues has a question for the Deputy Commissioner. In the past, it felt that there was not a broader vision or operating principle. Everything was technical, technical, technical. And if there's a broader vision that the C1 process is to, and I've made a list of things, to improve the access, look at the disease pattern that has changed, demographic shifts, and also gaps in care for the communities, cost of healthcare, in protection from private equity or people with poor track record in the past. So if there was a broader vision that was in place, that would help us as well, because once somebody applies, you look at it from the technical part of it, but there's no broader vision that at least I have been able to see in the operational strategy. So I want to look at that, and I've asked those questions from many people, and I've asked, where do you see the health of the state? What is a 5-year plan? What is a 10-year plan? What is a disaster plan and the broader strategy? And I have had answers, reasonable answers, not satisfactory to me, but it's worthy to have that conversation, not today, but another day. With that, I wanted to ask Representative Kai Belton. She has a question for one of our panelists.
Good morning. I have a question about the opposition for the menopause toolkit. Can you tell me more about why that opposition is? Is it about capacity, outside expertise? Just tell me more.
Thank you for that question. It's exactly that. It is about capacity and outside expertise. We would have to resource that. We would have to hire it, and there were not funds included in the governor's budget for that.
Thank you.
Representative Kristen McCarthy-Vahey.
Thank you for the second time. This one is just a follow up to you, probably you, Mr. Jackson, in terms of the idea of streamlining versus not streamlining, or streamlining and expanding, which I think you can have both happening at the same time, which is, I think, what your proposal does, which is it does streamline quite a bit. And it expands. And this is a conversation we've had, I think, at this table and others multiple times. Why? What is the why behind that? Can you talk to us a little bit more about what is the reasoning behind looking at this different strategy, which what Senator Anwar and Senator Gordon are saying is accurate. We have many struggling practices, but I know that there two things can be true at the same time. We also have some other situations happening, and I believe that's the why behind this, but if you could expand on that, that would be great.
Yeah, thank you for the opportunity. Certainly, I don't have to tell the doctors on the dais that the practice of medicine has changed over time, and the atmosphere and environment in which the physicians are practicing has changed over time. And we've heard a lot about the difficulties that small independent group practices have had to stay afloat, and we get that. And I think that the proposal is really to have some oversight over what's happening when those small independent group practices are being acquired, taken over by these larger entities of various types. So we've talked in the past about insurance companies that are buying up group practices, and what does that do to patients' care? We've seen commercial retail pharmacies buying up group practices. Certainly the hospitals have acquired a lot of group practices. So that's private equity has gotten involved in a lot of group practices. What we've heard in the past is private equity can be a lifeline for group practices to stay afloat and stay independent of all of those other large entities that I just described. And what we've tried to do in the proposal this year is acknowledge that there are business realities to the practice of medicine that may be completely appropriate. So we've talked over the last couple of years about management services organizations, MSOs, and management services agreements, MSAs. There may be a role for these entities to provide some back office support. What we've proposed this year is an exemption from this enhanced requirement. If you are contracting for these management business services and paying a fair market value under a contract, so that would be like saying, hey, we need support with our, back office business work, and we're going to pay you X dollars a month for conducting those business dealings. The same way that someone might hire an attorney and pay a rate for the legal services that they're providing to the physician office. We think that's fine. Where the concern arises is when significant portions of a group practice are sold off to these other entities, including management services organizations. Then we worry about there being a little more control in what's going on as a group practice with the practice of medicine. And we think that should just be reviewed. We don't propose to ban any of these arrangements, but we do think that it's the responsibility of the group practice to come in and just explain why this is needed, what they're doing, so that the state can look and say, yes, that seems completely reasonable. We support you. Go and take care of your patients. Or it looks like this financial institution is taking over the practice, directing care, maybe limiting how much time an individual physician can spend with patients. And we need to impose some conditions to make sure that proper practice is maintained. Or, setting staffing levels, setting what type of care is going to be delivered. Those are the kinds of things that we've seen examples in the past and that we would want to protect against.
So, and thank you for your indulgence, Mr. Chair. Just to follow up to that, if I'm not a physician, as you all know, if I'm a physician and I'm selling my practice and I have an entity that is telling me you are only allowed to do this or that, my logical thought is I'm not going to agree to that or to those terms and conditions. That doesn't seem right or practicable as the practitioner, as the provider of care. So are you seeing this? Have you seen examples of where this has happened and this has occurred? We often have that question here. Is this actually a problem that you've seen? Or is this just something that we're anticipating might occur?
At present, the CON program doesn't review these transactions because there's a major exemption for if you're selling a practice to another physician or group of physicians. We know that these deals have been designed so that is what is happening. And so what we see is an entity that will sell off all of its non-clinical assets to one organization and all of its clinical practice to a physician associated with the entity that bought all of the non-clinical assets, so that money is flowing in a certain direction. We've seen it in individual transactions. We've had it explained in very large commercial entities that say, we have seen press releases that say large commercial entity bought this group practice, acquired this group practice. And so the agency follows up to say, that sounds like the type of thing that requires a CON. Can you please explain why you did not get a CON? And then they say, what we said for the public was not exactly how it worked on paper. We spun off the non-clinical assets to this entity. We spun off the clinical practice to this physician who works for us and owns a large number of group practices as the physician theoretically in charge. And so you don't need to worry about reviewing it. So we don't review most group practice transfers because of that exemption. But I have read significantly in this area. I have met with researchers, with people in practice. I've been an attorney on all kinds of transactions and seen how these things work. Often you have a group practice that is selling, and physicians may have a set time that they're going to continue with the practice. Other times they're leaving the practice and they will be absorbed and replaced with other types of clinicians or practitioners. So I think often you hear a very different view of this from new physicians entering the workplace who are seeing these group practices being bought up and are seeing the type of influence that that we're describing. It's folks who may be leaving the practice and are leaving their practice to this other entity, and then it's the new people who are experiencing the new types of control.
Thank you. I just want to acknowledge it's really complex because our providers are just facing increasing pressure. And when it comes to thinking about, passing on a practice, a succession, retirement, with the difficulties of, saving for retirement, even, I am very sympathetic to that. And I think it's something that we on this committee, will we get there on that this year? I don't know. I will, I appreciate the comments from the good ranking member that she hopes that this is the last time that we will be talking about this. I may not be quite as hopeful, but I do think that this is a worthy conversation. I just, I'm being very candid here that I don't know where we land on that this year, but I'm very encouraged by many parts of this conversation today. And again, want to say thank you, and thank you, Mr. Chair.
Thank you. I just wanted to make a quick comment on this. We had a public hearing on a private equity bill, and we have another one today. And we had a number of experts who came in, and we asked this question. If you have limited resources and then you want to try to make the biggest difference, what is the area of opportunity to work? We want to try to stop everything from happening. That's the easy part. But do we have the resources? Because our track record suggests that we may not have the resources. And in the current budget environment also suggests that. And the answer to that was that, well, the bigger transaction with hospitals is where the ROI is going to be the best to protect the people. And then that's what but if we were to go after one or two clinician practices, maybe you'll find something, but the number of personnel to look at that and the return would not be worthy. So again, that's something that some of the experts said, and you probably are privy to some of the previous conversation, and we may have more today as well. I have a question for the commissioner, deputy commissioner. Deputy Commissioner, in your testimony on the question that Representative Belton had asked, that an act concerning provider toolkit for the diagnosis and treatment of menopause and perimenopause and postmenopause. When your testimony, is it the official position of the Department of Public Health whenever there's a bill where DPH is involved, and if it is not in the governor's budget, you would say no right off the bat?
I think that would really depend on whether or not we had existing resources that we could leverage or existing expertise. And in this case, we really don't.
So perhaps because, and this is more of a suggestion for future, because if somebody is looking at our state, and even the people within the state are looking at it, and to every policy suggestion that comes is that we don't have the money, so we are against it. but there's an intellectual, there's a public health component to it. So there needs to be an intellectual public health conversation that, yes, this is an issue. There is a big problem. We acknowledge this problem and we feel it's worthy to have a conversation on this further. We do not have it in the governor's budget. We will try to see we can have further conversation and look at it rather than say no money, goodbye. I mean, I'm just exaggerating, but you know what I'm saying.
Totally appreciate that. And
Yeah.
we are certainly happy to have additional discussions.
Yeah.
And at this point where we are right now, we did not see places in the department where we could leverage existing resources or expertise to do this well. As you all know, we're losing a significant number of federal funds and we're managing that. And so I think until we get through this part of the year, it's kind of a conversation that's difficult to have in terms of resource allocation, but we're certainly open to having additional conversations about the policy ideas behind this and how we might be able to leverage other funding sources to do this kind of work.
Thank you for that. And we are fortunate. We know people personally, and we know it is far from the truth. But for somebody else who does not know, they would say that DPH is not interested to do any public health policy issues, and that's far from the truth because we know that you are all consumed by doing it, but you're also overburdened with dealing with so many other things that are on the table. So I appreciate you being here. Seeing no other questions, we have Senator Gordon has a second round. Go for it, Senator Gordon.
Thank you, Mr. Chairman. I'll be brief. I'm just trying to understand where I'm not blaming you personally, Mr. Jackson. I think you and I must be seeing different things in the state of Connecticut relative to the private practice groups. Yes, there's been maybe one that was a blatant in one large group trying to perhaps do an end run around CON. There's processes to tag that. I'm extremely concerned, and I agree with my colleague and fellow doctor, Senator Anwar, that, there was statements made last year that, well, we got to throw a broad net and see what we find relative to out there in the group practices, including small. And that's I think, a bad mentality. I think we know where the problems have been and failures of state government to act in a timely manner. And that should be the focus. If it's one thing where you have an insurance company or a large hospital buying up a group, a private group, well, sure, one can look at that to see what there might be, and there may well be concerns. But I think if one has a mentality to say for all these private groups, even maybe small ones of like 3 people, 3 healthcare professionals, to say, come on into OHS or DPH, wherever OHS ends up, and explain to us why you don't need a CON. That's a wrong way of doing it. I don't see at all, and I know nearly all of the group practices in the state of Connecticut, where they would even fall under a CON. So if you have a group practice of 3 doctors who wants to merge with another group of 3 doctors because they find that's a way to survive in a difficult financial environment of Connecticut, then we should say thank you and help them. I don't think we should drag them in and explain why they don't need a CON. I think if one's looking at what to do, especially with limited resources, which we're just hearing now on a different matter, then we really should focus on where we know the problem is. And I'm happy to have further discussions with you. I agree there can be concerns with large hospitals perhaps putting conditions. I mean, there was one large hospital system in this state that's trying to make doctors and others see patients in 15 minutes, including complicated cases. I don't know how you can even do that in 30 minutes, let alone 15. I think those are reasonable things that we should be looking at. I think we should understand the reality of the small group practices and try not to burden them more. So I just want to say we should endeavor to do that and pull back on some of this broad reach. And I think it would be more effective that way. And then one can take things from there. Thank you, Mr. Chairman.
Thank you. I take that more as a comment. So, right?
Yes.
Perfect.
Any of my questions were rhetorical then?
No, this is good. Perfect. With that, I don't see any more questions or comments. Thank you so much for your testimony and your work. We look forward to working with you closely. The next person on our list is on number 3, Kathleen Holt, State Office of the Healthcare Advocate. Thank you for your patience. Welcome. And that'll be followed by Representative Lori Sweet. Thank you.
Good afternoon. Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claritas Ditria, and members of the Public Health Committee. I'm Kathleen Holt, State Healthcare Advocate. The Office of the Healthcare Advocate is an independent state agency with a consumer-focused mission to help consumers locate, understand, and obtain appropriate healthcare coverage from all types of healthcare plans, and to speak on behalf of consumers in policy discussions. I submitted written testimony on proposed bill, House Bill 5045, which we've just had a very robust discussion about, an act streamlining healthcare facility approvals. But I want to speak to the OHA, the Office of the Healthcare Advocate perspective on the proposed Certificate of Need unit and panel, our ideas, our thoughts on strengthening it, and to points raised in other testimony about proposed revisions to the CON process. To Senator Anwar's point about a broader vision, I could not have listed a better opportunity of all of the things that were said about the concerns, about the demographics, the changes in procedures, what we're seeing in the changes of healthcare in Connecticut and in the country, and in healthcare generally. Consumers, providers, and payers were all frustrated by a dysfunctional, unmoored healthcare system. And we have to try to get our hands around the entire picture to keep it all afloat as best as we can. So I'll focus as an example on the reality of healthcare payment. That's something that the healthcare advocacy operation, our office deals with on a regular basis. Every day, dozens of consumers that contact us that need to have something fixed with their healthcare and their payment. That is our main focus of our organization. 95% of Connecticut residents have some type of healthcare insurance. Some people have state-regulated plans, fully insured, the Affordable Care Act plans. Some have Medicaid. But the majority of state residents have the federally funded Medicare plans or the ERISA plans through individual employers that provide their insurance for them. They are not substantially influencing Connecticut policy. When I say that, I mean the majority of our plans. We have an Office of Healthcare Advocate is highly involved in those types of plans every day, as we know are all the providers. Where do you draw the line? How do you know? What we hear from providers at our office almost as frequently as we hear from patients, because providers are up in arms. They don't know how to deal with all of the insurance companies that they have to face. And they want our help because they know that access is harmed for their patients. So they're turning to us to try to get them help. And we've had a lot of difficulty in managing the volume of concerns that we have. In order for the CON process, the approval process, to operate as successfully as possible, the entirety of the payer systems have to be considered. We don't have to influence them as a state to understand and incorporate them into the calculus. Medicare should be considered and incorporated into the calculus. I submitted substantial comments to a proposed rule to CMS on changes to the private Medicare Advantage system that will take effect next year. We'll get the final rule next month or May, but the reality is the changes are horrible. The changes will significantly impact people in Connecticut, the 20% of people in Connecticut who are on Medicare, even in the public Medicare arena. We have to make sure that we're considering the impact that is happening. A growing number of high deductible plans may be increasing hospital length of stay. Why is that? People are not going to the hospital when they need care. They are waiting, and by waiting, their care is more intense. And so their length of stay in the hospital is longer. And why are these actions happening? Because we are not looking necessarily at the payers that are influencing these actions. It's critical, and the CON unit needs to have deep expertise and understanding of all payers, providers, and consumer needs and behavior.
Excuse me, Ms. Holt, but you've reached your 3 minutes. Thank you.
Thank you. I have a question, and then maybe you can add a few more sentences that you have. If your office, thank you so much for your testimony, and thank you for the work that you do. When we are struggling with the situation, we reach out to your office for helping out. If your office was to receive 100 calls, what percentage of those calls are about the insurance company making it difficult for the patients to get their care?
Close to 100%.
Yes, I think this is something that the public needs to hear, that it has been written and published as well, that one of the threats to the well-being of the citizens of a community and a state is the heavy-handedness of the insurance industry of restricting care that medical personnel have written and identified as with trained individuals to give them the care. And then that's one of the biggest issue that we are dealing with. That tells you that the Office of Health Advocate is not being impacted by patients not getting the physician or a specialist to see them as much as it is for them to be able to get the medicines or get their tests, and where the insurance have closed all doors. This is very helpful. Do you want to add anything else?
Yeah, I just wanted to mention, from the standpoint of what the example I was giving about the payment, the proposed panel of the commissioner of the Department of Public Health, the commissioner of DSS and OPM, all amazing, wonderful positions and opportunities. But again, it goes to the point that we have to consider that Connecticut isn't a bubble, that we live in a federal system, that there are a lot of other considerations that should be happening, that there should be a broader vision for that.
What do you think would be beneficial? Do you think somebody from your office or others should be there?
I think it would be helpful, but again, I'm not deep into the understanding of whether or not the CON unit has that expertise. If that expertise is there, and there are people who are commenting on Medicare rules and are very familiar with how those processes work, then maybe that's already built into the system. I'm just suggesting that there should be that broader vision of how these decisions impact one another and impact the residents of Connecticut.
In our previous conversation on CON, we always had a critical issue with them, was that there's no clinician or person with a medical perspective in the room. They don't understand at times. So everybody's a lawyer looking at the legal part, checking the boxes, and then it's taking away from the medical perspective in many aspects. So your testimony is very helpful. And I know my co-chair has a question, and followed by Representative Clarice Jeter, Representative Kristen McCarthy-Vahey.
Thank you very much, Mr. Chair, and thank you so much for being here and for being our advocate here in the state. And you heard me say earlier, I love my 4th grade example, but just to very explicitly help us understand where and how that benefit of that perspective could practically impact a CON conversation and deliberation. And I think it's important for us to understand as concretely as we can, because I agree, as a social worker, it's that systems perspective. And certainly there is no bubble. If you pull on one thing here, it impacts over there. And, what Senator Anwar is saying, yes, having the broader perspective on multiple fronts is important. But how do you think having you or someone from your office participate in those deliberations would have an impact practically in that process?
Well, I think we come to the reality, hearing the stories of consumers every day and looking for the patterns that arise from those, that we can offer that perspective into the process so that we look at geographic differences for healthcare delivery and the opportunities that come up, how you make a decision in one for one facility or one provider, how that impacts every other provider, and then how that is overlaid by the residents and the impact that it has on the citizens of Connecticut.
Thank you. I appreciate that. And you mentioned that you weren't sure if that type of expertise currently exists within the CON unit. And I won't ask, but just rather invite. I'm hoping that you and Mr. Jackson can have a conversation more specifically about that, because I anticipate, based on the questions you've already heard here today and some of the comments, that we'll be having further conversation about this. So if you all can have that direct conversation before we all do together, that would be wonderful. Thank you, Mr. Chair.
100% Clarity's teacher.
Thank you, Mr. Chair. Thank you for being here today. And I know we touched upon the panel and possibly having your office in there instead of OPM. And what are specifically, again, to my good chairs, fourth grade level, why your office versus OPM?
Again, it depends on the overall overview of the entire operation, but my perspective comes from being on the ground with consumers on a daily basis and understanding all of the various different opportunities that come both from within the state and outside the state in terms of how they are insured, how the payers operate, the behavior of the providers and the payers and the consumers together. It's all interwoven in a way that I think that the state doesn't necessarily see how the Medicare process, how the ERISA process influences that, and I think we could bring that part to the table.
Thank you for your explanation. And I do think you would be, your agency would be a wealth of knowledge compared to OPM. And hopefully we can have further conversations about that to move this forward. And my other concerns about the authority that the panel has are separate from who I think should be on it. So thank you, Mr. Chair.
Thank you. Senator Gordon.
Thank you, Mr. Chairman. I appreciate the work you do. And thank you very much for it. I read through your testimony and certainly been listening today. I think your point is very well taken, that if we can have people at the table, literally, when these decisions are being made about CON, I think we would have a much better outcome. I think when you look at people out in the community, patients, others who are on the receiving end of medical care and healthcare. And then there are decisions by those who have probably nothing, they don't even really understand that, making some of these decisions. This is when we've seen bad decisions by prior leadership of OHS, completely contrary to the actual medical needs of people where they live in their communities. For example, in Northeast Connecticut, where there's been two blatantly bad decisions that were made about allowing inpatient labor and delivery to be removed. And now there's really only one. And some women have to hop the border now into Massachusetts, and that's a sad reality. So I think it's very important. One question I have for you, and I'm happy to take this offline to have a further discussion with you, is are you looking for your office to have a seat at the table, or are you looking to have others when you talk about consumers or people out in the community, or you're looking for both as far as expanding beyond what is proposed to be a very small panel of folks who probably don't understand actual medical care, patient care, community health needs?
Thank you for that question. I would say if there is an opportunity for consumer voice on the panel, if it's found to be advantageous that it would be a good idea for it to be the Office of the Healthcare Advocate. We have the ability to bring in the knowledge of our work with insurance companies, with providers, with consumers. And again, we see the patterns through thousands and thousands of cases every year that we resolve for people. I will say our level of success of being able to win 70 to 80% of the appeals that we take is a testament to my staff, but it's also a concern that many overturned decisions are being made. And we only see the tip of the iceberg in my office, but I do think that as far as the consumer experience, that we are uniquely positioned within the state to be able to offer that perspective.
Thank you. I appreciate that. And that's very well said and should be very much taken into account. And just in closing, I can tell you in my other world as a doctor, I have appreciated the help you guys have provided. You're right. You only see the tip of the iceberg. For example, I'm not working in the hospital today, but I'm already getting texts from my office about appeals I have to make when I show up bright and early in my office tomorrow. It's multiple times a day, massive interference with actual patient care. So having your office have a seat at the table when these decisions are being made by state government is invaluable. And I would say absolutely should be every single time to give you guys an opportunity to weigh in. Because right now that perspective, no matter what we may hear, is absent other than whatever testimony, quote unquote, from the outside your office is providing. So thank you, Mr. Chairman.
Thank you. Seeing no other questions or comments, we want to thank you for the work you do and your testimony today.
Thank you very much.
That brings us to next person on our list, which is Representative Lori Sweet. And then we actually, because it's close to an hour, we'll be switching back and forth after you're able to speak. And Representative Roberts, welcome.
Good afternoon, members of the Public Health Committee. My name is Lori Sweet, and I sit here today with Representative Robert. We are the co-chairs of the End Homelessness Caucus. First, I want to thank the governor, in coordination with the Department of Emergency Services and Public Protections, for enacting the cold weather protocol many times over the last several months. Making those calls saved lives. We're here today to speak in support of Senate Bill 364. We need consistent protocol for severe weather, both hot and cold, since both can be deadly. These decisions need to be made as soon as possible so that our towns and shelters can prepare, and we need a clear communication structure. I'll give you an example. During the most recent storm, the End Homeless Caucus members were in touch with the governor's office, and he initiated a protocol late in the day. It began the next day at noon. Columbus House, who the town of Hamden contracts with for our warming center, had already made the decision to open at 4 so folks could come inside and avoid the snow. Given the short notice, Columbus House wasn't prepared to open at noon. Through communication with folks who were waiting outside our warming center and under the leadership of the director of Columbus House, who himself came to open our warming center at 1:30, we got folks inside. I'm not telling you this story to assign blame, just the opposite. I want to point out how the director went above and beyond to get people inside. But directors and staff need time to plan. We need a system that plans ahead and gives as much notice as humanly possible to service providers. When we hear about bad weather like we did yesterday at 10 a.m., we need an immediate response so that people do not freeze to death and die. I close with gratitude for the committee for taking this on, as I believe it is a public health issue. Thank you.
I'll allow Lori just to speak. She did a wonderful job. I'm just grateful for the actual committee bringing this forth to us. I can tell you guys, we have some data and people will testify again today. As you guys know, it's getting cold outside one day, snow outside the next day. We're in close contact with the governor's office on a regular basis to see if we're going to enact like the cold protocol, and it should never be that. We should have it set. If it's going to be till Good Friday or Easter, we always have to contact the governor's office each week by week to see if we're going to open up these hotels or we're going to open up the Ubers for our people to get out there. So we're honestly doing a wonderful service because that's what we signed up for. But in a sense, it's, hurting our homelessness population, and we're not really doing a service to us. So you guys in this committee, thank you guys for bringing this bill forward, because this hits it on the button. This is one of our caucus priorities as well, as the End Homelessness Caucus. And we're just grateful for you guys and anything that you guys need from us. We testified in transportation for a clean sweep bill, and we're just going to be here all the time advocating for our communities. So you probably will get sick and tired of seeing our faces, but other than that, we're just grateful for you guys.
Thank you so much for your testimony, and thank you for your advocacy and the work that both of you do. It's truly inspiring. I wanted to just ask you, it is my understanding that the school systems listen to the news about the weather, that this building listens to the news about the weather. Most of the other industries and places, they look about what's the weather going to be, and more or less it's fairly accurate. We make fun of the weathermen occasionally and then say, well, you were wrong. But majority of the time, there is accuracy to that. And I'm trying to understand, why is this not automated? Is there something in the system which says that we are not going to listen to the weather and we are going to figure it out in the middle of the night that maybe it's an extreme weather protocol and let few people die and then we'll make a decision? What is your understanding? Why is this not working for us?
I think you hit it on the button, and I'm always a blunt guy. So I realize, we'll take Bridgeport, for instance. They had a dead body. We'll take Stanford for a dead instance. They had a dead body. Then we'll start to really wake up and see, 45% increase in homelessness. Okay, I don't care if it's 10,000, 8,000, 9,000 people. We live in a wealthy state. This is ridiculous. So I'm on the record, it might take somebody to die for people to really wake up. And it's sad. It's very sad. So you said it, you hit it on the head. We don't have a protocol. Hence why last night we had to text numerous offices to say, are you guys enacting this protocol? We can't keep going week by week. People are dying day by day. And it's really ridiculous. So that's why we're here all the time advocating for this. Rep Sweet, we had a press conference with the End Homelessness Caucus and the CT-CAN, and Rep Sweet held up a list of all the people that died this year alone from homelessness. We have to fix this. It's heartbreaking, because if you know my background, I come from this. I come from low income housing where we had to find a place to live, to the point where we were homeless. And to see where I'm at today, I don't want nobody to go through what I'm going through. I live in Fairfield County. It's one of the wealthiest counties in the world. Why do I have people sleeping in their cars? I don't know. That's why I get upset.
Senator, to answer your question, the same way that we do have protocols for kids, right? Like my kid's afternoon was canceled because of the weather, right? In the building yesterday, we weren't sure, some staff were going home. We need something codified in state statute so that it is very clear that across the board, if this, then that. So that's what we're asking the committee to do. And we want to work with you to develop that protocol with the relevant agencies that actually, pull the trigger when it's really nasty outside.
And I was reading, there's a little bit of a pattern that I'm seeing. So I read the testimonies, I read the work that you're doing, and I read about a number of people who are advocates. So just like we had a conversation that the information about menopause, that bill, everybody's in support except the state agency. In this one as well, everybody's in support except the state agency. So it's like, what's happening is that the answer is that we don't have the resources. And so the people are saying, and you're saying people are dying, and the state says we don't have it in the budget. So we should be looking at the merit of the issue rather than the money of the issue. And right now we have had some 14 deaths of people frozen in our state, and that's what when this committee brought this bill forward, the rationale was that the current system is not working. We have a situation where people are freezing to death, and we have no organized system in place. And it's a failure when a legislator has to call every few days that, hey, it's too cold. It's too cold and you have to advocate. Now, let's say you are on a vacation. What would happen at that time? Right? Or if, God forbid, anybody's unwell. So we cannot have a system run because of the advocacy or 2 or 3 committed legislators, and thank you for your commitment. But this is not sustainable, healthy system for the state's protocols to be driven by the kindness of individuals to beg that, hey, people are freezing, help us out. So I hear you, and I can't thank you enough. And I hope the people in this building and beyond are listening to this conversation, because we are better than this. We are better than this as a state for waiting for the legislators to pick up the phone and say, hey, people are freezing. Can you have the protocol? Well, it's going to cost too much. Yeah, then fix it. Sorry, you can answer my statement.
Yeah, I would just add for the record that the person advocating that we do the partial cold weather last night was at a conference on ending homelessness on the West Coast and was still caring and making sure that people didn't die last night, and was texting us after a long day. You know, this work never ends. I'm not complaining. I was a birth doula before this. I'm used to getting calls at all hours of the night. But just to put a fine point on the fact that she was in California getting calls, providers weren't sure what to do. It took us a couple hours to coordinate that. We can do better. We can.
Thank you. Representative Belton.
Thank you both for being here. Actually, my question was going to be, about what protocols actually exist. And it sounds like there aren't any. So I guess my question now is, when you talk to state agencies or the governor about the specifics of the protocol, what kind of feedback are you getting?
Definitely. I mean, it's funding, of course. And also, I honestly get, we're extending it another week. We're extending it till a specific day. But that's not really enough. And I kind of like simply respond like, okay, Good Friday, Easter. I'm trying to give you months and weeks out in advance, just because I don't know. We just snowed and hailed and did all that stuff yesterday. It's March. We don't know what April can be, but I'll be honest with you, funding wise is always a conversation. And that is something that bothers me when you're talking about someone's life.
Thank you.
Rapara.
Thank you so much, Mr. Chair. Thank you for coming before us. I'm sorry I missed your testimony in transportation the other day, but sounds like you guys are making your rounds and I really appreciate it. So I'm on board with you here. There's a lack of organization, complete lack of organization. I ran into a lady. It was the first night. It was the night before 2 people in Stamford died, and I ran into her in Darien. And I approached her. She wasn't able to speak to me really. You could tell there was some mental health maybe issues that were going on. And I said, do you have a place to go? She walked away. And so then I'm scrambling to figure out who's going to come pick her up. She's walking down Post Road in Darien. I finally get the 211 number, which you're not going to get an answer on. You're not going to get an answer on. I called the police. Now, this was where there was a little glitch in the way. We've just talked to the police department now, so they're on the up and up. But the lack of organization of everybody looking left and looking right. And then I had my aide call the next day, 211. She was 116 on the list. This is just not good enough. I talked to my family in Kentucky and they're like, oh, the Catholic Church organizes everything, and here they go and they pick them up and they take them. And we're in the Northeast. What are we doing here? So I'm on board. I'm not sure if government is the answer, but I think maybe the nonprofits need to get together and figure something out. And I'm happy to support this, but I'm happy to work with you because I see a real problem here. Thank you.
Thank you, Representative Kristen McCarthy-Vahey.
Thank you, Representative Sweet and Representative Roberts, for your work and advocacy. I just want to clarify a few things. What are the current protocols? How does it work currently? Who is responsible for that? And what is the specific breakdown in the communication and process that you are seeking to change?
I believe there is a document that our emergency services put together. So again, I would defer to Sarah Fox on this. I think she's testifying a little bit later. It has to be a certain number of consecutive nights below freezing. So we know if it's 40 degrees for an hour, that kind of kicks, we're not in cold weather anymore. If we're having a big storm, we might be able to have cold weather and then we might be able to extend it. So there is a protocol. I think what might be helpful is feels like temperature outside, because remember, these are folks who are sleeping outside. So if we're running to our car and it's, 40 and hailing, it's just a moment of discomfort. But for someone in a tent or someone sleeping outside, it could feel like zero, right? So there are protocols that exist. We have been working with the Department of Emergency Services. We really just want to come together and make it really, really clear. And then the communication piece. So we were on text message last night, a letter went out, 211 didn't find out until 9. The cans were trying to coordinate where they had beds. I was in communication with Hamden. We were almost full, but there were some beds somewhere else. We know that cold weather keeps happening. We know that severe weather, hot weather, it's going to keep happening, right? This isn't a surprise. We act like it's a surprise every time. So how can we kind of come together? Maybe we need a roundtable. I don't know. I'm all in on this fight and figure out what people need and then the communication structure so that the governor's office was like, it'd be very difficult to call 169 towns at 9:00. I agree. So how do we figure this out? We've got lots of smart folks in this room, lots of smart folks who are really, really committed. Is there an emergency text? I'm not sure what that looks like, but I will partner with you to figure it out.
Thank you for that. And I appreciate you referencing that DESPE is really the lead and primary organization, that the conversation that we're having is public health focused, because this is obviously a public health issue. And I also appreciate you referencing it's not just cold weather. Hot weather actually can kill more people and be just as, if not more, dangerous to people. So I think you have a lot of people here who are very committed to this issue, and there is the issue of justice, morality, and there is practicality too. So I think I'm interested in us trying to bring together the parties who are involved in this conversation and seeing where those specific points are, because certainly we've seen and we know that there can be communication in things like Superstorm Sandy. I remember when I was in local government. But I think it's right now a convoluted and complicated process. And I hear what you're saying, which is we want to make it clear and very understandable for everyone along the spectrum in the end so that people can be sheltered. Thank you.
Don't go away yet. We have Representative Clarity's teacher.
Thank you, Mr. Chair. Thank you, both of you, for being here today. Do you have any idea what other states have done? I don't know if I missed that as part of your testimony or not.
That's definitely a question for the cans today. For me, no. Like I said, when we started this caucus, we started last year, and we had our top priorities, and our priorities. One of our big priorities, we have a line budget item in the actual budget. Never has been done before. $5 million for cooling centers. So that was a big thing for us just to tackle that. And clearly, we know where the funding is going now. But as far as other states, no, not too familiar. But the cans definitely can let you know. They'll be testifying today.
Yeah, thank you. I think it's worth looking to see, as we always do, what other states are doing. And this is an important issue, and we know things are getting extreme. We're getting more extreme heat, more extreme cold. So we need to address these issues, and hopefully we can come up with a solution. And hopefully not too much government involvement, but only what we need to get this accomplished as soon as possible. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, we appreciate you guys being here, and thank you for your patience. Thank you. And the next person is remote. That is number 6, Sandra Ferreira Molina, who is the Policy and Advocacy Director for Connecticut Oral Health. Welcome. Go ahead.
We can't hear.
Can you hear us? Sandra, can you hear us? Can our colleagues on Zoom hear us? Blink twice.
I could hear you.
Okay, good. You're on. Welcome.
Thank
It's
you.
your time to testify. Go ahead.
Okay, so my name is, I want to thank everybody for listening to my testimony. I'm just trying to read it so I don't get emotional. Dear Senator Anwar, Representatives McCarthy, Vahey, and members of the Public Health Committee. My name is Lori Gaglione and I live in Newington, Connecticut. I am here to support HB 5399. I'm testifying not as a policy expert, but as someone who has lived this experience. I'm the legal guardian, sister connected to someone with an intellectual and developmental disability. My brother is 64 years old with severe autism and normal pressure hydrocephalus. He has been a resident of the Harvard Center for over 50 years. My whole life has been dedicated to his care, and for the past 33 years, I have been his legal guardian and attend all his doctor's and dentist appointments. Since he is nonverbal, I speak for him. For decades, we were fortunate and spoiled to have Dr. Ronald Albert providing all of Joey's dental care. Dr. Albert is a treasure. He knew how to work with Joey, and all his staff did. Due to changes in his practice, he was no longer able to treat Joey. And that is when I realized how horrible it was to find a dentist to take his insurance and to be able to provide and understand this population. Somehow we found our way to the Yukon Dental Clinic. I would be lying to say that this was a smooth transition. The front desk has never been very friendly or helpful. During one of the visits, we were going to be turned away because the document from probate court stating that I was his guardian had expired a month prior. If I didn't have a contact with the probate court and was able to change the date and fax it over, we would have been sent away and would have had to wait several months to get another appointment. I sat and I watched several patients get turned away because the document had expired. This was heartbreaking because some of the patients were not verbal like my brother, and some spoke but that were clearly in pain. There was zero compassionate shown. When I called probate court to get the revised document for the appointment, they faxed it over and all they did was really just change the date. This was absolutely disgusting. It takes so much time and effort to get a patient to the clinic. My brother is in a wheelchair, so it is a process to bathe him, dress him, feed him, and get him into a van, and then not to mention search for parking. Nothing is easy when it is getting someone to the appointment. The most recent provider we had at Yukon Dental was horrible. She was afraid of Joey and didn't communicate well with me. I always helped her with Joey. I sat on the floor and literally had my fingers in his mouth to help her with the exam and to help her with any kind of cleaning. On one visit, Joey had a loose tooth, and she said it was an abscess infected and the tooth needed to be pulled out. She said the tooth could be pulled out at the dental clinic, but the morning of the appointment, we received a call and said that the procedure couldn't be done there, and it needed to be called I need to call the oral surgery department. It was obvious he was afraid of my brother. There was no reason to be afraid. She didn't prescribe an antibiotic, which I specifically asked for. Since my brother was
Excuse
having...
me, Ms. Ferreira Molina, but your time has expired. Thank you.
Okay.
I think you signed on with somebody else's name. What's your name?
I didn't. I signed on. Well, I did. My name is Lori Gaglione. I signed on with Sandra Ferreira, but she was having complications. She's a proponent of this HB, this document for oral health. And I was
Sure.
going to just share my testimony and
Okay.
just to
I
everybody.
think, yeah, we appreciate your testimony. We want to thank you for that, and we heard you loud and clear. Thank you. So I
Thank
don't
you.
see any questions or comments. We want to thank you for your testimony. Thank you. And we'll go to the next person who is over here in person, Wayne. I'm going to pronounce it inaccurately. You can correct me. Pesci. Pesky. No, no, I'll let you do this. Welcome.
Good morning, everybody.
Good morning. Good afternoon.
Senator Anwar, yeah, good afternoon. Been here since this morning. And other distinguished members of the committee, I thank you for your time here today. Submitted testimony on Senate Bill 382, which is edible food recovery. I represent the state's food retailers, food manufacturers, food industry, for lack of a better term. I try not to use that term. I like to call us more of a food community. And we've been working very closely with the legislature for the last 6 years on this specific topic, food recovery, food donation, food insecurity. It's a plank of the work that we do in our association to really just kind of blow life into the work that all of that are our members that are doing in the communities that they serve. We started this journey about 6 years ago with former Representative Boer and Senator Marilyn Moore. I served on the initial task force that they had created. And we, at that time, created a position in DOAG to put a person in place to really help connect the dots in terms of where are some of the gaps. What we were seeing, at least back then, was a lot of the hyper-local food recovery groups. There were no two that were alike. They all needed different types of support. Some needed refrigeration, some needed vehicles, some needed more volunteers. So we created that position. That person has been in place for over a year now. We just finished a task force report with Women's and Children's, the Women's and Children's Committee, and that report is literally hot off the presses. I think it came out several weeks ago, and there are recommendations on closing some of these gaps in food insecurity in the state as well. I would also make a comment that there is a statute on the book that passed 2 years ago, Statute 22A 226E, which requires food retailers to report their food recovery, their food donations. So that does exist today. And I would recommend to this group, if we really want to be helping the food insecure, we need to figure out what's going on with SNAP and ways to support that particular program. I'd say that's the biggest gap right now that we're seeing. The donation process that's in place in food retailers is very organic and very robust. I don't see more coming out of that. How do we get more people signed up for SNAP? We're working with a company called Front Door Benefits right now, because we figure about 50% of eligible residents for SNAP are not signed up today. And how do we find those folks and help them get signed up? And then the other recommendation I would make is that we need to continue to help local, hyper-local food recovery places that need the support, that need the truck, that need the refrigeration. Help get them settled, help get them in place, and make sure that they're working well.
Excuse me, Mr. Pesci, but your time has reached your 3 minutes. Thank you.
Yeah, I got it. Thank you. So just in closing, I saw this bill, into it up to here, and we're committed to the communities that we serve. And I just wanted to come in front of this committee and talk a little bit about some of the work that we're doing to support our citizens that are the most needy here in our state, and be more than welcome to answer any questions you may have on some of our efforts.
Thank you so much for your testimony, and more importantly, thank you for all your members for the work that they do. Actually, in my interaction with various food banks, that is one of the biggest resource that is there, that is actually helping communities out across the state. And so you guys are. This bill is not to suggest that the good work is not happening, but the bill is also to suggest that we can probably see if there's an areas of opportunity. And I think what was recognized was that still at times, some of the stores does not represent all the members or any one of your members perhaps, but some of the food is going to anaerobic digesters. They're going to waste and landfills. And there's probably areas of opportunity around there. So that was one of the purpose, to see if we can do collectively better and also reduce the burden on the side of the various stores, because the groups can actually take that ownership and responsibility of how they would be able to pick up and then have centralized location for further distribution. So there may be areas to look at how we can do better collectively. On the SNAP side, you're absolutely right. There's an opportunity, but there's also a little challenge because of the federal laws that are just were passed. We're going to lose 38,600 people to get SNAP. So that's another reason why there's a panic on our side, because we know that already, even before that law, a lot of people were not getting full nutrition. And we felt that with the 38,000 plus people who are going to be impacted, we needed to see what are the various things we can do. But collectively, it's also our responsibility that the food does not go to waste when it's edible and then useful. So that was the broader perspective on this. I do have one of my colleagues who has a question, Representative Cleardis Teacher.
Thank you, Mr. Chair. Thank you for being here, Wayne. I mean, some of the supermarkets in Connecticut are already donating a good amount of their day-old food.
All of them.
All of them. And are all of them donating and doing the anaerobic digesters, or
Well, it's different. It's a different, organic waste, which has been which was formerly trash, right? Right. And it's all soluble. So it's all very heavy, is now going back to either composting or the digester in Southington today. So, and Stop and Shop has their own digester up in Freehold, Mass. So they backhaul all of their food waste. But these are two different conversations. Our first goal is to sell product. Our next goal is to donate product. So there's a hierarchy in terms of where this food goes. We're not giving away the stuff at the hot bar, right? That's going to an anaerobic digester, unfortunately. It has to. There are safety issues. There are, concerns about where does that food go if you donate it, right? So canned goods, frozen meats, things of that nature are basically on the donation list. I mean, if you look at the list, it's very interesting. And then baked goods the day of, but you're not going to see prepared foods, given to, because we've had those requests. It's like, why are you throwing that food out? Because there's a safety issue here. We don't know where that food's going. Can't give you that food.
Is it an OSHA issue?
Sure.
Yes.
Absolutely. So there's a difference between anything that's going to the digester and anything that's donated. And believe me, we're donating before anything goes to a digester. Think about this, and your family was in the business. It costs a lot of money to transport trash and organic waste as well. It's a hell of a lot cheaper for a business in the state of Connecticut to donate food and give that to their local, you name it. I think there are thousands of organizations that our members donate to throughout the state, thousands. And it's a lot better to give it to them than it is to pay a tipping fee for organic waste. So we are looking to donate product before we put it in a digester.
And
So-
you typically, and I'm assuming this varies, do these organizations, these food banks come and pick it up, or do the supermarkets drop it off?
Both.
Both. I
So,
think it's more one than the other.
well, I mean, it's really about resources, right? So Food Share and Feeding America has an amazing network of trucks and distribution. And if they can come get it, they will. But most of the time we'll drop off to Food Share by trailer, frozen and things of that nature. And then what we see is you'll see the local church organization, St. Vincent de Paul in my hometown community of Waterbury, they come. They send their folks out pretty much daily. Church groups every day. So they come to the store and they build a relationship locally at that store. So it's a hybrid.
Yes.
In terms of how the food is donated. I would tell you the bulk, the frozen and the canned, the bulk stuff that goes to food share is generally delivered there. And the hyper local food that is donated is generally picked up by a local entity.
Okay, thank you. And I know, as you said, my family was in the supermarket business for years, and that is the cornerstone of what these supermarkets like to do. A lot of them are family-owned businesses or were many years ago, and they want to give back to their community and they want to donate this food. And I think it's something, and I commend them and I thank all of them for doing the great work that they're doing. Hopefully we could figure out a way to get even more food donated to all these organizations. So thank you for being here today.
Yeah, of course. And Senator, I just wanted to go back to one point you made in terms of, you know, how this food is getting there and how it's parsed out, right? So, for example, you know, we talk about a large entity and take an Aldi, take a Walmart, you know, the non-local, so to speak, right? There's data that we share every year in terms of the tonnage that they are donating. So there's a line of sight to the tons of how big this is. And most folks, unless they get into that data and take a peek at it, don't realize. So it's not just the local guy, the local family-owned business, you know, it's all of them. And I would be more than happy to share the latest report that I had. And that was a food share report based on who donated and how much they donated. It's an eye opener how much actually goes there.
That would be great if we could get a copy of that report for the committee too.
And I don't have the latest, but I'll ask for the latest before I send it. If not, I will send you the 2023 data, which is the last I had, Representative. Of course.
So just wanted to clarify, help me understand, when is the decision being made for sending the food or the material to the anaerobic digester rather than having the donation?
Well, a lot of times it's what is it, right? So there's certain food that has to go to the anaerobic digester because we're not going to donate it. So
why not?
Because it's in there are liability issues. You're not getting the leftover rotisserie chickens. Not happening.
Okay.
Right? You're not getting the chicken wings that are in the hot bar or the leftover stew that's in the hot bar. That it's unsafe. You don't know where that's going. So that'll go to a digester. That's the food that goes to a digester, the food that's in the foods to go that you can't donate. The food that's donated is generally, you know, cans of product that are dented or that are close to code, frozen products, beef, pork, chicken, you name it. If it's frozen, we can control it. So lots of deli items will go. Breads, day old breads will go and be donated. Stuff like that's fine. It's cooked products that are potentially in a hot bar that are not. That's not going for donation. Right. That unfortunately, you know, is not saleable and you know, because of liability issues, is not going to be donated.
Okay, this is helpful. And there are dates on expiration on material as well, but they're written in two forms. It's best before is one thing that's written, and then another group of food items have expiration dates. So the best before can still be used.
Correct.
Okay, so you guys are aware of some of those intricacies.
Well, there's some really neat entrepreneurial ventures out there where companies are actually coming in and getting that product and reselling that product at a large discount. So there's some entrepreneurs that have kind of come into that space on the close to sell by date, and they're willing to take fruit that doesn't look good, right? So, you know, we don't want to sell it if the cucumber looks like kind of strange. So that product's still edible. And so what we're seeing is there are a bunch of entrepreneurial organizations out there that are coming in and collecting that food and they're reselling it at large discounts to consumers online.
And this report, do you submit it to somebody in the state or it's just within your organization?
Oh, no, the statute that requires us to report goes to the state every March 1st. And that is, again, statute 22A 226E.
Which agency?
I'd have to get back to you.
No worries.
I believe it's DOAG.
Okay.
I believe it's DOAG.
Okay. Good to know. And is it okay if we reach out to you after this hearing and then have a discussion? And
well, we've done over 75 store tours with legislators in the last 40 months or so, and I would welcome any one of you into any one of our locations to tour with us and talk about, you know, what's happening in your local supermarket. So the answer to that is absolutely. Anything I could do to get you more information and anything we can do to help support this particular issue, we're all in.
okay. And one more thing. We love Food Share. They're doing good job, amazing work. And they do not have coverage across the state. So there are other groups as well which have broader coverage. And
so, for example, there's the large organization down in Stanford.
Yeah.
That gets all of our ShopRite, all of our Stu Leonards, all of our entities down that way in the state are working. This for us, it's the neighborhood that they come. If we give it to Food Share, it goes to Food Share, but we're working in Madison, New London, Waterbury, Stanford, you name the community, Bridgeport, you name the community, there's somebody coming to one of our stores right now who we're donating to.
Love it. Thank you so much. Thank you for your testimony. Thank you for being here and the work that you guys and your team does every day.
Please come and take a store tour. We'd love to take you through.
I'll take you up on that. Thank you. All right, that brings us to the next person on our list, which is Dr. Dinesh Kapoor. Dr. Kapoor, you're online. Welcome.
We just need to pull him from an exam room, so if you can hold for one moment.
Okay. Dr. Kapoor, or we can move to the next person. We'll wait for.
He's coming. I'm so sorry.
It's okay. We can come back to him if he's in the middle of an important conversation, I know.
He's coming.
Okay.
He's coming from the room, so.
Waiting for the doctor.
Camera's on.
I'm on?
You.
Okay.
Yep.
So I'm on?
Yep.
Hi, Dr. Kapoor. Welcome. Thank you. I know you're in the middle of seeing a patient. Sorry, we apologize to your patient and you're on. Welcome. You are muted. You're muted.
There we go. No problems at all. Thank you. Dear members of the Public Health Committee, thanks a lot. And I apologize that I'm not there in person because I like my interaction with all of you. But due to all these weather delays and all that, I have a pretty busy clinic due to rescheduling. So my name is Dinesh Kapoor, and I'm an oncologist and hematologist. I'm board certified, and I've been taking care of patients in North and Southeastern Connecticut, actually in whole of Connecticut for the last 28 plus years. I'm the president of my independent medical practice, Eastern Connecticut Hematology and Oncology Associates. And we take care of almost multiple thousand of patients a year. I stand in opposition to House Bill 5398 because it threatens the ability of practices like mine to continue providing patients with access to the highest quality, cost-efficient care in convenient, independent practice and in their own communities. About 7 years ago, my practice partnered with a management services organization to reaffirm our commitment to our community. The only other option at that time was that we either joined one of the bigger hospital networks, but we chose to remain independent. Little did we know that how important our partnership would end up, because COVID hit and we were able to get all the pandemic supplies, the flow of PPP, medications, vital supplies like saline flowing into our practice. Our cancer patients' treatment did not stop because of the pandemic. And our partnership with our MSO has led to many other things in our practice. And I apologize if I'm digressing from my testimony, which is in writing, because I really want to convey what we have been doing. Even years after the pandemic, our partnership continues to help us obtain life-saving and curative chemotherapies such as cisplatin, which was a shortage a couple of years ago, but we were able to get it. Patients come to us from out of state because of how quickly we are able to get personalized therapies for our patients and clinical trials that we so cherish in our community. Our partnership with our MSO and our commitment to our patients allows to bring state-of-the-art infusion therapies and infusion services in our practice for blood cancers as well as solid tumors. And I am very proud to say that we were the first independent practice in the state to do bispecific antibodies for our patients in multiple myeloma. And now we do it in lymphomas, leukemias, as well as small cell cancer of the lung. And in fact, we are the only practice that has developed an outpatient protocol in our community on an outpatient basis. No other practice has done it, but we have been able to do it. The MSO investments in our practice and our medical group in Norwich have kept cancer care local and in a lower cost, high value setting. These have helped us compete getting the best talent into our practice and expand our care. And we like to say that we are at a very high level and pretty much give as much care as a university would.
Excuse me, Dr. Kapoor, but you've reached your 3 minutes. Thank you.
Oh, okay, well, I'll just end with a couple of things, which is I will remind the committee of a critical point, that while our partnership with the MSO means that I'm always one phone call away for any decision, all the decisions that need to be made are made at a local level. The MSO does not control anything apart from helping us with business support. My final point that I want to really convey to all of you is that House Bill 5398 gives the Attorney General a shocking, and I mean it shocking, amount of authority to impose conditions on transactions so that they may go forward or not. I'm not aware of any state in the union that puts this kind of power in hands of a law enforcement officer. Our patients demonstrate every day the need for medical care that we provide. And it is unclear to me why Connecticut wants to take a step backwards and really penalize independent practices from being able to practice medicine in their own community.
Thank you, Dr. Kapoor.
Perfect. So I will be more than happy to answer any questions.
Yes. Dr. Kapoor, I wanted to thank you for your testimony. You're no stranger to this committee because you've spoken to us pretty much every year for the past few years, and then you've helped us understand the intricacies about private equity in the outpatient setting and then for specialty practices, and the fact that you've sort of educated us that it does not impact access, which is different from the private equities that we have seen. So there are two bills. One was Senate Bill 196, and which actually accommodate some of your previous testimonies and the previous bill that we were able to get many of the physicians to recognize, and it was not going to negatively impact existing practices. This bill is a little different. It's also coming to us to address some of the areas, and your testimony is helpful to us. I know one of my colleagues has a question, and that's going to allow you to answer that question and perhaps expand more. So I wanted to have one of your colleagues and our colleagues, Senator Gordon, ask you a question. Senator Gordon.
Thank you, Mr. Chairman. And Dr. Kapoor, it's nice to see you again. I think if I recollect, we've known each other and been colleagues in oncology for at least 27 years. So I understand very well what you do out there in the community. And I know you, like me and others, have a very strong and deep and continued focus on patient care and the importance of the patient-physician relationship. And a question I have for you to follow up on your testimony is that when the legislature is trying to sort through what we do about certificate of need with regards to keeping private equity completely away, I hope, from hospitals, that the problems that have been created that have made the news have not been by private practice groups such as yours. And in fact, your testimony highlighted about the MSO that you have for your group practice. And I just want to clarify from you that given the number of years that you have worked with an MSO, that you have not found it in any way, unlike we've seen other things with private equity with hospitals, to be making medical decisions for you, telling you what to do for patient care, or in fact interfering in any way with regards to the care that you provide every day and night. But in fact, you found it to help you actually do those things and continue to move forward strongly.
I absolutely agree with you, Dr. Gordon. We and our partnership with our MSO actually has enhanced our care and our ability to deliver the care. And when I'm talking about the bispecifics that we were the first ones to start in our practice, and having developed the outpatient protocol was in conjunction with our MSO and other practices around the country that are also doing it in an outpatient setting. And I'm proud to say that we are the only practice in North and Southeastern Connecticut providing these services. So if anything, our MSO stays out of any clinical decision-making that we have in our practice, and they help us on the back end support with human resources, financing, business, etc. So all medical decisions are totally made by clinicians in our practice. It would not work any other way.
Thank you, and I appreciate your testimony. It's been to the point and very powerful as we're trying to make certain we can focus on where we need to focus and leave alone, hopefully, group practices such as yourself that are doing well and doing well for patients, and not to have any interference by state government. Thank you, Mr. Chairman.
Thank you. So Dr. Kapoor, thank you for your testimony. We will let you go back to your patient. You have testified.
Can I add one 30-second thing,
Yes.
Dr. Anwar, if I may? So, just to reinforce it from my side and my practice's side, as I said, we are the only practice providing these newer treatments in our practice in North and Southeastern Connecticut. Even our hospital employed clinicians that are employed by the big networks are not doing it. So our patients who are treated by them have to travel either to Bridgeport or to Hartford to get the same treatments in the step-up dosing. We are doing everything in our local community for these patients. So I just wanted to bring that in as well.
Thank you. We appreciate your testimony and your good work, and that really helps us make better decisions.
Thank you very much.
We'll move to the next person on our list, which is Sarah Pavone on remotely. Sarah, you're on. Welcome, Ms. Pavone.
Hi, thank you. Good afternoon. I want to thank the Public Health Committee for hearing my testimony in support of SB 364, an act concerning extreme weather protocols. So my name is Sarah Pavone. I'm Director of Strategy with Journey Home, and we serve the Greater Hartford and Central Coordinated Access Networks, or the capital region in the state. This bill is about making sure that when weather becomes life-threatening, our response is clear, it's predictable, and it's coordinated across the state. So our activations are life-saving interventions for people experiencing homelessness. And when temperatures drop to dangerous levels, our warming centers, outreach workers, and our coordinated homeless response system mobilizes quickly to ensure that we can have people access safe indoor spaces. While these responses save lives, the current system places tremendous strain on providers and workers responsible for carrying this out. Many warming centers operate with very small teams, and staff frequently work 2 to 3 jobs to make ends meet. When activations are announced with little advance notice, providers face significant challenges securing enough staff to keep doors open and extend hours. Backbone organizations and system coordinators like Journey Home spend countless hours helping providers create staffing plans, troubleshoot gaps, and problem solve operational challenges in real time. We stay on call 24/7 for these system barriers. And despite these efforts, the strain on frontline staff has been significant. Street outreach workers, street medicine workers also shoulder an enormous responsibility during these events. When an activation occurs, our teams shift immediately into emergency response. Workers extend hours, work overtime, actively searching for individuals outside so that they know that there's a safe space available and that they can come indoors. Beyond outreach and engagement, we also have these workers providing transportation to shelters, hotels. They assist with meal delivery, ensuring clients placed in hotels have access to food, conducting daily check-ins to ensure people remain safe and connected to services and medical appointments and have access to medication. The responsibilities dramatically expand the scope of this work during extreme weather responses. And for individuals experiencing homelessness that these systems serve, last-minute activations cause confusion, anxiety, barriers to accessing safety. People living outside have a right to know what resources exist in their community that will allow them to stay safe and quite literally to stay alive. Coordinators must ensure individuals have access to transportation, medication, medical appointments, food. We accommodate for pets. When placements occur outside of someone's community, the level of coordination required also increases significantly. These efforts are essential, but the current approach relies heavily on emergency response that places significant strain on providers and individuals they serve. Extreme weather protocols are not simply an administrative procedure. They're life-saving systems, and strengthening them will help ensure no one in Connecticut is left outside without access to safety during dangerous weather conditions. We support SB 364 because it addresses what we experienced this winter. We must standardize extreme and hot weather protocols with clear triggers, temperature, wind chill, heat index, that prompt required opening of warming and cooling centers statewide, and
Excuse
also
me, Ms.
requires
Pavone, but you
coordination.
have reached your 3 minutes. Thank you.
Well,
thanks so much.
Thank you for your testimony. This is very helpful. So I think what I heard you say is that if you are not informed in advance, the amount of work and coordination goes up significantly. And if there is a predictive modeling that tells you what to anticipate, then that helps not only the people who are doing hands-on work, but also the people that you're doing the work for. Correct?
Yeah, yes, absolutely. And I know Rep. Sweet, referenced the activation that was called extremely late last night. But that is a clear example where by the time it was called, there was not enough time to coordinate outreach or any services to inform anyone that an activation had even been called. I think across the state, maybe only 2 people accessed a hotel room because just no one knew about it. So having a lack of notice and a lack of coordination across the state of when these get called significantly hinders our ability to provide services and coordinate locally.
I think your voice really is very helpful. That reaffirms, at least to me, and I'm sure many of my colleagues, that we can do better. Thank you.
Thank you.
And we go on to number 11, Amanda Gonthal, who is online. Welcome. You're on.
Hi, thank you. We have submitted more lengthy testimony. I've condensed it for today's purposes, hopefully adequately. Good afternoon, senators, representatives, and distinguished members of the Public Health Committee. My name is Amanda Gunthal, and I'm here today as president of the Connecticut Association of Ambulatory Surgery Centers, representing our 61 freestanding ASCs that provide high-quality, lower-cost surgical care to patients across our state. Thank you for the opportunity to speak on HB 5045 and HB 5398. ASCs are among the most regulated healthcare facilities in the country, subject to state licensure, federal CMS certification, national accreditation, and participation in a patient safety organization. We are committed partners in patient safety and quality while making healthcare more accessible and affordable for Connecticut patients. We appreciate Connecticut's efforts to modernize the Certificate of Need process. Regarding HB 5045, we strongly support removing CON requirements for cardiac services already approved by Medicare to be performed in ASCs, expanding access to important procedures at lower cost without compromising safety. We also support eliminating CON review when facilities reduce or eliminate services. Physician recruitment often drives those decisions, and facilities should not be penalized for market realities. The 10-mile relocation safe harbor is a positive step. We respectfully ask that it be expanded to 20 miles, reflecting real-world requirements of healthcare facility siting needs, including building requirements, parking, and roadway access. On process, we ask the committee to consider 3 refinements: enforcing the 30-day statutory deadline with deemed approval if not met, limiting completeness letters to no more than 2 per session per application, and providing clarity that public hearing and decision deadlines are firm. We also seek to further discussion to better understand how the 3-agency panel will function efficiently given differing priorities of each agency. And finally, we have significant concerns regarding the 20% ownership change threshold triggering a full CON review. Recent hospital bankruptcies, the apparent driver of this provision, did not involve surgery centers, and applying this broad standard to surgery centers discourages investment, limits access to capital, and makes physician recruitment harder at a time when Connecticut already faces provider shortages. Regarding HB 5398, we do have concerns, and we respectfully ask to collaborate on a better path. While we understand the intent behind greater transparency in healthcare transactions, HB 5398 creates a duplicative layer of oversight. ASCs already report ownership through both the CON process and DPH licensure requirements. Adding Attorney General review of a broad range of changes will create delays, increase costs, and will disadvantage Connecticut relative to neighboring states when recruiting physician investors. We are asking that this committee work with us to ensure that new oversight is targeted, efficient, and does not inadvertently harm the facilities that Connecticut patients depend on. We look forward to a continued dialogue on both bills, and thank you for your time and consideration.
Thank you so much for your testimony. You're right on time. We actually had our alarm go off exactly at the time. So
That's a first for me,
thank you,
Senator.
So, I just wanted to, is there, do you have an insight into how many of your facilities of your different group are owned by private equity?
Or have that kind of relationship? I don't, but we can certainly pull the membership, and I can get back to you guys with that for sure.
Okay, and this is outside the scope of our conversation, but I'm just going to put that on the radar. If it would be helpful to know how many are owned by private equity, is there any one of them who restrict Medicaid access? And so because I think there is a perception that some of them are pure business financial entities. But I think there's more to that. It actually reduces the risk of infections. You're outside of a larger healthcare facility. The service area is easy access and it has better coverage. So there are multiple other positive things that happen as well. But because of some situations we have heard that access may be impacted. So I will probably, if there's a way to follow up on that at some point.
Certainly.
And then my co-chair has a question or comment for you.
Sure.
Representative.
Thank you. Thank you, Mr. Chair. And Amanda, thank you very much for being here with us and testifying. I'm just wondering if we can just make sure to get your written testimony. I was scribbling, some notes, but I want to make sure that we have that. Have you submitted that already?
Yes.
Okay, great. So it will, I'm sure, be posted, and I may not be finding it so quickly, but I think you had some good concrete suggestions and thoughts. So thank you for your testimony.
Thank you.
Thank you. And with that, the next person on our list is Dr. Robert McLean. Dr. McLean, you're on. Welcome.
Yes. Can you hear me and see me okay?
Very well. Yes.
Super. Okay. So Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claritas Ditria, and members of the Public Health Committee. My name is Dr. Robert McLean, and I'm President-elect of the Connecticut State Medical Society. I'm here on behalf of the physicians and physicians in training of CSMS to testify on House Bill 5045. We have submitted more detailed written testimony for the record, so I will focus my remarks on the central policy concerns. CSMS is concerned that House Bill 5045 significantly expands CON requirements into routine physician practice transactions at the very moment that small and medium physician practices are under intense financial pressure. Under current law, a CON is required for the merger or acquisition of a physician group practice of 8 or or more physicians. HB 5045 lowers that threshold dramatically. It would require a CON for transactions involving as few as 2 physicians if the practice meets a $10 million revenue threshold or involves private equity. That's a major policy shift, and the rationale behind it is unclear. The $10 million revenue trigger is flawed in the physician context, as others have stated. Revenue is not profit. In many specialties, particularly those that bill for high-cost drugs and infusions and maybe some diagnostic testing, revenue can be artificially inflated due to pass-through billing. A small 3-physician practice can exceed $10 million in revenue, while a larger group may not. Revenue does not reflect market power, yet it becomes the regulatory trigger. For many physician practices, mergers are about survival. Rising administrative costs, low reimbursement, and persistent Medicaid underpayment are forcing physicians to combine resources just to keep their doors open. Imposing the CON processes on these transactions adds cost, delay, and uncertainty. Some practices will simply close rather than navigate that process. Others will default to hospital or health delivery system employment that accelerates consolidation rather than preserving physician practices and patient access. With respect to private equity, we recognize the concerns, particularly in light of the Prospect Hospital experience. Oversight is appropriate. However, HB 5045 responds with a blanket CON trigger based solely on the presence of a private equity entity without defining the term and without distinguishing between minority investment and full operational control. That is an overly broad solution to a nuanced issue. We also note the framework in HB 5398, which places review of private equity transactions with the Attorney General. Conceptually, that is more appropriate than an automatic CON trigger. However, 5398 still lacks clearly defined standards, objective criteria for review, and concrete guardrails. Practices must be able to understand exactly what is being evaluated, what benchmarks will be applied, and what timeline will govern the review. Without that specificity, the CON process creates uncertainty rather than meaningful oversight. Finally, HB 5045 also restructures the CON process itself, moving it to DPH and replacing rolling review with quarterly cycles and other time-sensitive requirements. The timelines outlined could approach a year for a standard decision, not including appeals or other issues. For
Excuse
physician
me, Dr.
practices,
McLean, but you've
negotiating.
reached your
Yes.
3 minutes. Thank you.
Okay, thank you. One last sentence then. Thank you.
Yes.
In short, this bill expands CON into smaller physician practice transactions at the worst possible time. It risks accelerating closures rather than preventing them. I do not think that is the goal of the legislature. So I respectfully urge the committee to reconsider this expansion of the CON process. And I'm happy to take questions.
Thank you so much, Dr. McLean, for your testimony. Thank you. You have submitted a written testimony as well, correct?
Yes, the two different bills.
Okay.
With more detail. Yep.
This is very helpful. And then I think you've covered a lot in the 3 minutes. It's a pretty filled testimony, but very substantial information for us to look at this. Do you think that we have been talking about the shortage of physicians in our state? Do you think if the bill passes in the current form, that's going to make it worse?
I think it could. Yes. And I say that because I think that, first of all, you're going to have more practices that will either merge, become part of larger groups, or I think some of the doctors on the latter half of their career may actually decide to just retire and hang it up. They just can't handle trying to do it alone. So the small practices, 2, 3 people maybe, may just say, I've had enough, or I'm going elsewhere.
Okay. Thank you. This is helpful. And Senator Gordon has a question or comment for you. Senator Gordon.
Thank you, Mr. Chairman. And Dr. McLean, thank you for your to-the-point and very powerful testimony. I can, as a past president of the Connecticut State Medical Society, I look forward to you becoming our next president. I won't say if that congratulations or condolences yet. But one question I had for you in follow-up, and I think it's an important point, when we look at various provisions of this bill, and it's also built into current CON policy, is relative to Medicaid. And I'm not saying we shouldn't be providing access to Medicaid. I think we need to be doing what we can to be of help. But one thing that you know well, and I want to ask you a question on this, that when we talk about CON provisions and unnecessarily lowering the bar to tag small group practices, many of which are trying to make ends meet, keep their employees paid, literally keep the lights open and the heat going so as to provide patient care. More provisions that tag them to Medicaid during a time of continued massive under reimbursement for Medicaid, including actually at a loss, which it makes things more financially difficult. Do you see that as part of the problem with regards to the CON relative to Medicaid provisions, that we should also be looking at what we can do relative to Medicaid reimbursement so we can have more private practices in this state and not try to be burdening them with a lot of different CON provisions?
Yes, yes, I completely agree. I think one can envision these small group practices that are potentially merging, a three-person group, whatever, who now may hit that threshold of dollars and have to go through the CON approval process. Those are exactly the practices that really have a hard time surviving on Medicaid rates. And when Medicaid rates are so low, and we all know there's reports showing that, it is an increasing barrier that may make some of those practices not try to merge and potentially try to merge, if anything, with one of the larger health systems, which doesn't have as much of an issue with larger administrative burden, although they have plenty on their own. So I do think tagging Medicaid participation to the CON could definitely have negative consequences to the small groups that are being hit by this the hardest.
Thank you for your testimony, and thank you, Mr. Chairman.
Thank you. Seeing no other comments or questions, thank you, Dr. McLean. We appreciate your testimony and your recommendations.
Thank you.
Next person is Dr. Mahesh Bhaya. Welcome, Dr. Bhaya.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy, Wahi, and other esteemed members of this committee. My name is Dr. Mahesh Bhaya. I'm a practicing otolaryngologist in Waterbury for the past 23 years. I'm here to testify against the Governor's Bill 5045 that restructures the Certificate of Need process and expands it to small physician groups in Connecticut. I want to speak to you not only as a physician, but as someone who may have been impacted by this proposal. I am currently part of a small full-time physician independent practice. We have a pending merger with another small otolaryngology practice. The resulting merger will be a 5-physician practice. We are merging for practice survival. Remaining independent in today's healthcare environment is increasingly difficult. Reimbursement pressures and administrative burdens continue to rise. For small practices like ours, combining resources is often the only path forward that allows us to remain independent and continue serving patients in our inner city community. We are not eliminating competition or creating market dominance. We are local physicians trying to keep our practices viable without selling to a hospital system or a corporate entity. Small community-based practices combine resources to survive in an increasingly complex healthcare environment. If this bill had been in effect, our merger may have required a CON. For a small physician group, the CON process is expensive, time-consuming, burdensome. It requires attorneys, formal applications, and months of uncertainty. That kind of regulatory hurdle can be the tipping point that pushes independent physicians to either abandon a merger or sell to a larger corporate system that has the infrastructure and the capital to navigate this process. What is the policy rationale for requiring a small merger like ours to go through a CON? We are not consolidating across regions. We are not driving up prices. We are trying to stay independent.
Should I start by saying I'm a doctor?
Moreover, independent physician groups typically deliver care at lower total cost than hospital-owned practices. Supporting their viability helps prevent further cost shifting into higher-priced hospital systems. Thoughtful policy can ensure safeguards remain in place. Transparency requirements, size thresholds, and oversight mechanisms can distinguish between harmful consolidation and pro-competitive collaboration. The goal should not to be block small practice from working together, but to ensure that collaboration strengthens access and affordability. If we fail to provide clear and reasonable pathways for small physician mergers, we risk accelerating the very consolidation that drives higher costs and reduces patient choice. Thank you very much for your time and consideration.
Thank you, Dr. Bhaya. Thank you for your testimony. This is very helpful. I was just saying that we hear you loud and clear, and I know this is this bill is probably going to have a negative impact on a number of practices like yours and not necessarily protect us from what it's intended to do. So your testimony really helps us out. So I wanted to thank you for that. I have one of my colleagues who has a question, Representative Steinberg.
Thank you, Mr. Chair, and thank you for your testimony, Doctor. We're trying to address a problem we're seeing in the marketplace, and we're very sympathetic to the role independent physicians play in our state. What should we be doing to help you? If it's not this bill, are there other things we might do that are going to be effective in allowing you to maintain at least a profitable business?
So the biggest problem that I see in Connecticut for otolaryngologists, and our practice in particular, we are a shrinking specialty. And I have another written testimony on behalf of our Connecticut Otolaryngology Society stating that shrinking ENT population, very hard to retain the physicians who graduate from Yale and from UConn to stay in state. Obviously, the medical malpractice environment does not help. In the city area like ours, the Medicaid population rose from about 12% to 20% in the last 5 years. And this is just based on statistics from my practice. On the other hand, the Medicaid reimbursement, as you all know, has not gone up in the last 20 years or so. So, when we run the analysis for every $1 that we spend on seeing a Medicaid patient, we probably get reimbursed 40 cents to $1. So very obviously, I know the governor has looked at this. The committees have looked at it. I've discussed this with Senator Anwar in the past. We definitely need to help inner city communities and physicians like ours who take care of Medicaid patients. And we don't shirk away from that responsibility. But definitely, if something can be done about that, we can probably stay more viable.
Thank you. It's just that easy. Reform the whole system.
No, it's not. I understand. I've been doing this for
I'm being
23
facetious.
years.
I'm sorry.
No,
It's just that unfortunately we're dealing with so many ramifications of a broken system. We're going to basically kill off independent physicians at the same time. And I wish we had a better answer. Thank you, Mr. Chair.
Thank you. Again, Dr. Bhaya, we hear you, and your testimony is going to help us make better decisions. Thank you.
Thank you much.
Seeing no other questions or comments, we'll move to the next person on the list, which is Dr. Adam Kay. Dr. Kay, you're on.
Thank you, Senator Anwar, Representative McCarthy-Vahey, and the other esteemed members of the committee. I'm Adam Kay, Dr. Adam Kay. I'm a radiologist practicing in Connecticut and a counselor with the Radiology Society of Connecticut. I'm here to offer comments on Bill 5045. We do appreciate the fact that Governor Mott has proposed a bill to improve and streamline the CON process. We support the provision in Section 4 that retains CON for the acquisition of imaging equipment. We in particular thank members of the committee and other members of the legislature for their support on that, including keeping provisions for MRI, CT scan, and PET CT scanners within the CON process. We believe it's critical that the CON process remain in place. Otherwise, we'd see an immediate migration of units to affluent areas with high proportion of self-pay patients and taking the access away from areas of the state that may be more in need of medical care. The law plays a key role in ensuring that the access to this life-saving equipment exists throughout the state. One important issue that's been raised is the expedited review process for CON proposed in Section 7. We do not have an issue with expedited process, but we do believe this should include a hearing when requested by an affected party. We do have provided, and it's provided in my testimony draft language that might accomplish this, specifically in Section 7, lines 400 to 406, could be amended to say, in accordance with the provisions of subsection D of section 6 of this act, any person seeking to participate as an intervener in an expedited CON proceeding may request a hearing and status as an intervener in the same manner that such a request would be made in non-expedited CON proceeding. In addition, the panel may hold a public hearing regarding any complete and eligible expedited certificate of need application. As I mentioned, this is in my written testimony as well if there are concerns, if there are questions about the language. We do have some other areas of concern regarding the three-person panel of the commissioners of the Department of Social Services, the DPH, and the Secretary of the Office of Policy of OPM. Will make all the decisions on CON applications. It's outlined in section 2, but there are no specifics as to how the process will operate, and we might be open to discussing how we might memorialize this in writing within the bill. Section 11, policies and procedures developed and implemented prior to the adoption of formal regulations. It's silent as to whether or not the public can offer written comments about draft document or participate in the hearing prior to its adoption. As mentioned, we believe these procedures should be mandatory and written into the bill. And section 6 and 7 outline the process for timing the consideration of CON applications, both standard and expedited. As we reviewed, it appears possible this could make the process longer, not shorter. I realize I'm probably running short on time, so I will simply finish by thanking the members of the committee as well as our entire legislature and the governor and his office for keeping CON on imaging. We truly feel that getting rid of CON on imaging would further the shortages we have of radiologists, and particularly shortages of radiology technologist shortages, further depleting an already diminished workforce. And we also obviously appreciate the work that was done last session on that issue as well. So I'm happy to take questions.
Sure. Thank you so much for your testimony. My co-chair, Representative Kristen McCarthy-Vahey, has a question.
Just to thank you, Dr. K. Very helpful testimony, and we'll be talking further.
Wonderful. Thank you.
So I have a question, Dr. K. You know, your industry has been impacted quite a bit. In the recent past, private equity just pretty much impacted 1/3 of all radiologists in our state. It was a pretty sad situation. How are we going to be able to address some of those challenges to protect that from, prevent that from happening?
Yeah. So to paraphrase Representative Steinberg, a complete overhaul of our healthcare system might be a good way to start. But it's a very difficult issue, and I really appreciate both the legislature and the governor's office and everybody's efforts on this. It's a very difficult question because no matter what gets drafted, there are always workarounds, and there's always ways that say a private equity investor led group might get around them. So we in general we support things that will keep healthcare local, things that will keep both small independent practices as well as, some of these issues are not unique. We always talk about the small independent practice. They're not unique to some of my colleagues that work in, say, Yale or at larger practices out of Hartford. And so things that give doctors control. So tackling, things that tackle prior authorization, issues of prior authorization, things that tackle maybe malpractice reform and tort reform are things that would go a long way towards making it easier for small groups not to have to consider selling to a large group. And that's for radiology, but as well as probably every other specialty and every other medical provider and healthcare provider in the state. So that probably skirted your question a bit, but I hope it helped a little bit answer.
Sure. Thank you. I have more questions. So I wanted to also ask you, we're trying to streamline the process, and one of the commonest thing that has never been rejected is a request for a CAT scanner. And in the past, the Office of Health Strategy would say we should probably not even have that on a CON list. And then right now there is the CT angiogram are something that the cardiologist can hopefully identify illness far faster and then manage those patients more efficiently. And if they were to go to a radiology lab, it takes a much longer time to a radiology facility to get the answers. So I know you and others, and I'm sure we're going to hear from Dr. Farquhar soon. What is the area that you would be willing to say as radiologists that, okay, we will not want to have a CON for that?
Okay. Tough question. I think my official answer is that we would like CON we like CON as it is for CT, for PET CT, for advanced imaging, for MRI. I think I understand the need that can arise for especially more acute need for CT scanners, since they are so incredibly necessary, say in emergency care and hospitals. As you mentioned, there may be chest pain imaging centers open that might need access to coronary CTA and chest CTA and things like that. I think that the expedited process can help with that. I think that the expedited process, when done appropriately, can make sure that hospitals or cardiology groups or whoever really needs these in short order. I think I would push back on the fact that the idea that we have never rejected a CT CON is not necessarily a sign that it's not working or that it's not necessary. I would counter that it may be a sign that it's working just as intended, and that that we don't have groups coming in unnecessarily asking for CONs because they know that the process works. Now, is it taking longer than it should? We wouldn't disagree with that. We would agree with the need for an expedited process, but you don't want to get rid of a process that actually in reality might be working pretty well to protect patient access and patient care.
Thank you so much for your testimony. I see no other questions or comments. Thank you.
You're welcome.
Thank you. And Sarah Bromley, I just want to check she's not here in the room. She's not in the virtual room. Okay, that's Dr. Farquhar, you're on. Welcome.
Hi, Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claridis Dietrich, and members of the committee. For the record, my name is Thomas Farquhar. I'm a radiologist practicing in Connecticut, and I serve as the legislative chair for the Radiological Society of Connecticut, and would like to offer some more comments on House Bill 5045. Basically, I'll just kind of emphasize some of the things that Adam had already spoke about, my colleague. We're in support of an expedited process and making the CON process easier, but we would also want to see a few things in the bill hopefully be addressed. One is to make sure that they keep the possibility of public comment, especially in intervener status. The reason behind that is we have seen other ones where CON applications have gone through and basically whatever's put in the application is just accepted as fact. And we think that especially other radiology or hospital groups that are experts in the area should have the opportunity to make public comment and provide that information as well. There were also the number of different kind of operational decisions about how things would work that were not specified in the bill, and we have concerns that could make it longer and more complicated rather than easier. So we would hope that those would be fleshed out before being finalized. And the last thing that we wanted to do is we just wanted to make sure that, more information around the administrative aspects of the process and the timing. And then the last part was to reemphasize what Adam was mentioning was about dropping the size of a group that counts as a small physician group. We do think that this will have sort of a negative effect. It'll require CONs for it went from 7 physicians down to 2 physicians, so now a 3-physician group is going to require us going through the CON process, which will make things more difficult. And so we think that's kind of a step backwards, and would like that to be at least considered in that direction. Thank you.
Thank you so much for your testimony. You heard some of the questions we asked Dr. K.
I do. May I?
Yeah. Do you want to answer them? Yes.
May I? Yeah, I was just going to say I didn't want to interrupt. So one of the questions about what to do with private equity, as Adam said, it's a difficult problem. I don't actually think that private equity is the problem. I think it's the final behavior that ends up being a problem. But what I do know is his statement about trying to empower physicians is the most important things. The groups don't do these types of mergers for any other reason than because it's all a consolidation thing in order to be able to survive in healthcare. So the hospitals will tell you that the insurance companies are so big, they push them around, and the physician groups will find that the hospitals have all the leverage, and that the physician groups need to get bigger in order to be able to be able to vie in healthcare with the size of hospital systems and insurance companies. So how do we reverse that trend? I don't quite know, but anything that's going to make it easier for physicians and physician groups is going to keep them from trying to consolidate. And then the other question about the CT scanners always being approved. The last CT scanners that were not approved was a CON application that was put in during COVID. It was for 3 CT scanners to scan asymptomatic patients in the very beginning of COVID when we had no treatment for it whatsoever. And there was a physician who subsequently made the New York Times for overbilling for dozens and dozens of lab tests that he would do in addition to a COVID test. And he wanted to scan down in Fairfield County patients with CT scans. So because there was a public comment for that, we were able to provide information from the radiology literature at the time, showing that there was no role for CT scan for the diagnosis, particularly back when it was untreatable, and that those CON applications were not approved. So I wholeheartedly agree with Adam that the CON process is working from that standpoint, that we usually don't get spurious ones. As far as CTAs for cardiac studies, there are decades of data showing that if providers order the studies and they own the equipment, utilization goes up. It's true for knee MRIs, back pain, CT scans for stones ordered by urologists. And so my question was, do we really want Connecticut to run the natural experiment of seeing how much CTA coronary utilization will increase if cardiologists own the CT scanners? Because that would be the concern for self-referral and overutilization.
Thank you so much for your testimony. This is very helpful. I see no other questions or comments. Thank you.
My pleasure. Thank you.
And that brings us to the next person on our list, which is number 17, Erica Rojivine Byrne. I hope I pronounced it correctly.
You were pretty
Welcome.
close, Senator.
Thank you. Go ahead.
Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and esteemed members of the Public Health Committee. My name is Erica Rugavane Byrne, and I'm the Development Director at She Leads Justice, a statewide nonprofit that uses a justice and equity lens to advocate for under-resourced and marginalized women and girls in Connecticut. For over 50 years, we've been a leading advocate for policy solutions to enhance women's economic security, combat discrimination, and increase gender equity. She Leads Justice stands in support of House Bill 5389, an act concerning a provider toolkit for the diagnosis and treatment of menopause, perimenopause, and postmenopause. My written testimony cites new research and data points about how undiagnosed and untreated perimenopausal and menopausal symptoms exacerbate economic and racial injustices. A toolkit would be a step towards addressing those injustices. But in my time before you today, I want to share a personal story of how this bill would help close a gap that I've experienced myself. I'm 44 years old, and I'm experiencing symptoms that can be attributed to perimenopause, including heavier periods and changes that are impacting my quality of life. I had my annual visit to my gynecologist a few weeks ago. She's been my care provider for over a decade, and I've always found her to be well-informed and supportive. I got there, I undressed, I put on the gown and sat down on the exam table. My doctor conducted the exam and asked if I had anything I wanted to bring up. I mentioned my symptoms and I waited for her response. I was prepared to be asked about my family history and told about different evidence-based options, including the use of topical estrogen. Instead, I was honestly shocked to hear her say that she didn't prescribe any form of hormone replacement therapy for anyone who is still having what she called regular periods. If you've been in the vulnerable position in an exam room, you know that arguing with your care provider is the last thing that you want to do. So I didn't. I nodded. She left the room. I got dressed and I left. It was painful to realize that my trusted care provider was less well-informed than the perimenopause and menopause subreddits, which are amazing, by the way. Although it would be designed for providers, a toolkit would have empowered me as a patient to continue the conversation with her. I'm very grateful to Representative Belton for her advocacy on this issue. This bill deserves to pass and it deserves to be funded. For every person who can be here today to testify in support of this, there are thousands of tired, busy women going through perimenopause. If they all had the time and energy to be here, their collective rage about how our very real symptoms are ignored or dismissed by medical professionals could get this bill emergency certified tomorrow. As this bill moves forward, I encourage the inclusion of guidance addressing racial and ethnic disparities and common comorbidities such as metabolic conditions. This is also personal to me as someone who developed a rare estrogen-sensitive liver condition during pregnancy, and I'm struggling to find any care provider who works at the intersection of these issues. Ensuring that providers receive comprehensive, equity-informed education will address racial and economic disparities and will help all patients receive evidence-based, compassionate menopause care. I respectfully urge the committee to pass this bill. Thank you for your time, and thank you especially to the committee staff for keeping this hearing moving smoothly. Happy to take any questions.
Thank you so much, Ms. Rogaline Byrne. Sorry to mispronounce your name initially. I have Representative Belton who has a question for you.
Wonderful.
Thank you, Erica, for your testimony. And I want to say that I'm sorry for your experience. And I can speak for myself and say that I had a very similar experience. And I know that there are many women who have their symptoms dismissed and they just don't know what to do next. So I am very happy that we have the opportunity to move forward this toolkit. But what I want to ask you is you mentioned something about an economic study. Can you tell me more about that study?
Yeah, thank you for the question. I'd be happy to. So as I was preparing to give testimony today, I did some research and found a new working paper from 2025 that was produced by the Stanford Institute for Economic Policy Research that found that women who visit a healthcare provider with menopause-related symptoms are earning 10% 4 years later, and that those effects are concentrated among women without college degrees and who are already in lower paying jobs. And so we know that women of color are disproportionately represented in these groups. And we also know that there are racial disparities in terms of who experiences menopause-related symptoms, with Black women reaching menopause 8.5 months earlier than white women and having worse symptoms, but are less likely to receive hormone therapy as well as mental health and medical services. So this really is both an economic justice and a racial justice issue. We know the overall impact on the economy and businesses in terms of hours lost, but we can really now see some real data about the impact that this has on individual women in terms of their ability to support their families.
Thank you for sharing that, Erica. I really appreciate you lifting up the economic impact that menopause symptoms have on women, but also the disparities that exist when it comes to Black women. So thank you for your testimony.
Thank you.
Thank you, Representative Kristen McCarthy-Vahey.
Thank you very much. And Erica, it's wonderful to see you. And I love that you gave a shout out to our team behind the scenes who's always helping. That we wouldn't be able to do this without them. Yes, as you know well. I just wanted to ask a question about the passing comment that you made about the Reddit subreddits that are helpful. And it really raises an important question for me, which is how do you know where to get good and helpful information that is reliable about menopause symptoms? I think it speaks to why we would want this toolkit, which you referenced, but
Yes.
how do you make that decision for yourself?
Yeah, no, great question, Representative McCarthy-Vahey, and great to see you. So I have a background in public health. I am an adjunct professor at the University of New Haven in their School of Health Sciences. I teach masters in public health students and also had the opportunity last semester to teach undergraduates in a research design and writing class. So I think a lot about how do we find evidence-based information and how do we understand it and how do we communicate it. And, in the last 5 or so years, we've seen an explosion of interest and information around perimenopause and menopause, kind of as our age group has aged into these experiences. And it is really hard. I mean, I'm someone I don't have TikTok, and so I don't see what's on there, but I know that, on social media, TikTok and Instagram, there's a lot of folks who are doing a lot of content related to it, and some of it, accurate, and some of it you don't know, or people sharing their own personal opinions and anecdotes about things. And so I am always really skeptical when I encounter information and always want to figure out where it comes from. And so in these subreddits, which are both moderated by the same people, actually, they have it's an incredible resource, this wiki page of information that is all linked back to the studies and to the professional associations and to the guidelines that connect with the specific symptoms, issues, treatments related to menopausal care. And so but it is really heartbreaking to know that, and I think many women especially have experienced this in medical care environments where you go in and you have to know more than your care provider does in order to get the treatment and the care that you need for your quality of life. And so it's really then becomes incumbent on the individual, and having a toolkit like this for providers, not just, gynecologists, but all different types of care providers. I mean, we see, how important estrogen is to your dental health, to your heart health, to your liver health, to all that stuff. So this would be a really great step.
Thank you so much. And I think you're pointing out two really important things. Is you have a background and know how to discern. Some of the rest of us don't know how to do that in the same way. So how do we know? And you also said there was an explosion of interest in information, but I think one of the things that is impacting providers, and maybe with just a yes or no, because I know we want to keep things moving, but with providers, is that there hasn't been an explosion of research on women's health issues in this way relative to many of the issues that we've seen. With a few notable exceptions, I think we've come a long way, for example, with breast cancer, but we don't have the same kind of body of research and background information. So I think, would you agree with that statement?
Yes, I would.
Well, thank you so much for your advocacy and testimony. And I would echo what Representative Belton said as well, that I appreciate you very much highlighting for us and informing me of the disparity for Black women and other women of color. I think that's something important and something I hadn't realized as clearly before. So thank you so much.
Thank you all.
Thank you. Thank you for your testimony, and then thank you for your advocacy as well, and also sharing your personal experience to highlight even some of the most basic things that we can do better at. So with that said, I don't see any other questions or comments. We'll move to the next person on our list, which is Kelly Craft, number 18. Welcome. You're on.
Hi. Good afternoon, distinguished members of the Public Health Committee. My name is Kelly Craft, and I serve as the director of the Meriden Middlesex Wallingford Coordinated Access Network at New Opportunities, also known as the MMW CAN. So I serve as the CAN backbone for our regional coordinated access network in this region. I also oversee one of our regional warming centers in the Meriden area. So I am here to speak in strong support of SB 364, an act concerning extreme weather protocols. So I am here to discuss on what the lack of standardized protocols affects me, my staff, and our community. So first I want to mention, staffing is our largest challenges when we're receiving a activation with hours, minutes, or sometimes even after the fact. We are scrambling to try to get our sites up and running. so we can ensure that people in our community have a warm place to stay and are safe from the extreme weather. As many of you know, and I know some of my predecessors spoke on it as well, our seasonal warming shelters run off of very small seasonal staff who sometimes have 2 or 3 other jobs. So trying to locate people who are free that day and able to work is a challenge. To get these sites up and running with little notice, we are often, myself included, supervisors and other managerial staff are often going to provide the coverage themselves. And if we had a protocol that was standardized, we would know beforehand and we would be able to plan a little bit better for these things. So that's on the staffing end. On the short notice end for clients, it is incredibly challenging because we're reaching out to our outreach committee, our outreach case managers to go out into the community. We're reaching out to our police departments, our mobile crisis, and our local mental health authorities who are working with people who are currently unhoused to locate and identify people who need to come in. And sometimes that is utilizing hotels because congregate living centers are not suited for those clients' respective needs. And I want to share an example of prior to one of the blizzards that we encountered this year. We had a client, I was working with one of our local mental health authorities who has an contract. Who has an ACT contract in our region. They had a client who was very skeptical about coming in out of the cold. We were trying to coordinate a hotel with our 211 providers. However, due to the late notice of the 211 activation, 211 was inundated not just from myself, but from my other state backbone providers in ensuring people are getting out of the cold. We're ensuring our cold weather spaces have ample room for people who are coming in off the street. It took this client 4 hours to get a hotel.
Excuse me, Ms. Kraft, but you have
Yes.
reached your 3 minutes. Thank you.
Thank you. I'm sorry.
Thank you for your testimony. This was very helpful. May I ask you a question? So if let's say extreme weather protocol is enacted right now, how do you reach out to the people who are homeless? As a director of a CAN, what is the next steps? What are the few things that you would do? If you can keep it short, but yeah.
Yeah, so I reach out to our local mental health authorities, so mobile crisis, our local police departments, as well as our outreach teams who are working with people who are known to be outside, and let them know that there's been an activation, and if anything is being risen, if they find anybody who is in need of assistance, to contact me, and we'll immediately find some kind of sheltering option for those individuals.
And on an average, when that's happening, how many people would you usually connect with during that time who would need the immediate help?
So in our region, I think we currently have about roughly 25 people unhoused. So it's roughly that 25 people population. We are one of the smaller coordinated accesses regions in the state.
Okay, so and so that's why you want to be ahead of the curve rather than having to catch up and try to navigate all of that with the limited resources in the evening or late at night.
Yes.
Okay. I think your testimony is very helpful. It continues to highlight the issue that we are all learning more about and recognizing we need to do better. So thank you so much. I don't see any questions or comments. Thank you.
Thank you.
And that brings us to in person over here, Kathleen Garrity. We'll have Dr. Goldman, we'll have you wait for a second because we called Kathleen Garrity just now, so we'll start with her. Kathleen, go ahead. Press the button. There. Thank you.
Thought I did. Thank you. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, ranking members, co-chairs, and members of this committee. My name is Kathleen Garrity, and I'm the Executive Director of the Connecticut State Dental Association, representing the licensed dentists in Connecticut, our oral health care teams, and the patients that we serve. I am here today to represent those groups and in strong support of 5399. There are two parts of this bill I'd like to address today. One is regarding a scope of practice expansion to allow dentists to do cosmetic injections. And the second regards our mandatory continuing education requirements that are addressed in this bill. Last year, CSDA worked with the Department of Public Health to initiate a scope of practice regarding cosmetic injections, and stakeholders were allowed to participate in that, including those in our state that can already do these injections, which include plastic surgeons, dermatologists, APRNs, PAs, and RNs. At the end of that report, which was an extensive collaboration over several weeks, the groups, the stakeholders that were there acknowledged that dentists are highly trained to do these injections. We have both the education, the anatomical expertise of the head and neck area to be able to do these safely, and the clinical techniques and education to do so. In fact, dentists do these injections regularly as part of their therapeutic practices. Connecticut dentists graduate from a CODA accredited program with extensive training in head and neck anatomy, neurovascular structures, pharmacology, injection techniques, and emergency management. In fact, a DDS is a doctor of dental surgery. Dentists complete thousands of hours of supervised clinical training and administer injections in the head and neck every single day. There are very few healthcare providers that do these types of injections as much as we do. Notably, dentists in Connecticut may already administer Botox therapeutically for conditions such as TMJ and bruxism. The medications, anatomical landmarks, pharmacology, and techniques are identical, whether we are doing it for therapeutic reasons or cosmetic reasons. The state has already determined that dentists are capable to do these agents safely and regularly. Prohibiting cosmetic use while allowing therapeutic use is not grounded in public health distinction. Nationally, there are at least 37 other states that allow dentists to do these types of injections. And I would actually like to note that the American Society of Plastic Surgeons in their latest annual report has noticed that this is a minimally invasive procedure, and it is very different from cosmetic surgery. With respect to the continuing education provisions in this bill, I would like to raise a few things. First of all, CSDA has reached out to the Commissioner of DPH as well as our State Dental Commission to talk about the inclusion of identifying potential patients who may have triggers that show us they might be victims of human trafficking. This is something very important to us. We would like to include this in our mandatory requirement that already covers looking for victims of potential sexual abuse and or domestic violence. It's a natural pathway for us to try to help victims and identify pathways to get them out of their situations. However, that's not a statutory requirement. That is something that is being handled by biannual review that happens every 2 years with the Department of DPH and the Dental Commissioner. So I would ask respectfully that that not be included in this bill because it's already being handled.
Excuse me, Ms. Garrity, but you've reached your 3 minutes. Thank you.
Why don't you complete your testimony, please?
Thank you. The last part of it is there's a piece in this legislation that would ask that there be a mandatory requirement on dentists to learn to be trained to handle patients that are in the IDD population. We already do this routinely. We have a mandatory that covers access to care. Dentists that are providing for this community are highly trained. It is not a 1 to 3 hour training. This is a very extensive training program that includes clinical expertise, specialized equipment, specialized techniques. So I would like to ask again that that be deferred to the existing process and that the content experts, being the commissioner and the dental commission, work collaboratively. If they identify a need, of course, we would embrace that. We have many wonderful providers in Connecticut that are already serving this population. We understand there need to be more of them, but there's other pathways to do that that are not training specific, but I can talk about those a little bit more extensively. A lot of the issue in this area falls to another committee, which would be Health and Human Services. So thank you for your time. I'm happy to take questions.
Yes, thank you so much. Representative Kristen McCarthy-Vahey, our co-chair, has a question.
Thank you, Senator Anwar, and thank you, Kathleen, for being here and for working with us. And also thanks to the dentists for going through the scope process. We really appreciate that as a committee, and thank you for referencing that and for sharing that it's 37 other states, which was actually one of my questions. So just to clarify two things, one, which is in the bill before us, and another, which is something we've talked about, and came up at the hearing, but is not in language right now. The continuing ed requirements, basically your ask is that both of these things, one that you want and one that you don't want, be allowed to go through the process as it is right now. Can you just walk us through a little bit about the mechanics of that process and how that works?
Sure. Under statute, there's 25 hours every 2 years that dentists are required to do of continuing education. Those are our requirements. Most dentists do actually hundreds of hours every year because they want to learn new techniques. They want to understand new possibilities and how to treat a certain type of patient that they're presented with. However, those mandatories are well thought out in terms of reviewing what our populations are here in Connecticut, what new techniques are out there, and what new pieces of information dentists need to be educated on. One of those mandatories is requiring dentists to learn how to treat patients with access to care issue. That could be a special population. It could be geriatric, pediatric, IDD, et cetera. But it could also mean just making sure that your office is accessible, that you have transportation ideas in terms of how to get people to you. So it's really well thought out. And that scope process, the review process happens every 2 years. And so DPH and the dental commission that's been set up review it, and they ask for our input, of course, but they also are looking at other stakeholders, including patients.
I'm interested in a little bit more specific. So about the review process, just that last part of what you said, which is every 2 years, there's a review process. So what happens? Is there a public meeting where the commissioner and the dental commission get together? Is it a conversation that they have? Just a little bit of detail about that process itself. That's what I'm interested in.
Of course, I would actually say that obviously the commissioner and the commission should be addressing that question, but I will tell you from my perspective on it and my participation through that 2-year process is kind of a living conversation that goes on where we identify gaps, where we identify new issues that are arising in the profession that I want to make sure both of those parties are aware of. And they're also hearing obviously from other stakeholders, including others on our oral healthcare team and the patients, and they come together and say, we've identified a gap, or we're identifying the language that's currently in those mandatories is not befitting what's going on in society. So it's an ongoing discussion. And at the end of it, they sit down, huddle, have their conversations that I'm not privy to, and make a decision and determination.
Okay, thank you. So fair point that we should ask them directly. The last thing is we had talked here among the committee, and we'd had some conversation about allowing, and there was a request from dentists specifically about allowing x-rays to be taken when a single practice dentist was not in the office. And I just wanted to give you a chance to comment on that.
Thank you very much. So right now under Connecticut law, in order for a dental assistant or anybody else on the team to be able to do an x-ray, they have to be well trained on it. A dentist can authorize an x-ray to be taken by a dental assistant if the dentist is there for direct supervision, meaning that they are in the space. Indirect supervision is probably more appropriate because that would mean the dentist is in the facility, they're in the building. But to advance it a little bit further, it probably should be overall supervision, that the dentist is the one that authorizes it to happen. Specific shoot of whatever it is. It's usually not a whole panorama. It's an issue where a patient comes in with an emergency. They want to see something very specific. Technology allows that dentist to be miles and miles away, get a picture on their phone or their tablet, identify it, and give some idea back whether there need to be emergency care or whether we should schedule an appointment for the next 24 hours to see you, and also whether antibiotics or other medications should be prescribed. So that particular piece of that specific statute probably does need to be updated just to evolve with technology and also access to care. If a patient is in your room, you want to get an x-ray, you want to treat them appropriately.
Thank you for that. And perhaps to evolve with what's happening in practice and the reality of what's happening in many offices. My teeth are hurting just having this conversation. So some of you know, I'm
a big fan of your dentist.
I'm a huge fan of my entire dental team. And I have not just a dentist, I have a number, but I certainly have learned a lot through my own personal experience and have a lot of empathy for what they are facing as well. So thank you for your testimony.
Thank you.
Thank you, Madam Co-Chair. Representative Claridis, teacher.
Thank you, Mr. Chair. Thank you for being here today. And I just have a few questions, some follow-up on the dentists doing injectables and neurotoxins. What is the how does the UConn School of Dentistry feel about the injections?
Well, I can't speak on behalf of UConn, of course, but I have had conversations with them. A lot of the UConn health team is already teaching these practices because, of course, their medical students can learn these practices. They're also teaching it to the dental students in the sense of doing pain management. So the transition from pain management to cosmetic, there is none really. So they are learning it, but they can't practically use those skills here in Connecticut. A lot of dentists that are taught in other schools are coming to Connecticut with the skill set, but they're unable to use it for cosmetic reasons. So if I had to hedge a guess, I would say that it's a little bit of a disadvantage to UConn at this point in time that our students can't come out with the robust education they get up there and use all their skills to a patient's needs and desires.
Right, thank you. And as of today in Connecticut, who can do injectables and neurotoxins?
Certainly MDs. So for instance, the plastic surgeons and the dermatologists, also non-doctoral professions such as APRNs, PAs, and RNs are able to do these injections. Some of them with oversight of a dentist, but an MD, but they're not usually on site when these injections are happening.
Okay, and then as a follow-up to that, as we know, neurotoxins and fillers are relatively new, 25 years or so. So if there was a doctor, an APRN, a PA, or an RN that's a little bit older and didn't learn these skills in school, med school or PA school or APRN, they would have to go back and take a course to learn how to do these, which is exactly what the dentists are asking to do. Is that correct?
Anytime there's a new procedure, that's what we would do in the dental profession. I won't speak for medical, but certainly anytime there's a new implant that comes out or a new way of providing therapy for our patients, we go to and do not just didactic, but also hands-on clinical observation, those sorts of things. So any type of new procedure, that's what we do. I mean, do no harm to your patient is what we live by.
Okay, thank you so much for your answers. Thank you, Mr. Chair.
Thank you.
Thank you. Thank you for being with us this entire morning and part of the afternoon. All the questions I had have been asked by my colleagues, so we're good.
Very good. Thank
Thank
you.
you. Thank you. With that, we're going to go back to Dr. Boris Goldman. Dr. Goldman, sorry about the wait. You came right at a tricky time, so we had already invited somebody else. So you're on. Welcome.
Thank you so much. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, Senator Somers, Representative Clarides Ditria, and the distinguished members of the Public Health Committee. My name is Dr. Boris Goldman. I'm a board-certified plastic surgeon and the current president of the Connecticut Society of Plastic Surgeons and the chief of plastic surgery at Norwalk Hospital. And I'm here today on behalf of the Connecticut Society of Plastic Surgeons, the Connecticut State Medical Society, and the Connecticut Dermatology and Dermatologic Surgery Society, literally representing thousands of physicians across our state to express our opposition to HB 5399. The provisions in this bill would allow dentists to administer cosmetic injections such as neurotoxins and dermal fillers, as you've heard. While these procedures are often perceived as simple cosmetic treatments, they are in fact medical procedures, and they carry significant risks when performed improperly. Under Connecticut law, the practice of dentistry is defined as the diagnosis, prevention, or treatment of conditions of the oral cavity, the jaws, and associated structures. The statute specifically excludes treatment of dermatologic conditions of the face and cosmetic procedures unrelated to the oral cavity. HB 5399 would expand dental scope well beyond these established boundaries. The face is one of the most anatomically complex regions of the body. A surgical or injection error of even just a few millimeters can cause catastrophic complications. An injection in the wrong location can puncture a blood vessel that connects to the back of the eye, resulting in immediate permanent blindness. In other cases, improper technique can cause tissue death, severe disfigurement, stroke, or nerve injury. There's also a risk of misidentifying a cancerous skin lesion and inadvertently injecting it rather than properly diagnosing it and then treating it appropriately. These complications are not theoretical. As a plastic surgeon, I routinely see patients referred to me after procedures performed elsewhere who require corrective surgery or procedures to repair significant damage. It's also important to understand the differences in training. Dentists complete 4 years of dental school following their undergraduate education. In contrast, plastic surgeons complete medical school followed by 7 to 10 years of intensive surgical training and accredited residency programs with extensive experience in full facial anatomy, complication management, and hospital-based patient care. Some dentists pursue additional medical education and surgical residency training in oral and maxillofacial surgery. And those individuals, after completing medical school and extensive surgical training, can obtain hospital privileges to perform advanced procedures. But that level of training is not stipulated in this bill. Allowing dentists without medical school and surgical residency training to perform cosmetic injections without clear limitations would lower the standard of care and put patients at risk. Additionally, dentists typically do not have hospital privileges, raising the question of who will manage serious complications when they occur. Let me be clear, we have tremendous respect for our dental colleagues and the important work they do treating diseases of the oral cavity and jaw. However, expanding the scope beyond the training that's without equivalent medical education and surgical experience raises serious patient safety concerns. For these reasons, on behalf of the Connecticut Society of Plastic Surgeons, the Connecticut State Medical Society, and the Connecticut Dermatology and Dermatologic Surgery Society, we respectfully urge the committee to oppose HB 5399. I thank you for your time and your consideration.
Thank you so much, Dr. Goldman, for your testimony. Dr. Goldman, I wanted to ask you a question. In this arena for the Botox and some of the other things, we have APRNs and physician assistants who are providing some of those treatments, and their training is much less than what a dentist goes through, and much more. The dental training is far more extensive, and especially around the part of the face, they're probably far more comfortable with that area. So help me understand that you have individuals with far less training. It's okay for them to do it, but another group you feel uncomfortable with. Could you share your thoughts?
Sure. Thank you for the question. I'm happy to address it. So the first thing is that there are health professionals with training that's not as comprehensive as dentists that do injections, for instance, PAs and nurses. However, they have to do injections under the supervision of a physician. Now, APRNs can practice independently, for instance, and APRNs, however, have to spend at least 2,000 hours in training as part of a care team model where they're specifically trained on how to do these types of procedures. The question is not whether or not our dental colleagues are skilled and whether or not they can perform injections. The question really is what defines their scope of practice. They certainly know the anatomy of the mouth and its adjacent structures in the jaw, but we aren't talking about treatment of bruxism, for instance, with a neuromodulator. That's painful biting or clenching of the jaw. We're talking about, with this bill, potentially injecting fillers and Botox anywhere on the body. I don't see limitations to the mouth or structures adjacent to the mouth. I was part of the work group last year with the Department of Public Health, where we discussed these issues along with other professionals representing other specialties. And it's almost unanimous where we felt uncomfortable with the request at that time. And at that time, the dentists were requesting the ability to increase their scope of practice to perform procedures basically from the clavicle to the top of the head and not limited to injections. So we have to understand what this is, which is a stepping stone. And if we're going to do that, there needs to be clear limitations on what these fillers and neuromodulators are going to be used for. Currently, there is no such stipulation in the way that this current legislation is written. And that's our objection.
Thank you. That helps me understand this better. So if it was limited to the area, the facial area, that was part of the initial conversation, then you and the group of physicians you're representing today, they would be more comfortable if we move forward in that direction?
I believe that if there were limitations on the request, that we would certainly have to go back and discuss this, depending on what limitations were placed on this. But yes, I believe that right now there is no limitation on where these injections are going to be performed. It doesn't limit it to the masseter muscle. It doesn't limit it to diseases associated with the mouth or mastication. So yeah, I think that's a fair statement, Senator Arnold.
Okay, thank you. Representative Claire Teacher has a question as well. Thank you.
Thank you, Mr. Chair. Thank you for being here virtually today. So you stated you don't have an issue with RNs, PAs, or APRNs injecting, but dentists who that's their background. They have extensive education on the face only. I'm just not understanding why this is an issue. And they went through scope of practice review and there weren't any issues from any of the other disciplines.
Let me address each of those questions in turn. So the first is, it's not that we don't have an issue with RNs or PAs injecting. Those injectors have to be supervised by physicians. Dentists would not have to be supervised by physicians. APRNs do inject, but after 2,000 hours in a care team model, learning how to perform procedures like this before they can go out and inject independently. And the next part of this is that dentists are trained and they are experts in the anatomy of the mouth, not necessarily the face or the head or other parts of the body. In order to become an expert in anatomy of the face or the periorbital region or the head or the neck, these people would have to go back, these professionals, these DMD or DDS professionals would have to go back, complete an additional 2 years of medical school, or go on and complete an oral maxillofacial residency in order to obtain the type of expertise in anatomy that surgeons and other physicians like us have. And I was part of the work group last year, and there were objections. So I'm not sure if we're talking about the same scope of practice review, Representative Clarity's Ditria, but I was part of that work group, and there were lots of objections to the scope of practice increase.
Okay, thank you for your testimony here. Thank you, Mr. Chair.
Thank you.
Thank you. This is very helpful. We appreciate you waiting and testifying. Seeing no other questions and comments, we'll move to the next person who is online, Diane Santos. Thank you, Ms. Santos. You're on. Welcome.
Hi, good afternoon. Can you hear me okay?
Very well.
Okay, thank you. Co-Chair Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Diane Santos, and I fully support Senate Bill 365, an act establishing a bridge program for emergency treatment of opioid use disorder, because it could have literally saved my child's life. The evening of December 28th, 2023, my son, Mark, sought help for his opioid use disorder at the Bacchus Hospital emergency room. He'd been given an appointment to start outpatient medically assisted treatment with buprenorphine for 2 weeks out, and there was no way he could be abstinent for that long. I was terrified of losing him. Mark was honest, telling the ER triage nurse he had last used fentanyl earlier that morning and wanted to stop. He kept nodding off, and the nurse told me she was concerned about that, but seeking treatment for opioid use disorder was no reason for a hospital stay. Their protocol was to have a recovery coach come from an outside agency to speak with Mark about his options. After about 90 minutes, the coach arrived. He handed us an access line number to call the next day, then told us we could stay there if we wanted to, but the doctor would only send us home because, in his words, hospitals are not detox facilities. The nurse and the coach made it clear that Mark would get no help there, so we left. 36 hours later, I found my 26-year-old son crouched in a corner on his bedroom floor. His body was stiff and cold to the touch, something no parent should ever have to see. That ER visit was our tiny window to save Mark's life, but it was slammed shut by protocols that create deadly gaps in care. Imagine the outcome if Mark was given a dose of buprenorphine in the ER, then sent home with a few doses and a warm handoff to follow-up care. Exactly what this bill proposes. He might still be here with us today. There is no tomorrow for someone using opioids in today's toxic supply. Treatment has to be immediate in the moment that it's asked for. SB 365 will make this a reality. Our tragic story clearly shows the dire need for this bridge program to become Connecticut law. I work at Bacchus Hospital. 2 weeks after Mark's overdose death, I returned to the place that didn't help us, determined to be part of closing this gap. Hartford Healthcare has invited me into their conversation on this subject because they recognize the need to do more. Passing this bill will make a life and death difference for someone who is ready to get their life back, the way my Marky was. Please, please vote yes for SB 365 and give families what ours was denied, the chance to heal and remain whole. Thank you.
Thank you so much, Ms. Santos, for your testimony. You are my hero because you relive your pain to make sure nobody else has to experience that. And thank you for highlighting the fact that if this bill had passed in 2022, this was never brought before, but had this bill been brought before and had passed, Mark would be here with us, and so many more. I think part of the issue that this bill would address is that right now the access remains a big problem, and individuals who are willing and are interested to get to rehab, the doors aren't that easily available. And then this is exactly the part. Do you want to add anything else?
I will add, Senator Anwar, that I will be speaking on May 19th at Hartford Hospital, as I do work for Hartford Healthcare, but as the parent of someone who we lost tragically because he wasn't helped in the emergency room. I will be the keynote speaker. Dr. Jason Wang, who's an addiction medicine doctor, has invited me. It's a program where they're looking to close the gaps in hospital-based care for people with substance use disorder. So they caught wind of our emergency room experience at Bacchus, and they would really like to hear my story and hopefully allow Mark's story to not happen to anyone else.
Thank you. I want you to know Dr. Wang is here as well, and he's been very helpful with the bill too. So thank you for your good work. With that, I do not see any questions or comments. Thank you again, Ms. Santos. Thank you for your work that you do and your advocacy. Thank you.
Thank you, Senator. Thank you.
Thank you. That brings us to the next person on our list, which is Carson Ferreira, who's here in person. Welcome, Carson.
Hello, everyone. Good to be back. My name is Carson Ferrara, and I'm the hospital liaison for the Community and Law Enforcement for Addiction Recovery Initiative with Liberation Programs, where I work with people at highest risk of overdose in Fairfield County. I'm also a recent graduate of the Yale School of Public Health, where my work centered on medications for substance use treatment and overdose prevention. And today I'm testifying primarily based on my experiences as a research assistant at Yale during grad school on the largest randomized clinical trial to date, looking at the effectiveness of long-acting injectable buprenorphine versus sublingual, an emergency initiated in the emergency department. That work helped inform my desire to pursue a career long-term as an addiction medicine physician. And so I'm very passionate about this issue and here today to testify in support of SB 365 with some suggested amendments. So the research is clear that starting MOUD in the ED and connecting people to follow-up care leads to them being more likely to stay in treatment and less likely to die. And many of the people that I work with use the ED as their usual source of care. So being able to treat withdrawal and craving in real time and then bridge them to ongoing care is often the difference between seeing someone alive again or perhaps hearing from a family member that they overdosed and passed after being discharged. As such, I strongly support the intent of the bill and urge you to strengthen it with a few key ways that align with the evidence and with recommendations you'll hear from addiction medicine folks later today. So first, the bill should explicitly include both buprenorphine and methadone. Those are the two gold standard medications for OUD, and clinicians need the flexibility to offer the right medication for each patient, especially in the fentanyl era. Second, starting medication in the ED is only half of the bridge. The other half is making sure that patients get to the other side after being discharged. So for buprenorphine, that means requiring an adequate bridge prescription at discharge so that patients don't run out of meds before they can attend an outpatient appointment afterwards. And then for methadone, that means a clear pathway to an opioid treatment program the next day, ideally, including a last dose letter so dosing can continue seamlessly. And a discharge prescription for a day or two or a vague referral with no confirmed follow-up isn't really a meaningful bridge for someone living with OUD. Third, the bill's definition of referral destination should be broadened. So as written right now, treatment programs are limited to those operated by DEMIS, which excludes many office-based and community providers. So primary care, psychiatry, addiction medicine practices, and telehealth practices, who routinely and safely prescribe buprenorphine and can often see patients sooner than traditional programs. So ED should be able to refer to both DEMIS programs and then also community providers. Also, hospitals need to train and support ED staff to do this work, including access to addiction specialists when needed. And the bill, of course, should preserve clinical judgment so medications are used when clinically appropriate and with patient consent. Later today, you'll hear from physicians who have dedicated their careers to building the evidence base for ED-initiated treatment and to implementing it here in Connecticut, including Dr. Gail D'Onofrio, who was my principal investigator on the trial I worked on. And who's
Excuse me, Mr. Farrar, your 3 minutes is up. Thank you.
Thank you. So just in wrapping up, I urge you to pass SB 365 with these amendments so that no matter which ED someone with OUD walks into in our state, they're offered not just survival and withdrawal management, but a real path to treatment and recovery.
Thank you so much, Mr. Ferrara, for your testimony. I wanted to ask you, is the work that you're doing, is that published now?
Yeah, it was published on February 11th in JAMA. It was a trial looking at 29 emergency departments across the country. And the focus of the study was looking at which formulation of buprenorphine led to better outcomes 7 days and 30 days post-discharge. And there was no significant difference in that, but it does highlight that still ED-initiated buprenorphine as a whole leads to better outcomes and more linkages to treatment, things like that.
So so there's a long-acting version that goes up to 30 days?
Yes, I believe so. There is.
So if a community has far less access for formal rehab facility, perhaps that kind of a treatment may be better in an emergency. I'm just extrapolating that.
Yeah, no, I mean, that's what I thought too. And anecdotally, within the RCT, which was across multiple different settings and hospitals, there was no significant difference in treatment engagement compared to like sublingual form of buprenorphine. But I still think it's great to give that options to patients, especially for those who, as you highlighted, might have coverage gaps or.
And we'll have these conversations later with other clinicians who are doing this, but there's no special training outside of the actual training that the physician and the ED doctors receive. That's part of it, that they would just provide the medicine and give them a prescription perhaps and be able to give them Narcan and guide them to a place to go to. This is like a common sense thing, but.
Yeah, absolutely. I think the idea and your point of bringing this bill up was just to kind of make it standard of care that medications for opioid use disorder are offered in emergency departments. I know that they have been for a while in the Yale system just because that's where I worked, but it's incongruent across the state. And, some people may bring up the issue of like provider burnout and being pulled in many different ways. But if you think about it, being able to initiate them on the medication before they're discharged and knowing that it provides better outcomes once they are released will likely reduce return ED visits and things like that. So I think it should be standard of care across the state.
Now, you've not submitted a written testimony this time yet.
I was working on it before I came up here, but it's submitted now and should populate in a day.
Okay, good. This will, and you have outlined some of the suggested changes in there?
Yeah, absolutely.
Okay, and I've received a letter from Dr. Wang as well. We'll address all of that.
Yes.
Good. This is very helpful. Seeing no questions or comments, I wanted to thank you for being physically here and your testimony and your work.
Thanks, Senator Anwar.
Thank you.
Thank you.
All right, we move to the next person on our list, which is Kaylin Crawford. I just want to make sure. I think she's not there. Trisha Pitter. Ms. Pitter, welcome.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Trisha Pitter, and I'm a resident of West Hartford. I am here today in strong support of HB 5389. I have also submitted written testimony with additional detail. In my mid-40s, I was medically induced into menopause following surgery. I was told I would enter perimenopause, but no one prepared me for what that would actually mean. Soon after, I began experiencing intense hot flashes, anxiety, insomnia, and brain fog. It felt like my body and my mind were changing all at once, and I could not keep up. When I sought care, I was told it was not menopause because I was not having night sweats and because this was considered a natural progression. Instead, I was prescribed anxiety medication and referred for a sleep study. I left those appointments questioning myself. Similar to what Erica shared from She Leads Justice, I felt dismissed. And I also felt alone. And I wondered if I was somehow losing control of my health. So I did what too many women are forced to do. I became my own medical researcher. I read, asked questions, talked to other women, and returned to my doctor ready to advocate for myself. Only then was I prescribed an estrogen patch, which dramatically improved my symptoms and restored my quality of life to the best of its ability. That delay in recognition and treatment prolonged my suffering unnecessarily. But no one should have to become their own medical expert to navigate a universal life stage. What stays with me most is this: in doctors' offices with specialists and even in the ER during triage, I was routinely asked if I might be pregnant, but nobody asked if I might be in perimenopause or menopause. Pregnancy is routinely considered in care. Menopause, which affects half the population, remains largely invisible. Every day, approximately 6,000 women in the US enter menopause, yet too few clinicians feel adequately prepared to care for menopausal patients. When they are not prepared, symptoms are often misattributed, minimized, or dismissed. Menopause affects far more than hot flashes. It can affect mental health, sleep, oral health, bone health, cardiovascular health, skin and eye health, and problems, and probably others that are not even documented. Yet too many patients are left to connect the dots on their own. As a Black woman, this is personal. Black and Hispanic women often experience more severe symptoms and longer duration, and gaps in care deepen disparities. HB 5389 offers a practical solution, a statewide provider toolkit to improve menopause care across the healthcare workforce. And when paired with SB 353, which addresses workplace accommodation, this creates a coordinated approach. When menopause is not recognized or treated appropriately, people may also struggle to access the support they need at work. Better provider education equals earlier recognition, more appropriate treatment, and less dismissal. I have a teenage daughter. I want her generation to enter midlife knowing their healthcare system will be prepared, not confused, and responsive and not dismissive. Thank you, Representative Representative Kai Belton, for championing menopause equity in Connecticut. I respectfully urge you to pass HB 5389. Thank you for the opportunity to testify and share my personal story.
Thank you so much, Ms. Pitter, for your testimony. And I see in the back you have Menopause Equity for All. Is that an organization or is it just a statement?
It is a statement by me. I feel menopause equity should be a right, is something that we deserve. I felt like I needed to make a statement, right? Menopause equity for all.
You're a very powerful advocate. Your testimony was very powerful and within the time, and the visuals are within the time. I love it. It's very, very helpful. I know Representative Belton has a comment for you or question.
I want to thank you for your testimony, Trisha. And we've heard a few times today how women go in for go to their healthcare provider and they're dismissed. So I really appreciate you telling your story. And I wanted to know if you could possibly send me that background, because in every meeting I'm in, I would love for it to be back there. Thank you for your
Absolutely.
testimony.
Thank you all. Thank you, committee.
Thank you. Seeing no other comments or questions, thank you again, and we'll move to the next person on our list, which is, I want to make sure, Jade Thomas. Welcome. Thank you for being here in person, and thank you for spending your morning and afternoon with us.
Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Jay Thomas, and I work as a community engagement and public policy specialist at the YWCA Hartford region, a nonprofit which has served the greater Hartford region for more than 158 years. The organization provides critical programs to the surrounding community, including emergency shelter and affordable housing, career training, and youth leadership development. In addition to operating early learning centers and before and after school care for students in grades K through 5 across central Connecticut. I am offering testimony in support of HB 5389, an act concerning a provider toolkit for the diagnosis and treatment of menopause, perimenopause, and postmenopause. The YWCA Hartford region stands in strong support of HB 5389. This bill would require the development and distribution of a statewide provider toolkit to help healthcare professionals better diagnose and treat menopause, perimenopause, and postmenopause. The toolkit would provide practical, evidence-based, and culturally appropriate guidance for providers across multiple fields, including primary care, obstetrics, gynecology, psychiatry, and others, with the goal of better equipping providers to reduce misdiagnosis, dismissal, and unnecessary emergency room visits. For too long, menopause has been under-recognized in healthcare settings. Many patients experience years of symptoms before receiving accurate information, diagnosis, or treatment. A statewide provider toolkit would help close these gaps by providing healthcare professionals with current clinical guidance and continuing education resources. In a 2023 study of obstetrics and gynecology resident programs directors, 90% responded that residents should have access to a standard menopause curriculum. Despite broad support, only a third reported that their programs offered one. A concerning discovery, given that knowledge practice deficits leave healthcare providers unprepared to adequately address and treat menopause concerns. Addressing the ongoing menopause and training education gap is a matter of equity. First, the lack of awareness creates disparities in care for a significant part of the population. This discrepancy threatens the quality of life of our mothers, sisters, and friends. Second, menopausal transition, including frequency and severity of symptoms, can differ across races, with studies showing that Black women tend to experience transition earlier than other races. For example, it is reported that anywhere between 75 to 85% of women experience hot flashes during menopause. However, researchers have discovered that Black women are more likely to experience intense and more frequent hot flashes. They were also less likely to receive treatment for vasomotor symptoms like hot flashes and night sweats. Ensuring that providers receive comprehensive, equity-informed education will help reduce delayed diagnosis, improve access to treatment, and ensure that all patients, regardless of race, language, income, or geography, receive evidence-based, compassionate menopause care.
Excuse me, Ms. Thomas, but your time has expired. Thank you.
Thank you. I would just like to acknowledge that several states have proposed laws establishing continuing medical education or supporting training to ensure healthcare providers have the necessary menopause-related education. I would like to thank Representative Kai Belton for championing menopause equity in Connecticut and for advancing a thoughtful, forward-looking public health approach. I appreciate the opportunity to offer testimony. I respectfully urge the committee to pass HB 5389 favorably, and I'd be happy to answer any questions.
Thank you so much for your testimony. Would you be able to share what other states have done? You touched on it towards the end.
Yes, absolutely. So California, Maine, there's a longer list, however, of states. Let me see if I can pull this. California, New Jersey, Illinois, Arizona, Maine, Texas are some of the states that have introduced legislation aimed at either supporting continuing medical education or some type of additional training or education like a toolkit that I'm aware of.
Okay, so there have been toolkits in other states as well?
Yes. I'd be happy to provide more information on specific states. I'd be able to follow up with the committee. I just don't want to misspeak and share which states specifically have proposed a toolkit.
Okay, but I just wanted to thank you for your advocacy work and for being here in person as well. I just want to make sure if anybody has any question or comments, and I want to confirm nobody on Zoom has it either. Seeing none, thank you so much for your testimony. We appreciate you being here and your work.
Thank you.
With that, let me see. The next person on our list is Sean Gramelli is not here, and Brian Donahue is not here, and Elise Courtois. You're on. Welcome.
Hello.
Hi.
Good afternoon, Senator Enward, Representative McCarthy-Vehy, Senator Summers, Representative Clatrides Ditria, and distinguished members of the Public Health Committee. My name is Elise Courtois. I'm an assistant professor and director of a single-cell biology lab at the Jackson Lab in Farmington. I'm also the very proud director of the Endorise, which is Connecticut Endometriosis Research, Innovation, Support, and Education Initiative. So on behalf of myself and the Endorise co-director, Dr. Danielle Luciano from Yukon Health, I'd like to express our sincere appreciation for the opportunity to testify in support to House Bill 5322, an act concerning an endometriosis, a working group regarding endometriosis. So it is very fitting that this bill is being heard now in March, which is Endometriosis Awareness Month, a time that is dedicated to shine light on a disease that affects 1 in 10 female-born individuals. And yet it has been historically under-recognized and underfunded. This week also marks an important milestone for Connecticut. Just on Monday, we joined the Connecticut Endometriosis Working Group to celebrate the first distribution of samples from the state endometriosis data and biorepository to a therapeutic partner. And this milestone represents the realization of a legislature original vision, creating a program that accelerates the discovery of new diagnostics and treatment for this disease. Since its launch, the biorepository has already collected more than 5,000 biospecimens for participants across 58 towns in Connecticut. And those samples are linked to clinical data and being used now to support research. And the Endometriosis Working Group played a central role in shaping this progress. It championed the original policy recommendation that led to the creation of this endometriosis data and biorepository program. That legislation established the most comprehensive state-led endometriosis initiative in the country and really positioned Connecticut as a national leader in women's health innovation. So most importantly, the Endometriosis Working Group has continued to serve as a critical forum that brings together policymakers with clinicians, researchers, patients, advocates, to ensure that we bring legislative initiatives and we can translate them into real progress for research, awareness, treatment, but also education. So House Bill 5322 is therefore not symbolic. It really ensures that this collaborative infrastructure continues to function and evolve. And to be effective, we recommend that the formally established Endometriosis Working Group maintains a broad and representative membership, including legislators, state agencies, physicians, hospital and community health centers, researchers, biorepository leaders, and therapeutic developers, as well as patient advocates and representatives of the historically underserved populations. Maintaining this coordinated structure is essential to preserve the stakeholder engagement and to guide future policies and priorities. And will ensure the continued progress in taking care of endometriosis across the state. And this is an exciting moment for Connecticut, for the more than 80,000 residents in our state that live with this chronic inflammatory and very debilitating disease. For decades, research in endometriosis has been limited with insufficient funding and lack of prioritization.
Excuse me, Professor, but I'm sorry, but your time has expired. Thank you.
I will just finish with this unique sentence.
Yes,
So by
please go ahead
supporting
and complete what you're saying.
The legislature will protect and strengthen the infrastructure that has already begun to transform how endometriosis is addressed in Connecticut and in the country. And Connecticut will continue to serve as a national model for this policy for a disease that has been historically neglected and women's health in general. Thank you so much for your support.
Thank you for your testimony. Thank you for the work that you do. I just want to make sure Representative Gilchrist has a comment or a question. Didn't want to put you on a spot, but go ahead.
Thanking Dr. Courtois for being here and for her participation and work in the endometriosis field. Thank you so much. Thank you, Mr. Chair.
Thank you. Dr. Courtois, I just wanted to clarify, with the work that you guys have initiated, and there was some seed money from the state, and our hope has been that we'll be able to get some NIH grants. What is the status at the national level for NIH grants around some of these areas or any area right now?
So as we know, endometriosis is not a strong priority for the research at the NIH level, but things are turning. So we are getting more and more requests for biospecimens from the biorepository to be part of grant application and proposal. So we really hope that this will lead to some NIH and Department of Defense funding for in supporting the research on endometriosis. And I will have to say that we are a unique partner in those applications because of this biorepository.
Good. Okay. Thank you for your good work. I see no other questions or comments. We appreciate you being here, and we'll reach out again later if you have a question. Next person on our list is number 30. I just want to make sure you're not here. Tricia Cunningham, and you're not. And next 31 is Fiona Ferreen. Mrs. Ferreen, welcome. You're on. Fiona? Sometimes our audio doesn't work. I want to make there. You're there.
Can you hear me? Yeah, can you hear me now? All right, hold
Yes,
on
we
one
can hear
second.
you.
All right, just took me a minute to connect. Good afternoon, chairpersons and members of the Public Health Committee. As you know, my name is Fiona Cullinan Farine, and I'm one of the founders of For Cameron, an organization we began after losing our son and brother Cameron to a fentanyl poisoning when he unknowingly took a counterfeit pill. I'm here in strong support of SB 365. Through our experience with Cameron, we learned how difficult it can be for people in crisis to access help for substance use disorder in our hospital emergency departments. Too often, patients are told they do not meet admission criteria and are discharged with nothing more than a list of phone number and resources. This leaves people without guidance at the moment they need support the most. Raised Senate Bill 365 addresses this gap. It requires hospitals to provide buprenorphine, even if patients do not meet admission criteria. It supplies naloxone at discharge and makes direct referrals to local treatment programs. Providing this medication reveals the severe symptoms of withdrawal. Without it, patients often experience extreme illness and return to using opioids, not for recreation, but out of urgent need to relieve suffering. Perhaps if Cameron had had access when his cravings returned that weekend, he would not have felt he needed to seek what he thought was a prescribed OxyContin, and it was actually a counterfeit pill. I'm dedicating my testimony to Nathan Jaquette and Mark Andrew Collins. Both sought help at emergency departments when they tried to address a disease consuming them. Their pleas and the pleas of their parents were met with a system that simply sent them back through a revolving door. The parents have bravely testified here many times. Nathan's dad testified in support of this measure in 2022, and you heard from Mark Andrew Collins' mother just a few moments ago. Bridges are a crucial part of our infrastructure. This bridge, SB 365, closes a deadly gap. Strengthening this emergency and follow-up care pathway saves lives and provides families with real and practical support. I want to say, because I come before you so often, I appreciate the work that each of you do and that you care about the lives and the well-being of Connecticut residents. It's always an honor to testify before you, and I know that working together, we could save more lives from dying needlessly. Thank you.
Thank you, Fiona.
Welcome.
Like I was saying earlier to Diane, and you're my hero too, because you stand up for Cameron and you stand up for everybody else, and then you relive the pain just to make sure that no other mother or other family members have to deal with this. So I want to thank you for this. And did I hear you correctly that it had this bill passed some time ago, this would have helped Cameron?
If it had been passed, Cameron died in 2018, Senator, so I don't want to misrepresent that. But if
No.
this bill had been in place in 2018, it absolutely would have helped Cameron because he encountered sort of an anxiety, mental health crisis on the weekend he died. And if he had been able to access this medication, I have no doubt that's what he would have done. He was very actively involved in therapy and in working to achieve recovery. And instead, what he did is he took what he thought was an OxyContin from somebody he knew. He did not know it was not a prescribed OxyContin. And he called his therapist and left a message that he was relapsing and that he would need to speak with her first thing Monday morning. But Monday morning didn't come from Cameron. So I think these measures that are in this bill would save lives in real time.
Thank you. Thank you so much for your testimony, and thank you for the work you do.
Thank
Seeing no
you,
other
Senator.
questions or comments, we'll move to the next person. I want to make sure, Monica Shoham, welcome. Thank you for being with us all day.
Can you hear me? I submitted longer testimony online. This is trying to fit this all in under 3 minutes, really hard. So distinguished chairpersons and members of Public Health Committee, my name is Monica Shoham, and I'm a resident of Wethersfield, Connecticut. I'm testifying in support of Bill 5389. I'm 51 years old, and I have been in perimenopause for several years. Exactly how long, I cannot say, because I did not recognize my symptoms for what they were. No one told me they could be related to perimenopause, not even my doctor. Looking back, my symptoms clearly align with what many women experience, yet the only things my OBGYN asked about were hot flashes, night sweats, and irregular periods. For many of us, the reality is far more complex. My first symptoms was depression, something I had never experienced before. Nothing in my life had changed. I had a good job and a healthy family, but suddenly I felt persistently sad and disconnected. When I asked for help, I was offered antidepressants. Then came severe brain fog, crushing fatigue, and worsening sleep. I began waking at 3 a.m. almost every night with intense anxiety and a sense of impending doom. My memory and focus declined. I would forget groceries in my trunk until they spoiled. Those were frightening signs that something was wrong. At age 49, I was diagnosed with osteoporosis after an early bone scan. Many women cannot access the screening until age 50 or later. Yet we know bone loss can begin after age 40 as estrogen declines. Too often we diagnose osteoporosis only after a fracture, when prevention opportunities have already been missed. I also experienced painful mouth sores that were resolved only after starting hormone replacement therapy. A connection no provider had made. I did it myself. These experiences are not rare. They are under-recognized, including long-term health risks, which are significant. I am sharing my story because I, like many women, feel deeply failed by the current system, by providers and insurance companies. More than half of the US population is female. Every single woman who lives long enough will go through perimenopause, menopause, and postmenopause. Each year, nearly 2 million women in the United States enter menopause. Thousands of them are here in Connecticut, working, caregiving, leading businesses, supporting families, and contributing to our economy. Yet many are doing so while exhausted, anxious, sleep-deprived, medically underserved. While midlife women's health suffers, workplace productivity declines, healthcare costs rise, families feel the impact, preventable conditions go untreated. Women in their 40s, 50s, 60s, and beyond are at the height of their professional and personal contributions. We deserve a healthcare system that recognizes our biology, listens to our symptoms, and acts early enough to protect our long-term health. Right now, too many of us are being left to figure this out alone. Thank you.
Thank you for your testimony. Yes, you did it, and you did it within the 3 minutes, but very powerful testimony, I must say. And
thank you. I was feeling emotional a little bit by
No, it's very important because your testimonies help us have the authenticity to fight for your bill, the issue that's going to be relevant to you. And then that's why you're physically coming here or virtually coming here and sharing your perspective is important for everybody to hear. Not only the ones who are in this committee, but people who are listening outside of this committee, they would recognize. And I'm sure today we have some bills. There will be a lot of clinicians who are seeing because of some of the other bills. They will recognize the value of perhaps as a medical profession doing better. And then this is your words, your experience, your sharing, your perspective is very helpful. I know my co-chair had to step out, and she specifically asked me to please thank her for her very powerful testimony. Do you have a comment? Yes, Representative Belton has a question for you.
I don't have a question. I do have a comment. I want to say thank you for being here today and sharing your testimony. I think that is incredibly important. One of the things that, I've been talking about with women across the state is the fact that for so long, no one was talking about this. No one was talking about it. And we were all just suffering, mothers suffering, my grandmother was suffering. And finally, people are talking about it, and we want to see things change for us, and we have the power to do it. So thank you for coming here and sharing your story. We appreciate it.
Yes, thank you so much. I really appreciate you saying this. This is very important for me. That's why I wanted to be here in person. As my previous speakers, I agree with all of them. We feel not heard. It's unheard of that you go to your doctor and they think you're crazy and they don't believe you. So it's been a long road, and I'm sure there is a lot of women that are still struggling in silence. So thank you so much. I really appreciate this.
Thank you. Thank you. Dziękuję.
Proszę.
All right. Next is Michael Biondi. Dr. Biondi, you're on.
Terrific. Can you hear me?
Very well.
Very good. Thank you so much for this opportunity. My name, again, is Michael Biondi. I'm a physician, radiologist, and current president of the Radiology Society of Connecticut. I'm not going to rehash our concerns we have with Bill 5045, because I believe my two colleagues were on earlier and did a fantastic job. I will answer your question, Senator, as regards to private equity. I think the damage for radiology is probably done at this point. I think they're done with us as a group, but that doesn't mean some of the other areas of medicine aren't at risk. The dentists, the dermatologists, the pulmonologists, the any other group. And I think seeing what happened with us, that hopefully that something can be done for them, because we definitely don't want to go through the whole medical field. In any case, if you have any questions for me, for the society, for Linda, for my colleagues, reach out at any point. We'd be happy to answer them. Thank you.
Thank you. I think with the governor's bill, there are a number of components, but I think the existing CON program and the current recommendations, they are pretty much the same as before. So what the radiologist perspective is, do not touch it.
That would be it, yes. And then to keep with the changes that are there, to keep the open dialogue so that people could come in and give testimony and see what's going on.
Yeah, this is very helpful. And I think for the private practices, it has actually changed the actual suggested thing, but that's what some of the clinicians are coming and speaking about their part, which may not necessarily impact the radiologist as much, except that sometimes a small radiology practice, which there aren't any anymore. So that will
No.
not be impacted. Yeah. I think this is the challenge because of technology and the needs for the technology. You don't have a choice but to be in larger groups and in the lifestyle component of being available 24/7. So
Couldn't agree more.
yeah. Well, thank you for your testimony. We appreciate you not spending the entire 3 minutes.
Have a good night. I appreciate it. Thank you very much.
Thank you. The next person on our list is Daniel Fitzmaurice. Welcome. How are you?
Great. How are you all?
Excellent. Welcome.
My name is Daniel Fitzmaurice. I'm the Director of Advocacy at United Way of Connecticut. Thanks for the opportunity to testify in support of Senate Bill 364, an act concerning extreme weather protocols. 211 Connecticut has been a vital public-private partnership with the state of Connecticut and United Way since 1976. Today, 50 years later, we leverage state-of-the-art technology that exceeds industry standards and are recognized as one of the most robust 211 contact centers in the nation. 211 is available by phone or online at 211ct.org. It's confidential, free, and available 24/7, 365 days a year, and in 180 languages. When you call 211, a trained contact center specialist listens and connects you to resources and benefits that match your needs. They also offer empathetic, comprehensive guidance to navigate the urgent, complex challenges you're facing, even beyond what your initial request was. One of our distinct services is the 211 Housing Crisis Hotline. This is Connecticut's coordinated access point for people who need emergency shelter. During extreme weather, this system expands to become the frontline response operation. We coordinate with the State Emergency Operations Center, municipalities, and community organizations to maintain real-time listings of cooling and warming centers. During severe cold weather protocols specifically, we go a little bit further, assessing vulnerability, arranging transportation, and taking whatever additional steps are necessary to make sure everyone who calls 211 gets safely inside. And the activation trigger for the extreme cold weather protocol is 1 or more days or nights with temperatures or wind chill in the single digits. The data that I provided in my written testimony explains why this matters. Since 2015, Connecticut has activated severe weather protocols 55 times for a total of 259 days. Our team has handled nearly 23,000 calls during those activations. Activation days and call volume have remained significantly higher in recent years. Extreme weather is happening more frequently and lasting longer, and stable housing options are growing more and more scarce. Our response systems right now reflect that reality. That's why we support Senate Bill 364's goal to improve safety, strengthen coordination, and reduce confusion. But please know that extreme weather activation triggers a resource-intensive response. This bill must be paired with adequate, sustained investment to fully deliver on its intent. United Way and 211 Connecticut stand ready to continue and always serving as Connecticut's central hub for information and coordination during extreme weather. We urge you to support the bill and the resources needed to implement it. Thank you.
Thank you so much for your testimony and the work that you're doing. Can I clarify some things?
Yes.
On a regular day, what happens to people who are home insecure for 211 at 5:15 p.m.?
So specifically, if they're calling 211 for the housing crisis hotline at an ordinary day,
yes,
it's not a severe cold weather activation.
Correct.
They're connected with our contact center specialists who arrange for they assess them based on what their needs are, but it's going towards the coordinated access network for emergency shelter.
So even after 5 o'clock, there is a pathway for people to do, because my understanding is after 5 o'clock, there's no particular action can be taken on a regular day, not on an extreme weather protocol day.
Yeah, our hours are we're not 24/7 on the housing crisis hotline anymore. It goes until 6. Sorry, I don't mean to pick on your nuance, but
okay, yeah,
Monday through Friday.
It's a 6 o'clock. So
yeah,
okay, so good. I'm a few minutes short. So 6:15. What would happen at 6:15 then?
At that, they can still talk to a contact center specialist in our information referral hotline, but they're not able to organize an appointment at the CAN.
Right. Okay, and then if there is a protocol initiated, what happens then?
So then we have a dedicated team that actually handles the response time on the phone because it's an emergency. So we have dedicated staff that are responding to cold weather activations specifically. So again, assessing them for what their needs are, arranging the transportation to a warming center if needed, or some kind of emergency response. And we do that, of course, in coordination with the municipalities and the local providers in the coordinated access network too.
So do you have numbers for the days when the protocol is initiated, what happens and how many phone calls we get?
Yeah, sure. I mean, I have, I put it together in a consolidated way, but I can get you the details on, here's a typical day and how many calls we get. But, to date, this year was more than about 7,000 calls.
But that evening and that night, how many calls are you guys getting? So let's say
during cold weather activation, it's 24 hours until at least the activation ends, which is determined by the protocol.
So in one day, how many calls approximately?
I don't have it in front of me, but it's a lot of calls.
It's a lot of
to get, again, this year we've done 63 days, 7,000 calls.
Yeah. So and the timeliness of the decision is critical. And you're nodding your head. So just for the people who are not, if you want to say yes, you can.
Yes, absolutely. It's
okay,
critical.
good. And the reason is when you say yes, the computer and everybody gets to see you and the people. And what that does is that allows you to get the resources, but you have a whole machinery in place. This machinery, when it was created many, many years ago, was the best in the country. And everybody used our formula to say this is what Connecticut gets it, and they're doing a good job. But then, and I use this example that we made the best car, and then we did not put, well, nowadays electric car, we never charged it. And then you say the car doesn't run. You say, well, you're not charging the car. So everybody else has made the car, seeing our car, they charge it and they're using it and it's working. But we refuse to charge it. And then you say our car doesn't drive. And he said, let's get another car, figure this out. And that's part of the frustration at times for people who have followed this issue for quite some time is that we created a system, then we it, and the system doesn't work, and the needs of the people are increasing. And those are not because of 211. You are actually part of the pathway for emergent solution, not a permanent solution. But collectively, what we have done is we have not been able to address the needs for a long time. So the challenge has exploded. It's out of control. And for state policies, federal policies, society policies, and social issues that we are dealing with is a combination of a perfect storm. And then we are really not dealing with that. And as a result, you are in the midst of that storm. And then when things don't work out, we say, okay, 211, we're going to blame you. But the 211 is not getting the resources at the timely fashion and not have the personnel. But even if you pick up the phone, you don't have a solution on the other side. So we again say 211, it's your fault, you can't get me the home. So I empathize with your stresses and the challenges that your entire agency has to deal with. But I know that you're also recognizing the symptom of the larger problem. And there should be an opportunity to share collectively broader policymakers that this is out of control calls. We have never seen this. We have a disaster that's going on and we need to intervene far more than what we are doing right now. So I wanted to share some of these thoughts and first appreciate you coming here, appreciate the work you guys are doing, but also highlight the fact that you need timely information so that we can be better prepared and not do this after the fact.
That's right, Senator Anwar. And if I might just, again, I said it in the testimony, but just so folks know, the standing protocol right now is one or more days of temperatures or wind chill in the single digits or lower. So that's 9 degrees, which is very cold. Yeah. So as you consider the public health aspect of this policy, the question that we can't even answer, and I don't think a lot of our partners in municipalities and community homelessness providers can answer is to what extent the body can handle 9 degrees of temperature for multiple days. That's the point at which we have additional resources and capacities to help people. And I think that's really where If that was adjusted, we would need additional resources to handle that, but that leads to assume we would also save lives.
I just want to highlight one issue that people may not recognize, but many people who understand this issue speak about this. I came across somebody who was homeless, and it was not a fault of theirs. It was just their landlord said, you cannot live here anymore, and they could not find a place. When they were homeless, they were in the winter month. There's so much pain from the cold that the person had no option but to take a substance to survive. Now that person is addicted to that substance because that was the only way to survive, because there's no place. Now he cannot find a place because he's addicted. And there's no system in place to be able to have them go through detox while he's tried it. And so he's a friend of mine now because I've invested enough time and spent some time. As a co-chair of the Public Health Committee, I cannot find detox and treatment for this person, despite making phone calls. And he has to move from one part of the city to another part of the city, right 5 minutes, 10 minutes from here. So it's a pretty significant failure that we have collectively created. So thank you for listening.
Thank you.
Yes, my co-chair has a question or comment.
Absolutely.
Thank you, Mr. Chair, and thank you so much, Daniel, for being here. And I'm sorry that I did not get to hear all of your testimony, which I will listen to later, and I will certainly read your online testimony. I feel like I need to do this with our Planning and Development Committee chairs who are also members of this committee, but this is, a trick question. Would you agree that we would have a lot less issues related to homelessness if we built more housing?
Yes.
Thank you. I appreciate that. That was really to support the efforts that are happening in other committees, and also just to add that this issue is certainly across many committees, and it's a multi-systemic issue that we need to address on many levels. So I appreciate you focusing on this particular aspect of it from the health perspective. Thank you for being here today.
Yeah, and just to add to that, I was surprised looking at the data we put together in the testimony. Folks have been talking about the harsh winter we had in 2015, which we did. And we did have 40 activation days in 2015, but only 3,000 calls. This year, we've had significantly more activation days, but also more than double those calls, which does suggest, again, a correlation between the availability of places to be inside during that time frame, because this year's cold weather, I think, was quite similar to 2015.
Thank you for adding that important piece of data.
Representative Kavros DeGraw.
Thank you so much. And thank you for being here, Daniel. We appreciate it. Certainly, we recently, a bunch of us toured 211, and we were incredibly impressed by the call system and how the calls are handled. But obviously, it's a lot harder when you have more calls. To your point about 9 degrees and how you can be outside, and perhaps this is actually something that the good Dr. Senator could comment on. My understanding is at 46 degrees, you could, if it's raining, you can actually get hypothermia, which certainly begs the question of why we've kept it so low, other than perhaps funding. But in a situation like yesterday, for instance, my understanding is we only had sort of a partial situation. We knew there was ice coming. I don't know how the rest of the state was, but in the Hartford metro area, there were inches of ice on the ground. This morning when I drove in, I saw various unhoused people walking around, and it was incredibly slick on surfaces. So to the point of yesterday, at what point was 211 notified that there was a partial cold weather, and what is a partial cold weather situation?
Yeah, I don't know the exact time that activation occurred. It did occur, and I have the data on that. As my colleagues have alluded to, it was pretty late in the evening, which does make it difficult, as a lot of folks have mentioned, even for us to deploy the necessary staff to do the appropriate surge on the phones, and also the organizing of everything else on the ground. That said, it is difficult to, our staff, for example, look ahead at the weather to see when we're getting into single digits with wind chill so they could begin to be ready as possible. But until the activation occurs, there are no resources available to do additional, actual additional staffing on any of that.
Okay. I thank you so much. Thank you, Mr. Chair.
Thank you. Thank you for your testimony and the work you do. Say hello to all the people who answer phone calls. I had a chance to meet them, many of them, so I appreciated them.
I certainly will. Thanks, y'all.
Thank you. All right. Next person on the list is Linda Sprague Martinez. Welcome. You're on.
Good afternoon, Senator Anwar, Representative McCarthy Vahey, and esteemed members of the Public Health Committee. My name is Linda Sprague Martinez. I'm a professor in the Departments of Medicine and Public Health Sciences at UConn Health, and I direct the UConn Health Disparities Institute. I'm here today to provide testimony regarding House Bill 5389, an act concerning a provider toolkit for the diagnosis and treatment of menopause, perimenopause, and postmenopause. The Health Disparities Institute was established in 2011, and we have a legislative mandate to enhance research and the delivery of care to minoritized and medically underserved populations across Connecticut. Community engagement and partnership are critical to our work, and it is through community engagement that we identified menopause and menopause equity specifically as a community priority 1 year ago. 1.8 million women in the United States enter menopause each year. And as we heard, it comes with a series of symptoms. And it's also important to take into account that it's shaped by social, cultural, and environmental factors. Despite everything we know, menopause remains rarely discussed, which further contributes to misinformation, stigma, and barriers to care. Over the last year, the Health Disparities Institute, under the leadership of Tricia Pitter, has established the Menopause Equity Collective. We've partnered with them to launch a menopause equity initiative and engaged hundreds of individuals across the state in community-led health education and promotion events focused on menopause equity. Through extensive community engagement with our partners across Connecticut, we've identified urgent concerns regarding a lack of accessible, culturally responsive, and linguistically appropriate information about menopause. Consistent with national research that's been conducted nationally, women in Connecticut report limited access to accurate information, which reinforces a culture of silence. Silence, stigma, and isolation are well documented in the menopause literature. Ageism and gender bias contribute to cultural norms, which devalue women as they age, framing menopause as a marker of diminished worth. This lack of information, coupled with already existing racial healthcare inequities, further marginalize women of color. House Bill 5389 addresses a clear and urgent need by supporting the development of a provider toolkit for the diagnosis of treatment of menopause, perimenopause, and postmenopause. There are documented gaps in provider training. We've heard some of them alluded to earlier today. A study of the 2023 study, for example, of obstetrics and gynecology residency program directors, where over 90% reported that there was a need for strongly agreeing of the need for a standardized menopause curriculum. 31% reported having a menopause curriculum of the 99, and only 29% reported that trainees have access to menopause clinics or even to work with women who are experiencing menopause. 84% agreed that there was a need for more curricular resources overall. In addition, there are reports from providers overall reporting with fewer than 7% of reporting feeling adequately trained to have conversations around menopause. And recently, because we did an assessment recently in an effort as we were developing CME trainings for oral health providers, we learned that 66% had no training in menopause and 47% reported not screening for menopause, despite the fact that research indicates menopause is associated with dry mouth, changes to taste and tooth sensitivity, tooth decay, and tooth loss.
Excuse me, Ms.
However,
Sprague
it's important to
Martinez,
know-
but your time has expired. Thank you.
Okay, thank you.
Actually, if you have a couple of sentences, please go ahead.
Yeah, I just wanted to make the important point that there is evidence that's out there that reports that providers are very open to additional training and resources regarding menopause. There are studies that report that self-paced modules, podcast-based learning are all acceptable among providers. And we've also found through our efforts in Connecticut, when we invite providers to our events, they come. And we heard earlier, California is a state where they've incentivized providers using CME trainings. free CMEs. And so there are ways when we include providers in the development of trainings and materials that they do participate. We're able to create resources for them that don't cause additional burden, given that fact that providers are already burdened. Their time is already burdened. So I can stop there. I've also
Thank you.
provided written testimony.
Thank you so much for your testimony. So can I ask, have you guys changed your curriculum for the training for residency or even for medical students and the residents around this?
Yeah, so we've been doing work around menopause education that's focused more broadly on communities. We've that's focused on communities and community residents in particular, because that's where we heard the initial need. Recently, we just completed the assessment of oral health providers, because that was an area where we saw and heard a need, and so we met with them first and then developed the CME training for them. So we are we haven't yet developed for residents. So.
Thank you. Your written testimony is very helpful. We appreciate your work. And I think Representative Belton has a question or comment for you.
Hi, Linda. Thank you for being here today. I wanted to ask a question about what other states have done as far as the toolkit. Do you know of any other states who have the toolkit or anything close to it?
Yeah, there are states, and we can provide this in writing, because we did an analysis that was led by Malia, who's going to testify later today. But we did an analysis of all the legislation that's been introduced across the country, and educational initiatives were the most common type of legislation that's been introduced in other states. And so there are examples of resources and toolkits that we can provide you a written summary, because we have that. So.
Thank you.
My co-chair, Representative Kristen McCarthy-Vahey, has a question.
Thank you. Thank you, Senator. And thank you so much for being here with us for your testimony. And as Senator Anwar said, your written testimony, which has some really great visuals for anyone following along at home, with a lot of helpful and important information. As someone who knows very little about menopause, I wondered if you could actually talk about the connection between oral health and menopause. We have, as you know, a bill on the agenda today also about our dental care, but can you just talk a little bit more about that connection, why it's important for dental providers to be informed, and what kind of impacts there are for women who are going through menopause?
Certainly, although I'll say that I'm not a dentist, I'm a social scientist. And so, but I can tell you that the literature indicates that dry mouth is associated with menopause and drops in estrogen, as well as changes in taste, tooth sensitivity, as well as tooth decay and tooth loss. And there have been some studies that have found that as many as 30% of women have lost a tooth during menopause. And so there's definitely implications when estrogen levels drop, that there are implications for oral health. But I will let the dentists and OB-GYNs talk specifically about some of that.
I just want to say thank you. And I think that for you and for everyone who's testified today, as all of us know as humans, it's really validating to be heard and understood, to be seen, and to know that half of the population is going through this experience if they're fortunate to live long enough to do so. And that you, and I again can't thank Rep. Belton enough for her leadership, are bringing this forward to us, an issue that we really haven't talked about in this committee, and certainly many people haven't. So I just allow my thanks to you and to others who testified before you who I wasn't able to thank. Just echo forth.
Yeah, well, we are very grateful to Representative Belton for bringing this forward. And just to echo your point about there's such a desire to be heard around this topic. We hosted an event in March. We had over 300 women come out for the event to talk about menopause and menopause symptoms. And the more events that we host across the state, the more women that come out, and they repeatedly tell us they're not getting the information they need from their providers, and they're not getting it early enough. So.
Thank you. Do you think it's possible to have a video recording of a CME program that can be shared with clinicians across and they could get their CME credits?
I do think it is. Yeah, I read a really interesting study that looked at self-paced training for physicians and podcasts as well. There was one. So there are definitely ways to get the CME training to physicians in a way that, and providers, different provider groups in a way that would work for them, that was tailored for their specialty. I think it's a question of anytime we do a lot of toolkit development, and one of the most important things is really working with the end users to make sure that you're developing something that works for them and piloting it. But also, in this case, we want to make sure that what we're hearing from Connecticut residents, they also have access to that information because that's so important as well. So.
Thank you. Thank you. Representative Cabral-Stigall has a question.
I was just wondering, because we're talking about the fact that women are going to their providers and they're not getting the information that they need necessarily from their providers, or maybe they have a provider that, they're interested in hormone replacement therapy and that provider is not interested in prescribing it. Just because we do have you and you have expertise in this, is there something that you would suggest in terms of like what the patients should be saying to those providers to try to have a better interaction? I mean, I as a Gen X woman who has been in menopause for 2 years, the majority of my information is Dr. Mary Claire Haver and other doctors who are on TikTok or Instagram. I think they're calling them doctor influencers at this point. But if it were not for them, I don't think I would have sought out that hormone replacement therapy. And it's incredibly frustrating because while thankfully I didn't have the dental issues, I could give you a whole laundry list of what losing estrogen has done to our bodies. So I guess if you have any suggestions at all for how to approach physicians specifically, that would be really useful to us.
Yeah, no, definitely. And you bring up a really important point because you have to think for years, physicians were trained that hormone replacement wasn't a good thing, right? Because some of the earlier research that has since been invalidated. And only recently are we starting to see changes in packaging where disclaimers are being removed. But that's all up-to-date information that not everyone is getting and not everyone is having access to immediately. And we find that some physicians aren't even aware of that. But probably the most important thing when you're talking to the physician is to remember that you are the expert in your own lived experience. You know your body best. And if you're not being heard by that physician, it's okay, one, to fire them and to find a new one, or to continue to bring things to them. If you feel like I've done studies similarly around Black barriers to cancer care and clinical trials. And one of the things that we hear consistently is that I've invested so much time in educating this physician on working with me as a woman of color, and I don't want to just get a new physician to have to start all over. And so sometimes people are not willing to fire their physician, but it's okay to bring information to them as well, and continue to have conversations with them. But I have to say it is exhausting and takes a toll on the body when you're having to consistently fight for adequate care because there's not enough information and research out there.
And I would just add to that the fact that, I remember watching a doctor who said, there were literally hundreds of ways that the loss of estrogen and our other hormones affects our body. That I think the most common thing that comes up with other women is when you say, oh, I didn't realize this was a symptom of menopause. And then you share it with them and they say, oh my God, I've been having that for a year. I've been having that for 2 years. I mean, the itchy ears thing alone, and the fact that we're getting tips again from the internet about how to put Flonase on a Q-tip to put in our ears so they're not itchy. I mean, this is the level of ridiculousness, and no offense to our men in the room, but honest to God, if this were the same situation, I do believe that with men, this would have already been resolved many years ago, because the amount of research that has not gone into this. And again, I'm repeating what I have heard from other female physicians who are saying this. It just has been incredibly frustrating, but I also am so proud of us as Gen X women that we are making this better for the next generation, because I certainly don't want millennials, Gen Z, et cetera, to have to go through what our mothers and grandmothers have now had to go through, and what we almost had to go through if this HRT hadn't, and other things. And not everyone's a candidate. I understand that. But there is a lot of possibility out there for us finally to not have to just suffer because we're of a certain age. And I'm loving this of a certain age, if I'm being honest. So anyway, thank you so much, Dr. Senator.
Yeah, you're welcome. Thank you. Thank you so much. I think, it's funny, we learn about pregnancy in 5th grade, right? We get like a health curriculum. We're told way ahead of time all the things we need to put into it because they finally are figuring out what our symptoms are. That, I mean, we should be talking about menopause so much earlier than we are. So thank you so much to the committee.
Thank you. Thank you for your testimony. And we will move to the next person on our list, which is Sarah Fox. She's virtual online. Sarah, well, Fox, you're on. Welcome.
Good afternoon, members of the Public Health Committee. My name is Sarah Fox. I am CEO of the Connecticut Coalition to End Homelessness, and we lead the statewide effort to prevent and solve homelessness through the Connecticut Can End Homelessness campaign. We work closely with providers, state agencies, municipalities, and frontline staff and people experiencing homelessness every day. Before I speak about the raise bill, I just want to address what is currently happening across the state. The winter response has required constant coordination across agencies and municipalities. United Way of Connecticut and providers, state agencies, people have extended our hours. We've opened doors. We've transported residents to safety and made placements under enormous pressure. I am very grateful for that partnership and the seriousness which everyone has approached these life safety stakes. The severe cold weather protocol has been effective for and active for 47 days this winter through activations and weather-driven surge response. And for you and for many of you, you come to this work not only as legislators, but as physicians and nurses. You know what it looks like when a clinical course is predictable and when a system still intervenes too late. And that's why I'm here today in strong support of this bill, Raise Bill SB 364, in support of an extreme weather protocol. I want to share some of what outreach teams are reporting because I think it's the clearest indicator of how serious this has become. They describe laying blankets over people sleeping directly on frozen ground, trying to slow heat loss because there's nowhere else for people to go. They have provided care to people with icicles forming on their clothing and bodies after nights outside in the snow and sleet. In the summer months, they have watched people deteriorate in extreme heat when dehydration and heat illness progress quickly without shade, water, transportation, or indoor cooling. These are our neighbors, sons and brothers, sisters and mothers, fathers and grandparents. For someone who is unsheltered, weather is not a backdrop, it is exposure. It can cause hypothermia, frostbite, decompensation of heart, lung disease, infection risk, falls, and sometimes death. In extreme heat, exposure becomes dehydration, heat stroke, rapid organ stress, especially for older adults and medically frail people. When someone cannot get indoors, weather becomes a preventable medical emergency. We do have a statewide protocol. And as Daniel said before me, it is in the single digits for multiple days. I will also say that I'm grateful to the administration for enacting it oftentimes this winter at higher levels. We need a predictable, ongoing protocol that accounts for extreme weather, whether it is extreme cold, whether it is extreme heat or severe cold or severe weather, so that every single one of our neighbors can come indoors, can be protected, and can not have these life-saving, not have these critical issues and this exposure at this scale. As more and more of our neighbors fall into homelessness, we need a response, and we need to be well situated on the ground with the capacity necessary to handle this level at scale.
Excuse me, Ms. Fox, but your time has expired. Thank you.
Well, thank you very much for having me. I have examples, national examples that I'm more than happy to share. And I've also included the severe cold weather protocol in my testimony.
Thank you. Thank you, Ms. Fox, for your testimony. Sarah, could you share about some of the examples that you may have and that would be done? And then if you can share with us what other states are doing as well around this.
Well, first say, last winter, there's a story that just stays with me. It was a man who received care through Hartford Healthcare. and he had been out for quite some while. He did not, and he tried to come inside. They identified him, and he had frostbite all over his body. He ended up having to have limbs removed, and to have extensive care provided by the state at a high level of cost. And there were a few places where he could go after having his limbs removed, and they didn't know where to discharge him to, because he would have been back out in the cold. Those are the stories that we hear. We're hearing that from medical providers. You know, if you speak to a healthcare van that is going around our streets, they're seeing people in critical situations because they cannot come into safety. To answer your other question, Senator, just give me a second and I will share some national examples. There are a few things that set national examples apart. And so what they are is, you know, there is a public health emergency response framework that exists. There is a predictable, sustained infrastructure that is enacted. And so some of these includes New York City's activates code blue when temperatures are forecasted to reach 32 degrees Fahrenheit or below, and that includes wind chill, and it expands shelter access while intensifying street outreach, so people are brought inside before conditions become life-threatening. Multnomah County in Oregon activates severe weather temperatures at 25 degrees Fahrenheit or below, 32 degrees Fahrenheit with rain, snow, and high winds, recognizing that precipitation and wind sharply increase hypothermia risk. Philadelphia activates code blue during life-threatening winter conditions and increases street outreach operations and emergency shelter capacity during those periods. And other jurisdictions across the country have heat-related protocols where they are resourced to ensure that people can come into cooling centers and to save spaces and to shelter during extreme heat as well. So they are not just looking at a cold weather response.
Thank you. This is very helpful. I wanted to just also ask you, I know cost remains a big issue, and this winter, I hope this winter is an anomaly, because if we're going to have a winter like this every year, maybe we all need to have another state. But if we were to look at this strategy, do you think there could be efficiencies that can be created even in communication systems outside of the one part is the decision making? So let's keep that on the side for the time, because we've already addressed that. How can the communication systems be more efficient across the entire state, and then work with a CAN system so that if the decision is made, you just press a button, and with the 2026, we should be able to get everybody on the same page right away?
Well, first, and that's a really good question. And I think when you get to cost, there are costs associated with really having a system in place to protect people. It is there, but there are also costs, Senator, of homelessness. So for, you know, the individual I described earlier, the amount of cost to rehabilitate him was exponential within the healthcare setting. And we know, you know, an emergency room. I mean, you all know all too well the cost associated with healthcare and providing health services for people who are coming into emergency rooms, who are outside. So I won't belabor that. But in regards to ways to make this better, elevating the temperatures so that right now, honestly, it is, you know, you'll have the severe cold weather protocol called. You've heard from all of my partners and colleagues about the challenges of, you know, the mobilization. You will have it called, and people are brought inside. They're brought into hotels, and then they have to go back outside. They have to go back outside on days like today in Connecticut, where there is snow and ice, and you have people often frail, often who have been exposed to the elements for a long time, who are being exposed. So making sure that we have a humane response means that we're really analyzing those triggers, and we are moving from the very low triggers to a higher threshold, which would allow us to have more time to get everything situated, because it's people would be able to come inside during those activation periods. And beyond that, it's really about having public facing triggers, and we do have that, but strengthening those, making sure that because we have a longer duration of time, we can more clearly outline these for every single partner, including people currently experiencing homelessness who are waiting to find out what's going to happen. I will say, just within the last couple of days, the CLIP program that we work with, which is the Consumer Leadership Improvement Program, they have been sharing about their concerns, and they're hearing from people in their communities that are frightened for their life because they're outside in this temperature. And so I think it's really about looking and doing this work through the Interagency Council on Homelessness, partnering with all of the state agencies who are dedicated to this, who we appreciate, and coming up with clear strategies that can really turn this around and turn this into a clearly protocoled, sustained infrastructure for the state that is life-saving and strong and sustained in a way that upholds providers.
Thank you so much. Representative Kristen McCarthy, he has a question.
Thank you, Mr. Co-Chair. And Sarah, thank you so much for your work, for your testimony. And actually, my question is a follow-up to what you just said. If you were to kind of design the perfect room of who would be sitting around the table to have this conversation, to kind of hammer out the details on how this would work and how we would implement things differently here, who would be sitting around that table with you to have this conversation?
Well, I mean, I will say, and with great appreciation, the people who are doing this work, including the Department of Emergencies, I'm going to say it wrong, DESP, and Department of Emergency Management, United Way of Connecticut, Department of Housing, DEMIS, the Governor's Office, OPM, and all of our relevant other state agencies, including DSS, our healthcare providers, our municipal leaders. This must be informed by the people who are currently experiencing homelessness, and their voices to ensure that we are meeting the system level gaps. This is most appropriate through the Interagency Council on Homelessness that was codified and has been enacted, and we are meeting. But it needs to be something that isn't delayed, that we can bring forward in a short period of time, because this is, for every day that we delay, people die. And it's not just the cold, it is the heat, and it is when severe weather hits. And so it needs to be responsive, and it needs to be timely and actionable.
Thank you. So I hear United Way, Department of Housing, Governor, OPM, DEMIS, DESP, DSS, healthcare providers, municipal leaders, and the Interagency Council on Homelessness.
I mean, I'd add first responders, faith communities. I mean, I could go on and on, but it's really the people who are working with the unsheltered outside, and making sure that we have the tightest response, a disaster response to the experience of unsheltered homelessness.
Okay, well, I look forward, Sarah, to ongoing conversations on this, to just think through and work on the practicalities of how we can make this work more smoothly. So basically people are safe, sheltered, and stay alive. Thank you.
Thank you, Sarah. I think Representative Kristen McCarthy, and I won't take it personally that we are not involved in the party and the table, but
you know what? So that is just I do mean to.
I was joking. Don't worry.
No, but I actually did. So that was just I do mean to include like the committees of cognizance in the legislature. When I think about the work that we need to do to prevent and solve homelessness, it takes your voices and leadership. And obviously, we so appreciate your leadership every single day in the work that we're doing.
Speaking of leadership, Representative Kevros DeGraw.
Thank you so much, Senator. Mr. Chair, Sarah, you mentioned more than once, it's good to see you. You mentioned more than once heat, and we talk a lot about the cold, and we've talked a lot about cold weather today. Are you aware when you're talking about other places that have different cold weather structure, has anyone put in any sort of heat recommendations? Because, they always say the heat will get you first. And we, have seen some incredibly hot summers. I think the past 4 or 5 have been the hottest on record, breaking the record every single year. So my question is, are there other states that perhaps are putting those resources in, or at least have some guidelines for what we should be doing around the heat?
I mean, so Arizona, Phoenix, but they're mostly places that have warm climates that are not dealing with sort of like the shift of all 4 seasons. And so I don't think that we shouldn't act because other states don't have a really humane framework. I'd also say that other states have a similar protocols to us. But it's incumbent that our state really drives and we can lead across the nation a response that encompasses heat. Because what we're seeing on the other end of that and what providers are telling us is really about, how many people are impacted during the heat, how oftentimes heat related exposure is so much worse, and it's a silent killer. And it's not something that we often talk about, but it's something that we are recognizing more and more, which is why this year, we didn't just say we were grateful for the resources we received last year and have been annualized in the budget for cold weather. But providers really have been saying in a really profound way, like, no, we have to ensure that we're addressing heat-related exposure as well, and we must come up with policies to protect people. So I will provide you with the strategies that Greater Hartford has been deploying, and they've really come up with a wonderful framework through Journey Home, and it would be a great step forward for our state to be able to think in this other way, which is really recognizing extreme weather, and for us to be resourced appropriately for it.
Thank you. I really appreciate that answer, and I'm looking forward to seeing that information. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, thank you, Sarah, for everything that you're doing. We move to the next person on our list, which is Kate Hickey, who is not here or on. Oh, you're here. We're looking for you remotely, but I'm glad you're here in person. Welcome. I'm glad you decided to come here, and thank you for being with us all day.
Hello, sorry. I'm in between patients, so I apologize for the running around. Good, sorry, getting myself all settled.
Dr. Lilas, there was somebody else there.
Oh,
so
sorry.
Just wait for a second when you're next though.
Hey, good afternoon, members of the Public Health Committee. My name is Kate Hickey. I'm from Old Lyme, and I'm an MSW student at the UConn School of Social Work. I'm here today to testify in support of HB 5389, an act concerning a provider toolkit for the diagnosis and treatment of menopause, perimenopause, and postmenopause. This bill will develop a statewide menopause screening and treatment pathway toolkit that will focus on when and how to screen, symptom assessment, evidence-based treatment options, guidance on knowing when to refer to a specialist, and the creation of free and optional training modules that will be eligible for continuing education credits. Menopause is a universal and natural stage of life that affects more than 500,000 women ages 45 to 64 in Connecticut. However, there's a significant lack of equitable, evidence-based, and accessible menopause care. Because of the lack of research, education, and stigma associated with menopause, I myself was unaware of what menopause was and the impact it can have on an individual's life. Many women who are experiencing associated symptoms may not even know that their symptoms are related to menopause and are consequently being left untreated. In Connecticut, approximately 70 to 80% are experiencing menopause symptoms, but only 1 in 4 women are receiving treatment. Not only does this have a drastic impact on the health of the individual, but on society at large. Research shows that women with untreated symptoms have 121% higher healthcare utilization and experience 57% more days loss of productivity, which results in an additional $2,100 per woman per year in healthcare and absenteeism costs. These costs contribute to an increased use of emergency services, higher healthcare spending, reduced workforce participation, and economic stability, and widening widening inequities for underserved populations with limited access to care. For women that are seeking care, many healthcare providers are not trained to recognize menopausal symptoms and counsel patients on treatment options because of limited training curricula. In Connecticut, less than 7% of primary care providers reported that they felt adequately trained in menopause care. Evidently, there's a significant gap in education and care for menopause-related care. This is why I'm asking you to support and pass the bill that will help thousands of women receive the care they need. Thank you for your time and consideration.
Thank you, Kate, for your testimony. You did very well. Is this the first time you're testifying?
This morning was the second time.
Second time.
Yeah.
Well, it was very good. Looks like you're a pro. You just did it within time. Your message was great. You'll be doing wonderful.
Thank you.
We need social workers.
Thanks.
Thank you. All right. Representative Belton has a question for you. Don't go away.
No question, just a comment. I want to say thank you so much for your testimony and happy Social Work Month.
Thank you. You good. All right. Dr. Liana Lyles, you're on now. Thank you for your patience with us. Welcome.
I am so sorry about that earlier, y'all. That happens when you multitask way too much. Good afternoon. My name is Dr. Ayanna Lyles, and to Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Joint Public Health Committee, I'm a board-certified OBGYN physician in Connecticut for the last 11 years and the vice chair for the Connecticut section of ACOG, which represents 1,068 OBGYN physicians and partners in women's health answering the call of our profession in our state. I also take care of patients with endometriosis, perimenopause, menopause, and feel very comfortable in that space. Thank you for the opportunity to submit the testimony on behalf of the Connecticut ACOG section in support of HB 5322 with some general comments for HB 5389. I did submit testimony for both of those bills, but to start with HB 5322, we applaud the committee for valuing this underrepresented community and the challenges they face in diagnosis and treatment. I have several patients with endo, some of whom have complained of years of symptoms and experienced delays in their diagnoses. ACOG recently released new clinical guidance on the diagnosis of endo that is intended to reduce delay in diagnosis and improve treatment for patients. Endometriosis is a chronic inflammatory condition that causes significant impacts on a person's life. ACOG's new guidance provides detailed recommendations on the use of clinical findings and imaging tests to get early treatment options and diagnoses, and it is essential for us to understand the burden of disease in our state and improve timely access to care. However, we want to ensure that the correct individuals with expertise in this area are providing this information, and as such, CT-ACOG respectfully requests that one of the members appointed to this committee be an OBGYN and a member of ACOG. With regards to HB 5389, ACOG's clinical expertise and guidance covers all stages of a patient's health, including menopause, perimenopause, and postmenopausal care. The resources are in the written testimony for review, and suffice it to say, we strive to equip clinicians with expert reviewed clinical guidance and practice management tools to address the concerns they have during their transition. I know that I frequently use it on a daily basis to ensure that I'm providing the most up-to-date counseling and options. It feels like menopause care is having a renaissance as more people are being advocated for, diagnosed, and treated. So I applaud the members of this committee for advocating for this underserved community. At the same time, I also believe that creating medical resources should rest with experts and should not be influenced by the legislative process. The patient-physician relationship is essential to the provision of safe patient-centered care and protected from government involvement. The creation of state-mandated materials interferes with this relationships and sometimes can prevent physicians from proceeding with patient-centered care that is nuanced. ACOG welcomes the opportunity to partner with members of this committee to identify gaps in access to menopause-related care and determine legislative fixes. Overall, we seek to partner in the work of this committee and appreciate all the efforts to center evidence-based medicine, protect the patient-physician relationship, and provide critical resources to our patients.
Thank you, ma'am.
Thank you so much for your testimony. You're on time with on message. I appreciate you. Can I ask you for a favor? Would you be able to do a CME lecture for us that we can put online for any of the places that would be willing?
Regarding CME for what? I won't agree unless
A lecture on menopause, so the clinicians would be able to learn about it and be better prepared.
I can do it. I also, as you can see, I'm really busy. So I would be happy to find a board certified ACOG, someone who's evidence-based, because I agree. I think the more knowledge everyone is aware of menopause, the better that we can serve that group of individuals who have unfortunately been neglected for decades. So if you are all willing, I'm happy to help set that up either with me or whomever. There's several people in this state who are what we call NAM certified, meaning they've gone through the menopause certification and they are passionate. I'm passionate about everything, as you guys have all learned over the years, but finding someone who's extremely dedicated in this space is something I'd be happy to coordinate.
Perfect. We want to thank you for your testimony. Thank you for your time, and thank you for the work that you do.
Thank you.
All right. That brings us to the next person on the list. I want to make sure you are not in the room here. Quinn Meehan? No, you're not. All right. That brings us to online Medicine Sprimuli. Medicine, Miss, you're on.
Thank you. Good afternoon, members of the Public Health Committee. My name is Madison Sprimuli, and I am the organizer for the CT Zero Waste Coalition. I am here to testify today in support of Senate Bill 382, an act concerning edible food recovery. The CT Zero Waste Coalition brings together various environmental nonprofit organizations across the state, including food recovery organizations, all with the combined goal to advocate for waste reduction. We believe that this proposed bill provides a solution to two pressing issues our state is facing: feeding our hungry residents and diverting organic material from landfills and incineration. It is alarming that we throw away nearly 40% of our food supply, while approximately 1 in 7 Connecticut residents face hunger. I will speak primarily for the rest of my time on the economic and environmental burden of wasted food. Nearly a third of our state's municipal solid waste is organic matter, which is heavy and expensive to dispose of. Currently, retail food establishments and municipalities incur high costs by sending food waste to landfills hundreds of miles away in Pennsylvania and Ohio. And disposal costs are only expected to rise as aging incinerators in our state close and landfills reach capacity. Not only that, but food decomposing in landfills is a major contributor to methane emissions. To put it in perspective, Connecticut sends nearly half of its waste to landfills out of state. We do have one proposed change to this bill regarding the definition of food distribution organization. The current definition in the bill is limited only to nonprofit organizations. However, there are other organizations without nonprofit status that contribute greatly to food recovery in our state. Instead, we urge the committee to adopt the broader definition of food relief organization, established in Public Act number 22-28. This definition includes community-based organizations, mutual aid networks, as well as nonprofits. So to conclude, we ask the committee to please pass Senate Bill 382, an act concerning edible food recovery. Thank you for your time.
Thank you for your testimony. Do you have a written testimony as well, Madison?
I do. I did submit it.
Perfect. Perfect. Thank you. We'll make sure that we look at your specific recommendations. We want to thank you for being with us. We appreciate you and the work that you're doing. With that, we're going to move to the next person on our list, which is, I don't know, I don't see him, Dr. John Wysocki. Oh, there you are. You've been here all day with us. Thank you. Thank you.
Yeah, thank you, Dr. Senator Anwar, Rep. McCarthy-Vahey, and distinguished committee members. Thanks for having me today. My name is Dr. John Wysocki. I am a board-certified gastroenterologist with Connecticut GI. We care for tens of thousands of patients all around the state of Connecticut. We are an independent physician practice, and normally my partner, Dr. Joe Kapp, has been here the past few years presenting testimony on behalf of similar bills that we've talked about today. He sends his regrets that he cannot be here today. But I'm here today to talk about House Bill 5398 in opposition to that bill. This is a bill that would make it harder for independent practices like ours to continue providing care outside the hospital, health system, or insurance company setting. This bill assumes private equity partnerships harm care and increase costs. Data would suggest otherwise. Research does show that hospital-driven consolidation, not private equity, is leading to higher healthcare costs. healthcare organization called Avalier analyzed some Medicare data back from 2019 to 2022 across 5 different medical subspecialties, including GI. According to that study, a staggering 82% of physicians in those fields are now affiliated with hospitals or corporate entities like Optum, but just 6% of those are independent and affiliated with private equity-backed MSOs. So private equity does support independent practices and is not necessarily the driver of consolidations. Hospitals and payers buying medical practices are. Avalier also found in that same study that previously unaffiliated physicians, when they join a hospital system, annual Medicare spending per beneficiary actually increased by over $1,300. When a similar unaffiliated physician would join a private equity-backed management service organization, they found that Medicare spending per beneficiary per year actually went down by $963. A new peer-reviewed study in July of this past year showed that hospital outpatient departments are reimbursed at dramatically higher rates than that we see in independent physician offices and ambulatory surgical centers across these medical specialties, including GI. Upwards of 860% more for Medicare and over 1,300% more for commercial insurers. This has real-world impacts for patients in our healthcare system. Take, for example, what I do. I do colonoscopies. Quite often, that's people's introduction to the GI community, age 45. It's the only cancer screening test that both can detect and prevent cancer. According to a study from 2023, a colonoscopy in the hospital setting could be as much as 65% more than in an independent surgery center, like where I do many of my procedures. And I may be the same physician doing that exact same procedure in a hospital in that ASC. But we need to make sure that Connecticut doesn't make it harder for us to expand care in order to offer affordable care to our patients. Our MSO partnership provides capital and operational expertise that allows us to expand high-quality, affordable care and adopt advanced technologies. Through national data that we have from nearly 3 million patients, we look to implement care management programs across a variety of diseases, including fatty liver disease, inflammatory bowel disease, obesity, and this helps to improve outcomes and reduce ER visits. The partnership.
Excuse me, Dr. Wasaki, but your time has expired. Thank you.
Thank you. It's one last closing.
Yeah, please.
But I urge the committee to try to tailor policy solutions to address these specific failures we face in Connecticut, like the Prospect Medical bankruptcy, without undermining independent practices' ability to grow and be competitive and allow access for high quality, affordable care throughout the community. So again, please oppose House Bill 5398. Thank you for your time.
Thank you. Thank you. This is very helpful. I think the data that you're sharing helps us recognize that sometimes we are worrying more than what the reality is. And the real challenge is that what Prospect did has raised our awareness, and that's where the area of opportunity has been. But I guess there is a little bit of a concern at the national level, more so that there are things happening that are concerning in the private practice arena, and that brought some of these conversations over here.
Absolutely.
Anything else that do you think that the MSO agreements can sometimes restrict access?
I think probably the opposite. So I think there's, not only with technologies, but new ways of doing things, sharing how practices are able to survive and thrive, in today's healthcare universe is good to hear, because everybody does things a little bit differently around the country. And when you have that shared expertise that you can get from other practices that are doing things a little differently, possibly better than you can do, may open up opportunities for you to make sure that you can offer care to people in a variety of ways, whether it's after hours or unique APP opportunities in the office, having more flexibility with how you see patients, how you can do bypass colonoscopies. But there are, I think, a lot of solutions that exist that you may or may not be aware of that allow you to enhance your practice, offer more care, because we are facing that disparity between providers and the demand of society and what our patients need. So we have to find new and inventive ways. And I think being nimble, allowing for competition, good competition. I think competition is a good thing to help push us ahead, because we have to be much more creative with our solutions as opposed to the age-old techniques that we've been using in the past to try to treat our patient populations. And AI, technology, the list goes on and on of things that we can implement to help make sure we're offering the best care for the most amount of people at an affordable price. So I think it's a good thing to continue to push the envelope, and having the support of MSOs and other organizations around the country, and a lot of these are independent, is essential to make sure that we can all move this ball forward, because it's not just a hospital issue. It's not just an academic center issue. It's not just a private practice issue. We all need to be involved in various facets. So this will help to ensure the health and vitality. It's one of the components that's just as essential as hospitals are. Insurance companies play a role, but they're important to bring to the table as well. So I think there's all these things are important, but independent practice must be recognized and understood, and make sure that it doesn't get squashed.
Another stereotype we have on the outpatient side is that the Medicaid patients are getting restricted by private equity. Is there any evidence of that?
No, I mean, there's no restrictions that I've seen in my practice or that I've heard about. People, regardless of insurance, it's a nice thing. We need to see patients. So we have openings for every patient. Whenever I get asked a question, for example, are you seeing new patients? The answer is always, of course. So, like, I've never closed a book or never heard of anybody closing a book as a result of anything before any MSO affiliation or after one. I've never been told how to practice medicine, nor have I think my colleagues been told the same thing. So I've noticed absolutely no change after being involved with any type of MSO organization.
Good. Well, we want to thank you for being with us throughout the day and experiencing this part of the world as well.
Democracy at its finest. I appreciate the education. Thank you.
How many patients will be upset at us today with the Public Health Committee?
A few.
Okay. Well, we appreciate them and appreciate you. Thank you so much. Oh, we have a question. Sorry. Representative Kristen McCarthy. Sorry.
Thank you. No, more just a comment and to point out to my colleagues. First, thank you for serving the people of Fairfield and Bridgeport, who I represent.
Vice versa. Thank you.
I also want to say thank you for including in your testimony the background and the references that you made today. So when I clicked on and saw the 69 pages, it was helpful to see that there is that background, which is great. So thank you for that.
Sure.
Thank you for spending time with us today.
I appreciate it. Thank you.
Thank you. With that, we will move to the next person on our list, which is Dr. Kirsten Eck.
Good
Thank
afternoon.
you for patience with us. Welcome. Thank you.
Good afternoon. Dear esteemed members of the Public Health Committee and chairs, my name is Kirsten Eck. I'm a board-certified internal medicine physician. I take care of hospitalized patients. And in part of my role, I work with medical residents to connect with community partners who do street outreach medicine for our unhoused persons. I have an interest in teaching climate and health, and I come before you as a member of the steering committee for the Connecticut Coalition on Climate Action, or CCCA. I come today before you to speak on behalf of Senate Bill 364, which grabbed my attention and my heart, an act concerning extreme weather protocols. This bill touched me because I just recently took care of a gentleman, I'll call him Mr. L, who came to me in septic shock. So he was very, very critically ill. He had been in the cold in the extreme weather event we had a few weeks ago, and he had suffered frostbite to his hands and to his feet. By the time he was found on the streets, the frostbite had progressed to gangrene, so that his feet were black, the tissue was dead and necrotic, and infection had gotten into the underlying bone. The problem is that taking care of this gentleman was very hard because he had schizophrenia. And when we had to discuss treatment options with him, it would trigger stress, mental stress for him. He would begin clenching his jaw repeatedly, and to the point where he couldn't speak or process what we were saying. It was a very hard thing to watch. He was in a lot of pain. He ended up with amputations, which he perceived as threats to him as a person suffering mental health illness. His presentation was a consequence of him not being able to organize himself enough to seek shelter and not being able to connect with outreach teams in the town where he was from. I support this bill because I feel that it expands access to people like Mr. L and to so many others that my medical residents see with these street outreach teams who really suffer in these extreme weather events. I heard our previous speakers talk about the thousands and thousands of calls and need for these services, and not just in the cold weather, but in the extreme heat that we were sure to see soon enough, even though it feels far away right now. I hope that you will all support Senate Bill 364, expanding coordinated access and setting consistent triggers across the state that are more health guided. I agree with the previous speakers that 9 degrees is too low, and 90 degrees over 3 days is too high a threshold to trigger these in order to prevent significant morbidity and mortality for our unhoused persons and for other people all around the state with vulnerabilities to these temperatures. Hypothermia can easily set in the mid-30s temperature range, especially if it's wet or windy, while for patients with medical vulnerabilities, extremes of age, medications that affect how they handle heat, even heat indexes above 90 for a short time can pose deadly hypothermia threat.
Excuse me, Dr. Eck, but you've reached your 3 minutes. Thank you.
Please do continue. I wanted to hear last
Thank
couple
you.
of thoughts.
Thank you. I'll just make one more point that I think that sticks really with me as well. This is something I anticipate housed people will also come to need when I review the global heating projections for Connecticut and what we can expect in terms of extreme weather, extreme heat, unstable cold. We can expect storms that will displace communities on the shoreline, inland flooding, hurricanes. We can expect neighborhoods to be displaced and need shelter or lack power. I think the expression is there by the grace of God go I. Any of us may need expanded access, and I anticipate more and more will be required for this state in the coming decades. I salute the members and chairs of this committee and all the partners who spoke before me for this bill. I think it is a worthy one of your time and vote. Thank you.
Thank you so much, Dr. Eck. Thank you for your advocacy, and thank you for the work that you do for the Connecticut Coalition for Climate Action. And this is very much connected to this and the way things are. Unfortunately, we may be seeing such extreme temperatures that would be dangerous for communities. Yes. Your testimony is very powerful, very helpful. Every 2 years, I would see somebody in the ICU who would lose their limbs from being homeless and being out in the cold. So it's very real, and while the people who die get attention, but the ones who are very sick are also a significant impact on the healthcare cost for the state, but the quality of life for them and then the future options. So your point is very powerful. So thank you for your testimony and the work you do.
Thank you.
With that, we move to the next person on our list, which is Dr. D'Onofrio. Welcome, Dr. D'Onofrio, and thank you for the work you do.
Thank you, and thank you, Senator Anwar and the committee. My name is Gail D'Onofrio, and I am board certified in emergency medicine as well as addiction medicine. I am in support of Bill SB 365, and I am going to give my comments. Opiate overdose deaths, while recently declining, continue to be a leading cause of death in people under the age of 45. Despite the availability of effective medicines. In Connecticut for 2025, that was approximately 775 deaths. Each overdose death results in 38 years of potential life loss. Emergency department initiated buprenorphine has been shown to be effective in increasing treatment engagement in multiple trials, is cost effective, and yet, even though we know this, adoption has lagged. Despite this knowledge, for over a decade, the removal of some regulatory barriers to buprenorphine treatment access, such as the X waiver, and national consensus recommendations from the American College of Emergency Physicians supporting ED provision of medications for opioid use disorder, published in Annals in 2021, there has been minimal improvements in ED provision of buprenorphine across the state of Connecticut. We know that individuals with opioid use disorder use the ED as their usual source of care, and this visit provides a very reachable moment. We know that specific state-level investments, such as those that had happened in California's expansive ED resource and technical assistance known as California Bridge, has paid off, leading to a much increase in number of ED-initiated buprenorphine prescriptions from emergency physicians, and that is published in JAMA 2025. While I'm not usually an opponent of legislating medicine, it is the time to change if we're going to change practice. Emergency physicians expect to treat patients with an acute myocardial infarction with aspirin, other medications, and to send these patients expeditiously to the catheterization lab in less than 30 minutes. Overdose has a similar 30-day mortality rate of approaching 5%, and yet emergency physicians do not feel the same degree of necessity to adhere to evidence-based practices. Why is opiate use disorder any different, I ask? There is precedent for this legislation. We know that the state of Massachusetts has enacted a similar law requiring that all hospitals and EDs and satellite emergency facilities maintain capacity for providing MOUD. Also, our neighboring state of Rhode Island has a similar bill included in their levels of care framework. And other states have other substance use disorder statutory protocol requirements. I've spent my life building evidence for ED treatment for substance use disorder, particularly opiate use disorder. I have not been able to change the practice in my own state, yet California ran with my work. I participated in the Connecticut Opiate Response, which is CORE initiative, advising the state of Connecticut on evidence-based spending of the opiate settlement funds. I am working with Connecticut's Department of Mental Health and Addiction Services right now to improve ED MOUD through monies appropriated by that settlement. We have had difficulty getting
Excuse me, Dr. D'Onofrio, but your time has expired. Thank you.
Can you complete? I was really interested to hear what your outcome for your DMIS support has been.
Okay, so we've had difficulty getting EDs to accept the funds for hiring health promotion advocates and insisting to assist the clinicians to detect, offer, and treat, despite the fact that I have offered my services and other EM-boarded emergency physicians to help beyond technical assistance. So this is time to act. I suggest that there are a couple of things in the bill that need to be amended, which I would say that treatment should be provided in any office-based clinic for buprenorphine and does not have to be a DMIS certified clinic. MOUD should include methadone as well as buprenorphine. And I also suggest that there should be a warm handoff to the referral sites for continuation of MOUD and not a simple referral with a name on it. I also ask there be some method for monitoring and feedback to ensure that the bill is successful and to help EDs progress. And this not just be another piece of paper. Thank you very much for my time.
Thank you. This is very, very helpful. Can I ask you a couple of questions?
Sure.
I think you were working with Carson and you had your publication at JAMA recently about your work.
Yes.
What is your bias, a 7-day treatment or a 30-day shot or a 7-day shot?
Oh, well, that work that we published with a bunch of group of people and my cohort with Dr. Filene showed that we, in the emergency department, could give a 7-day injectable as well as sublingual. And both of those groups were in treatment approximately 40% at 7 days, and more than that, 45% at 30 days. The 7-day injectable is great in the emergency department because of the way the pharmacology is. It has a gradual uptake in the bloodstream, and that allows us to inject it with people with very low CAL scores, as little as 4. Okay, so in the emergency department, while people are there, we could offer that injection and take advantage of the fact that they're right there in the emergency department. In this whole study, of which there were 2,000 patients in 29 sites, we had less than a 1% incidence of precipitated withdrawal. Only 5 people that got the injectable and half of that. So that's a reason to use the 7-day in the emergency department. We could use a 30-day, and we can have that offered as well, but that is a rapid rise. And so there's other things that have to be taken into account, but we should have 30-day available if we want it as well. If people come in and they've been on bupe before and they're in higher levels of withdrawal, you could inject a 30-day. But the advantage of the 7-day is that we can use it in people who are presenting with very low levels of withdrawal and take that opportunity to use it, to do it and really initiate treatment right then in the ED.
Thank you. And how fortunate were you to get them hooked with a outpatient facility?
We're very fortunate. We had all of our patients. We continue to, and again, I'm speaking on part of myself today, but I've never had any trouble getting anybody to a place. They're throughout Connecticut. There are places. People keep saying there aren't, but there are. And we just have to make those connections to get people into that and make that warm handoff happen. And really, literally, we can give out prescriptions in the ED. There's no reason not to give at least a 14-day prescription to get someone into someone's office or in a opiate treatment program. There really should be no reasons that we can't do that.
Your testimony is very helpful. The work that you're doing is very helpful. We are fortunate that we have a number of experts in this room and yourself here working on helping this issue out. And we are hoping perhaps as a public health committee, we can do something that may prevent some deaths. Thank you.
Good, thank you.
We have a question. Representative Carpino has a question for you.
Thank you, Mr. Chairman. I just had a clarifying question. Towards the end of your testimony, you said there should be no reason that we can't give a 14-day prescription. And I appreciate that. I was happy to hear that. I just want to confirm, can you write the script for 14 days or can you fill and send somebody home with 14 days of the appropriate medication because of the difficulties associated with sometimes filling the script depending on the particular patient?
Well, that... it depends on the hospital and whatever of whether or not we can get these filled. Some hospitals have pharmacies right there. And so if someone has Medicaid, for example, they can get it filled for 30 days even. Other times it's not. That's the advantage of using the injectable actually, so that there's not so much trouble of getting that initial prescription. But we, where I am, we have capacity to help with this. And at least start it there in the ED. So they have to go tomorrow, say, to get the to get the prescription filled. But that is an advantage of the injectable that you don't have to worry about going. But we found even in where I am that we have the ability of people getting those prescriptions.
Thank you very much. Thank you, Mr. Chairman.
Thank you again for your testimony. Seeing no other questions or comments, we move to the next person on our list. I want to make sure Malia Hunt is not there. So you are. I was looking at you on the computer again. Welcome. So Jaya, you have to wait for a bit. Go ahead.
Okay. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. I'd like to thank you for your leadership on public health and for holding.
Can you come closer to the mic and be a little louder? Thank you.
This better? Okay. I'd like to thank you all for your leadership on public health and for holding this hearing today. My name is Malia Hunt. I'm a graduate social work student at UConn, and I'm currently interning at UConn Health Disparities Institute, where I'm working on a menopause equity initiative. Today, however, I'm representing myself as a Glastonbury resident in strong support of House Bill 5389. Over the past 9 months, I've attended numerous community events across Connecticut focused on menopause education and awareness. I have spoken with countless individuals who all say the same things. I didn't know, I wish somebody told me. Most of these community members are already in perimenopause or menopause and uninformed of the changes already taking place within their bodies. In fact, 86% of our community members report knowing little to nothing about menopause. This is concerning because menopause does not result in just discomfort and undesired symptoms like brain fog and hot flashes. The decline in estrogen levels reduces bone density, increases cholesterol, and raises the risk of health conditions such as heart disease, strokes, and osteoporosis. This means that time, attention, and treatment are critical for protecting and maintaining quality of life and prevention of serious conditions or diseases. As much as we might encourage folks to talk to their doctors, healthcare providers may also be uninformed. Medical programs do not have enough curriculum on menopause. This is why less than 7% of primary care providers feel prepared to manage menopause. In Connecticut, there are over 500,000 women and gender diverse people in the menopausal age range, which is between 45 and 64. But there's only 23 Connecticut practitioners certified by the North American Menopause Society as being menopause competent clinicians. So there are far more individuals in need of menopause-related care than there are specialized clinicians available to provide it. Without the support of doctors, menopausal individuals seek help in unregulated markets for management of symptoms, often using compounded hormone therapy that is not FDA approved. This has many risks and places people at harm. This bill is a great opportunity for Connecticut to join and lead the national movement recognizing menopause as a public health issue. 21 out of 50 states have introduced legislation that focuses on improving menopause-related education and awareness between 2024 and 2025. I know there were some questions about that, so I'm happy to answer that. With the average life expectancy of women being 80 years old in the United States, women and gender diverse people will spend over a third of their lives in menopause. House Bill 5389 offers Connecticut a way to ensure our providers feel equipped with the knowledge, tools, and perspectives they need to deliver high-quality, inclusive menopause care. No one should have to navigate this transition uninformed, unsupported, or alone. I've submitted a written testimony in addition, but I'm happy to answer any questions you might have.
Thank you. You were within 3 minutes. You did a great job. Very good communication.
Thank you.
I wanted to ask you what's going on in the other states? What kind of policies?
Yes, so I've used LegiScan to do a policy scan of other states. I found 4 categories or like focus areas that other states are proposing things for menopause equity. So the first category is education. I found that 66% of these policies were covered by this topic. The next category was coverage, workplace, and direct care. For education, I can tell you that there was 5 proposals that were successful in passing in 2025. Maine created and distributed menopause education materials. Illinois and Pennsylvania passed awareness resolutions. So they set like a menopause day or week or month to focus specifically on menopause. And usually during those times, there's distribution of materials that kind of highlight what menopause is. In Arkansas, they passed an assessment of menopause health resources and care, probably to then develop policy to fulfill certain gaps that they find. And then Washington calls for the Senate to improve tools and efforts that will support those in menopause.
Thank you. This is very good.
Yes.
Very, very good. I don't see any questions or comments. Thank you for the good work you're doing.
Yes. Thank you.
Good luck.
Thank you for your time.
Next is Jaya Dadwal. Jaya, welcome. You're on.
Thank you. Good afternoon, Senator Anwar, Representative Vahi, Senator Mark, Senator McCrory, Representative Belton, and distinguished members of the Public Health Committee. Thank you for the opportunity to provide testimony today in support of House Bill 5322 and House Bill 5389. My name is Jaya Dadwal, CEO and co-founder of women's health company ForEva, and I also represent today my co-founder Emily Deschaines, the company's chief scientific officer. At ForEva, our work focuses on advancing women's health through research, innovation, and policy engagement. ForEva strongly supports House Bill 5322, a working group for endometriosis. March is Endometriosis Awareness Month, so it is my pleasure to be speaking with you today about the condition. Endometriosis affects approximately 10 to 15% of women of reproductive age. For most women, if we do not have endometriosis ourselves, we know a friend, loved one, or colleague who does. For me, that person is Kanika Madan, a close friend who at the age of 27 has already had 3 invasive endometriosis surgeries, 2 of which left her unable to walk for 2 months post-op. Endometriosis is a complex and often debilitating condition. Despite its prevalence and impact, patients wait an average of 7 to 10 years to receive a diagnosis, and these delays are even longer for many women of color. Women represent 50% of the population and 100% of our life force, yet women's health research and policy have historically focused primarily on fertility and breast cancer. Conditions such as endometriosis remain under-recognized and underfunded. Establishing a multidisciplinary working group in Connecticut would be an important step to addressing this gap. International models demonstrate how governments can take meaningful action in this space. Australia, my home country, for example, has invested over $37 million in a national endometriosis initiative, including the establishment of specialized endometriosis and pelvic pain clinics and the development of national clinical guidelines to improve diagnosis and treatment. House Bill 5322 has ForEva's complete support as an initial step in this direction. Yesterday, I testified before the Labor and Public Employees Committee in support of Senate Bill 5353, a bill calling for menopause accommodations in the workforce. Today, it is my pleasure to also support House Bill 5389, legislation directed at providing a menopause diagnosis toolkit. Studies show that over 90% of medical residents feel inadequately trained to manage menopause-related care. Menopause is not only a natural life stage, but also a critical period for long-term health. The reduction in estrogen associated with menopause can increase risk of cardiovascular disease, osteoporosis, and bone fractures, as we've heard today. Evidence shows that hormone replacement therapy is most effective when initiated before the age of 60 and when treatment begins close to the onset of menopause. Early recognition and evidence-based management is therefore essential. A comprehensive provider toolkit would equip physicians with clear guidance for diagnosing and supporting patients through perimenopause, menopause, and postmenopause, ultimately improving care for millions of women. Together, these bills represent meaningful steps towards improving women's health across the lifespan. By addressing conditions that affect millions of women, yet remain underdiagnosed and undertreated, Connecticut has an opportunity to lead in advancing equitable and evidence-based healthcare. Thank you for your time and consideration. ForEva would welcome the opportunity to work with the committee in any capacity and also answer any questions you might have today. Thank you.
Thank you so much for your advocacy here. We've been fortunate on this committee to have Representative Kennedy and Representative Gilchrist leading the way on this conversation related to endometriosis. So we're very grateful to have you here to help support this effort. Seeing no questions or comments, we will go next to Alex Brown, who I believe is here. Welcome.
Thank you. Good afternoon, members of the Public Health Committee. My name is Alex Brown. I am an MSW student at UConn and work in policy and advocacy on human rights issues. I am here today in support of SB 364, an act concerning extreme weather, and HB 5389, which would establish a provider toolkit for menopause diagnosis and treatment. Today, I plan to spend my time talking about HB 5389. Menopause is a normal stage of life, yet many people still navigate it without clear guidance from the healthcare system. Symptoms such as sleep disruption, hot flashes, brain fog, joint pain, and mood changes can significantly affect daily functioning, mental health, and overall quality of life. Despite this, many patients report that their symptoms are dismissed or not fully addressed in clinical settings. One of the challenges is that many providers do not receive extensive training in menopause care. When clinicians lack clear resources or guidance, patients are often left searching for answers on their own or navigating symptoms without adequate support. A provider toolkit offers a practical and accessible way to help address this gap. By giving clinicians clear, evidence-based guidance that can be used in everyday practice, Connecticut can help ensure that providers across specialties feel more prepared to diagnose menopause, discuss treatment options, and support patients through this transition. From a social work and public health perspective, improving menopause education is also about health equity. Access to accurate information, knowledgeable providers, and evidence-based treatment can shape whether individuals receive meaningful support or are left navigating significant health challenges on their own. A well-designed toolkit can help normalize conversations about menopause in clinical settings and ensure that providers have the tools they need to offer informed and compassionate care. Menopause is something that millions of people experience, yet too often it remains overlooked in healthcare conversations. HB 5389 represents an important step towards improving provider education and strengthening menopause care across Connecticut. Ensuring that providers have the knowledge and tools to support patients during menopause is not just a clinical issue. It is a matter of health equity, dignity, and quality of life. Thank you for your time and consideration. I respectfully urge you to support HB 5389 and SB 364.
Thank you so much for being here today with us. And I will add to what Rep. Belton said earlier as a fellow social worker. It's wonderful to see our social work students and leaders here. So thank you for your testimony today.
Thank you.
Seeing and hearing no other questions, we will go next to Paul Kidwell, who, as I mentioned to him earlier, seems to somehow always end up at the tail end.
But I learn so much every time. So
it's great to see you, Paul.
It's appreciate being with all of you this afternoon. I had actually written this evening, but I got to scratch it out. So this afternoon, we've submitted testimony on a number of bills today, but wanted to take my time on HB 5045 and 5049 and just highlighting some of the key points we make in each of those bills related to the CON process. As has been noted, 5045 proposes a fundamental restructuring of the CON process in our state. We certainly appreciate the intent of the administration to create a process that moves applications more expeditiously. There are a couple of provisions or lack of provisions in the legislation that I'd like to highlight. The first, and as Boyd Jackson from the Office of Health Strategy noted this morning, the bill allows through the process the unilateral imposition of conditions. Currently, in today's process, those are negotiated with OHS, and in this new process, those would be sort of take it or leave it conditions. We think the bill also needs to include prohibiting applicants from being mandated to meet requirements or obligations that are not set forth in statute or regulation in order to obtain a CON. We believe that those conditions should also be justified, and the duration of any condition should be justified by weighing the burden of the condition against the benefit. There's also some discussion related to the flipping of the hearing requirements. Not every CON application should be subject to a hearing. This change in process will significantly slow down CON approvals and subject the most adversarial CON requests to an overly administrative process that is not required. There's also a significant shift in that CONs will be determined by a 3-member panel. We're concerned that the infrequency with which the panel will meet will mean CON applications are delayed and not determined timely. We also believe the legislation requires clarity related to the role of the panel. Will the panel preside over hearings, or will they convene to make determinations? If they're not presiding over the hearings, who will be conducting the required hearings? And will the panel be able to meet in between their scheduled quarterly meetings? We certainly appreciate that there's a change in service terminations where there's a requirement that the Department of Public Health Commissioner would have to approve a plan. What we're concerned about with that is there's no off-ramp should the DPH Commissioner never approve the plan for the service termination. There needs to be some due process where a applicant could appeal sort of a never-ending process with the department. Related to 5398, certainly there's been quite a bit of testimony related to that bill today. As we've noted in the past, we are concerned related to the review of transactions involving any healthcare entity, and including that the Office of Healthcare Strategy or its successor organization would be able to participate in the AG's process, basically creating a separate CON process through the Attorney General's office. What has not been noted today is there's a separate section in the bill at the end related to a requirement that to include the corresponding actual cost of each related good or service when a hospital files its price master. I think the bill just generally doesn't recognize how hospitals do this process. We don't do it by service. We do it in the aggregate, and it's a means to understand how we're getting reimbursement in from insurers. And the notion that we would have to do this by service would be extraordinarily administratively burdensome and expensive. Happy to continue to discuss that provision with the committee, and thank you.
Perfect.
Sorry, Kathleen, I talked right over you. I'm sorry.
The voice
Saw
is
that. Thank you.
Oh my gosh. It's great to hear Kathleen's laugh. Paul, thank you for your testimony. Your testimony is online, correct?
It is, and it's much more extensive related to certainly the CON bill. We have some very specific provisions. I think just generally, we'd like to engage in the conversation. We are glad that the administration has proposed something with this committee, and CHA certainly has been talking about the CON process for some time. We think there are things that should be corrected. We think the intent is to make CON more efficient and effective, but we think there are some things in here that won't get us to that end. And so we just want to keep talking about how do we improve it.
Thank you. Senator Anwar. No, I'm good for now.
Thank you for your testimony, and I think this is a big shift that's happening from Office of Health Strategies to the Department of Public Health. This would be a good opportunity to revamp some of the things. So agree with you about the process issues. Like I was having a conversation initially with Boyd Jackson, was that there's a part that is what condition situations should require that's a separate conversation, and the part that I think many of us may agree with the CHA is the process part, the streamlining part. I think there's an area of opportunity there to make it more efficient but fair at the same time, so that everybody has a say, but it needs to be efficient, and there should be pathways, and there's more than one pathway depending on which path it would be. And the area that perhaps I may disagree with CHA is that when somebody's going to leave a community, I would like to have a CON process there. Not necessarily as robust or challenging, but we need to have a frank conversation of who's leaving and why, and then what's going to be the negative impact.
Yeah, certainly. I think contemplated in the legislation is that a plan would have to be submitted to the Department of Public Health, and the applicant would have to explain why they were removing the service or ending the service, and what would be the steps to remediate any impact for the service. So certainly, Senator, happy to continue to talk to you about that, because certainly those decisions aren't made lightly.
Right. And so I saw that part, and to me, it's good that that information will be there. The challenge I have is, I'll use a hypothetical example. So let's say Wyndham healthcare is being taken away. The women will not be able to get any OBGYN or women's healthcare issues. While the hospital may put that information to the Department of Public Health, I want the community to be able to come up and say, no, 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 we need this help. There's going to be a big vacuum. There'll be a gap created. So it needs to be a public conversation around that, so that we can start to see what else can be done by the state. And if the hospital cannot do it, there may be ways around it for some support systems that can be created. So that's where I think there's an area of opportunity. When you withdraw support or service from a community, we need to have that community be aware of what's going on. And on the entry point, I think that should be made easier. Exit should be a little difficult, not extremely difficult, but difficult. And the process should be efficient. So that's the simplistic thing. So I think we will see eye to eye on a number of different aspects for sure. And then would love to coordinate collaboratively with everybody and getting everybody together to make the best decision.
Appreciate that. Thank you.
Good. Representative Clarity's teacher.
Thank you for being here today. I think there's something in this bill for everybody to hate.
Yeah.
And maybe more than one thing in the bill. I do think everybody is in agreement that we need to streamline whatever process we have, because it takes too long and there's too many obstacles to go through the CON process. So I'm hoping at the end of the day, we have something that we don't hate. And that's a lot of times what legislation that comes out of here is a compromise. And we'll work with CHA to address some of your concerns, because I do think that if a hospital isn't making money, or they can't get the help with the doctors, they can't keep a service if they can't keep the doctors in. So there's, I think that's worth the conversation to try and figure that out as well.
Appreciate that. Sometimes these CON applications are symptoms of other things, right? And so we certainly try to keep that in mind. And we also now have experience with our sort of the expedited CON process related to bankruptcy, where we know that these processes can be done efficiently with due diligence, and sort of done in the best interests of the state. So we know we can do it. And now I think it's applying it to a broader set of CON circumstances.
Thank you. Representative Kristen McCarthy-Vahey has another question.
Thank you, Senator Anwar. And so to that point, Paul, besides and outside of the expedited process, Would you say that there's been a change and improvement in the time and experience? Like, I think we've heard from OHS that they have, shown us data, but just from your end.
Yeah, I think from our members objectively, there are certain CONs are moved more quickly than they had been in the past. So I think OHS had been making a concerted effort to try to process those things more quickly. As Boyd described this morning, there are structural things about the CON process that make it burdensome, make it expensive. If we could, in this legislation, amend those things that make the process burdensome and expensive while not foregoing the review that we all think should be done, I think we'd be in a better position. I think the other, beyond structure, we've talked about this with this committee. We're concerned about a CON process that is used to extend other health policy ambitions of whatever administration is in power at the time. That the CON process is not a policy-making apparatus. It's a health structure apparatus and what we want healthcare to look like in Connecticut.
So thank you for that answer. And something you said, you used the word burdensome, but I think referencing Mr. Jackson's testimony, there are also statutory timelines that are in place, right? Like, is that part of what you're talking about? I'm just gonna give words to what I see you saying.
Yeah, I think that
like
the time frames also can be. I'll use an example. So I worked at the Center for Medicare Medicaid Services in Medicaid for many years, and there are statutory timeframes in the Social Security Act about how states and the CMS interact. But they get used to say, let's pause this and ask for more information, and then we'll come back and let's ask for some more information over here just to buy time. And so the corollary in Connecticut is that the statute can be used to buy more time, ask more questions. And all of that means more cost and more delay. And to what end? At the end of the day, are we coming up with the same answer that we would have come up with 90 days prior? And did all that information we provide actually get used in the process or not? That's very opaque today.
Thank you. It's helpful. I would say what I'm hearing you say, and you can correct me if I'm wrong, is that there definitely has been improvement, especially in certain areas, that there is a need to make changes to the statute so that we can continue to improve and try and get closer to what the expedited process has looked like and continue to review. So you're not saying, and you haven't said consistently over time, we want to get rid of this process. We just want to make it work better for everyone. And in the end, for the patients who are receiving care.
Absolutely. We do not want to get rid of the process. We think there's room for it, but we think it needs to be improved, and unequivocally it needs to be improved.
I can almost promise we'll have a lot more conversations before the end of the session.
So.
Yes.
We hope so.
Yeah, it's much needed. Thank you so much. Thank you for being here with us all day.
Thank you. Thank you.
And that brings us to the next person on the list, number 48, Dr. Gigi Meinecke. Welcome.
Thank you. Thank you, Mr. Chairman. My name is Dr. Gigi Meinecke, and I'm speaking in support of House Bill 5399. I have a degree in nursing and dentistry and hold active licenses in both. I'm a faculty member at the Boston University School of Dental Medicine, where I served for nearly a decade as the director of the facial injectables program. For more than 15 years, I've taught and continue to teach injectables in continuing education programs nationally, as well as dental residency programs, often in conjunction with cadaveric anatomy. I'm a head and neck cadaveric prosector, and I also serve as expert witness in legal cases exclusively involving facial injectables. In my limited time today, I'd like to highlight a few points that may add additional perspective to our discussion and help clarify some of the concerns that have been raised. Dental education is often misunderstood. Dentists complete 4 years of doctoral level education after college that includes pharmacology, anesthesia, emergency management, and management of complications. In my own education, I completed the first 2 years of medical school alongside my medical student colleagues before transitioning fully into my dental training. Many dentists actually hold hospital privileges and routinely treat medically compromised patients. As the U.S. population ages, dental care is provided to individuals with complex medical conditions by all of us and requires a high degree of preparation, which we have. Dentists have used toxins since the late 1980s for movement disorders of the jaw, tongue, and lips. And this was decades before its first cosmetic FDA approval. And we continue to use it today for these same dystonias and TMJ problems. In a landmark publication in 2010, the National Academies of Sciences, Engineering, and Medicine, an independent body that advises Congress on science and healthcare policy, emphasized that healthcare professionals should be allowed to practice to the full extent of their education and training. This reflects modern healthcare workforce policy. Patients are best served when trained professionals are allowed to fully utilize the skills they've been educated and licensed to perform. And my last point is this. It's very important to know that consensus literature recommends spacing Botox treatments, at least 3 months apart to reduce the risk of antibody formation and resistance. When cosmetic and therapeutic injections like those used for TMJ are split between practitioners, patients can inadvertently receive staggered dosing that violates this well-documented precaution. Dentists are the primary clinicians trained to diagnose and manage disorders of the masticatory system, including TMJ and parafunction, which is why medical practitioners often refer these cases to us. Tox treatment provided by a single trained provider allows for adherence to the official label-based dosing intervals and protects patients. Thank you. And I appreciate the opportunity to speak today, and I'll be happy to take any questions.
Sure. Thank you for your testimony. Representative Claudius Teacher has a question.
Thank you, Dr. Gigi, for being here today. My first question is, are doctors qualified to do cosmetic injections on the face?
Dentists, yes.
Dentists, sorry, yes.
Dentists, the very education that we receive, all of us, is the entire head and neck. And when I train individuals now, what I'm basically doing when I'm training dental practitioners is this is a complete review of something that they probably experienced either with a cadaver or with some sort of modeling or 3D modeling of the layering of the facial envelope. So dentists are head and neck experts. So yes, they are eminently qualified to treat the upper third as well as the lower third. And I would add that the lower third is much more complex than the upper third. So it's strange when I hear from other states that they won't allow the upper third, but they'll allow the lower third, which means you have to train someone immediately in the most difficult area.
Thank you for that answer. And isn't it true that now in 2026, dentists go through an extensive training on oral, face, head, neck anatomy, and also do cadaver studies, cadaver work on the head?
Most programs, as I mentioned, have cadaveric dissections. Either they've been prosected before by someone who has the ability to dissect these just simply because of cost and time constraints. But just about every program I'm aware of includes cadaveric dissections. So you really get to understand the different layers of the face. And I mean, the other point I would like to make is we are the only profession that I know of that on a daily basis we're injecting cranial nerves. And that's when you get down to toxins, that's absolutely what we're doing. But a very clear understanding of the three-dimensionality of the face is something that is part and parcel to every single dental curriculum that I know of.
Thank you. And one of our testifiers another doctor had mentioned that his concern is that dentists don't have hospital privileges, but I heard you say in your testimony that dentists do have hospital privileges. Is that correct?
Many of them do. I have a colleague here in Maryland who is a general dentist that treats compromised patients, and he has hospital privileges. And this is just in my very small enclave of people that I know in the community. But I know he's not alone. I just happen to know him personally.
Okay, thank you. And my last question, I'm sorry, Mr. Chair, is there was also some information out there on negative outcomes. And have you heard of any negative outcomes in other states from dentists performing neurotoxins or fillers?
So as I said in my preamble, I do expert legal work for cases that only involve injectables. And I have a small minority that have been dentists, and I have the larger majority of those cases have been medical individuals. The bottom line is, and we all understand this going into this, that adverse events are something that are just a reality, and understanding what can happen. And I know that every day, like today, when I was picking up syringes, I'm always thinking about what is exactly underneath my needle, because the face is an amazing network of on and off ramps of vasculature. So I'm always thinking about what could be there. But the bottom line is everyone must be prepared for the eventuality of adverse events, because I've been to many medical forums that are solely based in injectables. And the word is, well, if you haven't had an adverse event, you haven't been doing it long enough, because everyone gets adverse events. And the bottom line is being prepared for that. And I would say that the cases that I see, the predominance of the cases that I see in the legal realm are people that were not prepared for those eventualities, which is why in my programs, I usually say, if you see me spending time and dwelling on something and you're wondering why is she beating this dead horse, it's because I see a signal that individuals, medical, and like I said, a minority is dental, but that could also reflect the number of individuals doing these procedures. I recognize that, but everyone should be prepared. And when I teach, I make sure that I cover these areas and people are prepared for all eventualities.
Thank you, Dr. Gigi, for testifying today and giving us a lot of helpful information.
It's my pleasure. And I'm always available by email if there are any follow-up questions. I'm happy to do that.
Thank you so much for your testimony and answering all of our questions. We don't see any further questions, so thank you again.
Thank you.
We'll move to the next person on our list, which is Heather Gaidon. Welcome.
Thank you. Good afternoon, distinguished chairpersons and esteemed members of the committee. I want to first thank you for your time and the privilege of being heard today, especially during the first week of Endometriosis Awareness Month. My name is Heather Guidon, and I am the Program Director of the Center for Endometriosis Care, a member of Representative Gilchrist's Endometriosis Legislative Working Group, and someone who has lived with this disease most of my life. For over 3 decades, my work has focused on moving endometriosis from the margins into evidence-based public health strategies, and I'm grateful for the opportunity to testify today in strong support of Raised Bill 5322. Endometriosis, if you are not aware, is a systemic inflammatory disease affecting nearly 200 million women and girls, along with unmeasured numbers of gender-diverse people worldwide. It costs an estimated $69 billion in healthcare expenses and over $119 billion in lost productivity annually. This disease can erode quality of life, impair daily functioning, derail education and career trajectories, impact family building, and impose lasting consequences. Yet patients still wait as long as a decade or more for diagnosis and will see as many as 5 physicians on average before their symptoms are finally believed and treated. These delays are not benign, and that is exactly why Connecticut's leadership matters. Our Connecticut-based working group and the EndoRise biorepository have become the national model, turning long-ignored suffering into real change. Maintaining a formal working group is critical to keeping stakeholders involved, including and especially patients and advocates, establishing policy commitments, securing ongoing funding, and continuing our precedent-setting progress, not just across the state, but as the template for the nation. Awareness alone is not enough for endometriosis, and sustainable changes require coordinated policy investments and institutional commitments. Supporting this bill is critically important towards continued improvements in diagnosis, proper multidisciplinary treatments, research strides, and increased accurate disease awareness. It sustains our momentum and continues Connecticut's public health leadership on endometriosis and represents true commitment to ensuring fewer people will spend a decade being told their debilitating pain is normal. For all these reasons and more, I implore the committee to move 5322 forward and support the research progress and life-changing efforts it represents. Thank you again for the privilege to be heard today, and I'm happy to answer questions or submit more detailed written testimony if needed.
Thank you so much for your testimony. I have Representative Gilchrist and then Representative Kennedy. Representative Gilchrist, you're on.
And I'm sorry I can't be on camera. I just wanted to say thank you to you, Heather, for being here today and for all the work you do for those who have endometriosis and everything you've contributed to the working group so far and what you will contribute in the future. So thank you. Thank you, Mr. Chair.
Thank you, Representative Kennedy.
Thank you, Mr. Chairman. And I too wanted to thank you, Heather, for bringing this to the forefront. So many times we talk about endometriosis and it was just pushed back. And, women continually were always told, oh, it's fine, take an aspirin, use a hot, washcloth or whatever, make yourself, you'll be fine. And so I really appreciate you. And it's significant that we're taking this bill up today when yesterday we kicked off Endometriosis Month with a little public hearing, and it was wonderful. And I do believe you were there. I just want to again say thank you so much for keeping this in the forefront. Thank you, Mr. Chairman.
Thank you.
Thank you. This was all strategically planned by the Public Health Committee. Seeing no other questions or comments, thank you so much for your testimony. That brings us to Dr. Atiq Mirza. Dr. Mirza, you're on. Thank you for your patience with us.
Hello, and thank you for all of you who are having such a long day. I heard it started at 11 o'clock and it still has to go long, many hours from here. So anyway, good afternoon, Mr. Chairman, Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claridas Detra, and distinguished members of the Public Health Committee. My name is Dr. Atiq Mirza. I'm a practicing cardiologist and the president of Hartford County Medical Association. Thank you for the opportunity to testify in support of Senate Bills 364 and 365 today. First, with respect to Senate Bill 364, as we know that extreme heat and cold are not only the weather events in our human lives, they are predictable public health emergencies if temperatures go to extreme levels. As physicians serving communities across Hartford County, we and our colleagues see the consequences firsthand. Extreme heat contributes to dehydration, heat stroke, worsening existing heart and lung conditions, and kidney injury. Certain medications, including diuretics, beta blockers, also can increase significant vulnerability to those patients who are on these medications. Extreme cold increases the risk of hypothermia, heart attack, stroke, respiratory failure, worsening of the heart failure, falls, and carbon monoxide poisoning. There has been a very robust circulation paper published in 2023, which can be submitted as an evidence in case it's needed. Emergency departments across Connecticut routinely see spikes in temperature-related illnesses during severe weather events, many of which are preventable. State Bill 364 recognizes that extreme weather requires coordinated planning, establishing clear statewide protocols to improve communication, early warning systems, outreach to vulnerable residents, and access to warming and cooling centers. As standardized frameworks promotes equity and preparedness across municipalities, evidence-based scientific measures will save lives while reducing strain on our healthcare system. Now, turning to State Bill 365, as we know, opioid use disorder remains one of the most urgent public health crises in Connecticut. As a matter of fact, my last patient I saw today, when I was leaving my office, he has 3 children and he's lost 1 child to opioid abuse, and he had to adopt his 3 children. And now he said, I took care of 2 families. So we have seen some decline in our fatal overdose. Hundreds of residents continue to die each year with fentanyl overdose in a vast majority of cases. Non-fatal overdose remains high and represent critical missed opportunities for many interventions. State Bill 365's bridge program model focuses on emergency department as a point of engagement, initiating medications for opioid use disorder such as buprenorphine at the time of emergency care has been shown to reduce mortality and significantly improve connection to long-term treatment. Providing naloxone at discharge equips patients and families with life-saving tools. We believe discussions on implementation should continue in coordination with our emergency physician colleagues and other stakeholders to address clinical workflow.
Excuse me, Dr. Mirza, but your time has expired.
All right. So
Thank you.
On behalf of Hartford County Medical Association, I respectfully urge you to support these 2 bills because extreme temperatures can cause fatalities, and opioid abuse and overdose also disrupt families and are very disastrous. Thank you for your consideration.
Thank you so much, Dr. Mirza, for your testimony, and thank you for the work you're doing. And thank you, Hartford County Medical Association. We are all a little tired, so it's not lack of interest, but we just want to get to the next person online.
We are available for answering any questions in case you have. Thank you so much.
Thank you. Thank you. With that, the next person on our list is Jennifer Paredes. Jennifer, welcome. Good to see you.
Hi, hello, hi everybody. I know it has been an incredibly long day for you all. Thank you so much for your service and your work. Co-chair Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Jennifer Paredes, and I serve as the Executive Director of the Bethel Center in Milford, Connecticut, and I am a resident of Hamden. Thank you for the opportunity to testify in strong support of SB 364, an act concerning extreme weather protocols. It's critical in moments like this that I also share that I'm a person with lived experience. Those who will be the most impacted by these critical policy changes are people like my parents, Bob and Judy, who spent years and many hot summers and cold winters sleeping in their van in the back of a bowling alley where my dad worked. I ask that when we are voting on policies such as SB 364, that we think about our loved ones and we think about if they were in the position where their lives, their health depended on the extreme weather policy working to be clear, to be consistent, and to be predictable. We are all very far away from that reality today. Our current policies do not match the current problem, and the amount of deaths we've experienced this past year alone is evidence of the extreme weather policy that waits too long. In Connecticut, you know, homelessness has increased 44% since 2021, with unsheltered homelessness rising by 45% in the past year alone. These numbers are even more significant in the greater New Haven community where we work, where homelessness has increased by over 80%. Extreme weather policies are now an essential part of how we need to respond. Our cold weather program at the Bethel Center is a life-saving extension to our emergency shelter infrastructure. And at a time, typically we have capacity for 20 individuals. However, we have seen consistently since the day we opened 40 to 65 folks consistently throughout the season every night. And large weather events bring us over 100 folks coming to our doors for help. We have struggled to serve so many, but we have also refused to turn anyone away, resulting in the needs of additional overflow sites and a volunteer corps of over 80 volunteers helping our staff manage night to night. This is a blessing, but not how we should be operating our emergency response as a state. life-saving care for our most vulnerable, sick and elderly, and families. Scotch tape and bubblegum does not touch the surface of describing how we are responding to the need today. And yet we stand these resources up night after night on a moment's notice with a tremendous amount of statewide miss and lack of information, communication, disjointed coordination, putting overwhelming strains on our already extremely limited resources. Further, our current lack of policy traumatizes staff and guests alike, not knowing how or when or if emergency weather protocols will be enacted. At this point, I think that you all have heard that the goal of this policy is to create stability, is to create clear, consistent, and predictable policy. It is better for us all, and it is better for the staff, it is better for the guests, and it's better for our communities at large. I want to close really by just thanking you all for introducing this policy, but also just sharing. I understand that OPM came out with a report saying that the expense associated with this policy is about 17.5 million or something around there. And I've heard before, I heard earlier today that we really need to be thinking about this moment and through our values. And not just what our budgets look like. However, emergency response is.
Excuse me, Ms. Paradis, but you have reached your 3 minutes.
Thank you. I'll close very, very quickly if I may. Emergency response is two-pronged. One is the response through 169 municipalities, and two is through the homeless response system. And I do think that if we got creative and we started looking at how we implement emergency cold weather protocols, particularly through the municipalities, we could possibly find some cost savings, but I think better coordination. And so I would encourage us to not just look at the whole as it exists today, but also take this time to reflect and make sure that that the policy is updated to reflect today's needs for the person, but also from an infrastructure perspective, that it's reflective of how our communities need to work together regionally. Thank you so much.
Thank you, Jen, for your testimony, and thank you for the work you do to raise awareness, but also help the people who are unhoused in our state. I think we do not see any questions, but there is a question. Yes, Representative Kennedy, sorry.
Thank you, Mr. Chairman. I know it's been a very long day and I still have to go over to Education Committee, but I would be remiss if I didn't acknowledge Jen Paradis. Jen, your work is just incredible. The work that you and your staff do. I've been there so many times, and how many times you've had to stay open, with the cold weather protocols in place and serving all the people that there. You just do an amazing job. And I just wanted to note that. Thank you, Mr. Chairman.
Thank you, Representative Kennedy. Jen, you have a lot of fans over here. Keep up the
Thank
good
you
work.
so much. We do that alongside you, Representative Kennedy. You are family. Thank you so much.
Thank you. With that, we have the next person who's in person over here, Dr. Wong, Jason Wong. Thank you for being with us. And then final speaker will be Tricia Cunningham. So Tricia, hang in there for us for a little bit. Thank you so much for being with us all day. And I apologize for the technical difficulty you had, but I'm so thankful that you have helped us out with a number of thoughts on the policy, and then you're going to speak as well. Thank you.
It wasn't a technical difficulty. I just submitted too late. But dear honorable members of the Public Health Committee, my name is Sujia Jason Wang. I'm a board certified addiction medicine physician at Hartford Hospital, where I direct our outpatient addiction bridge clinic and serve on the addiction medicine consult service. I'm the president of the Connecticut Society of Addiction Medicine, representing physicians, PAs, NPs, and other professionals across our state who specialize in addiction treatment. I'm here representing the views and recommendations of the Connecticut Society of Addiction Medicine. Thank you for the opportunity to testify on SB 365. There remains a profound gap between what we know works for opioid use disorder and what people actually receive in many hospitals and emergency departments. Medications for opioid use disorder, buprenorphine and methadone, reduce mortality by more than 50%. They are among the most life-saving treatments in modern medicine. Yet, they remain dramatically underused in emergency settings. In one large national study of more than 74,000 ED visits for opioid overdose, less than 1% of patients were discharged with buprenorphine, and only 23% received a naloxone prescription. Here in Connecticut, our overdose rate is among the highest in the Northeast. For people with unstable opioid use disorder, every visit to a Connecticut emergency department is a critical intervention point, a moment when people are at high risk of death but are also highly reachable. If we fail to start evidence-based treatment at that moment, we are missing one of our best opportunities to save lives. We can and must do better. SB 365 moves us in the right direction. We strongly support its intent to improve ED care for people with opioid use disorder. However, we recommend several targeted amendments to ensure it reflects best clinical practice. First, methadone should be explicitly included alongside buprenorphine as an appropriate treatment option. Second, if buprenorphine is initiated in the ED, the bill should require a bridging prescription so that the person isn't left without medication prior to reaching follow-up care. Third, if methadone is initiated, patients should receive a direct referral to an opioid treatment program and a documented last dose letter to ensure continuity. Fourth, the definition of acceptable buprenorphine referral destinations should be broadened from narrowly defined treatment programs to include qualified community providers such as bridge clinics such as mine, buprenorphine-capable PCPs, and psychiatrists. Alternatively, the language of the bill could be revised to use the more broadly accepted and understood ASAM levels of care. Fifth, the bill should ask that hospitals train and support EDs to provide evidence-based opioid use disorder care, including providing subspecialty consultant support if necessary. Finally, the bill should preserve clinical judgment, making clear that no medication is required when contraindicated and that clinicians retain full professional judgment. I am not only speaking on behalf of the Connecticut Society of Addiction Medicine, I'm speaking on behalf of people who we've lost after being discharged from hospitals without effective treatment. And I'm speaking on behalf of the many we can still save if we align hospital practice with established evidence. SB 365 represents a meaningful opportunity to reduce overdose deaths in Connecticut. With these amendments, we can encourage hospitals to deliver high quality, high reliability, evidence-based care for people with opioid use disorder. Thank you for your leadership and for considering our recommendations. I'd be happy to answer any questions.
Thank you so much for your testimony. Thank you for the work you do. And thank you for working with Diane Santos, with Mark, and then having her be the keynote speaker in Hartford on this topic.
Yes.
So
I'd like to extend an open invitation to you all. We are going to have our annual Connecticut Society of Addiction Medicine meeting on May 19th at the Bone and Joint Institute at Hartford Hospital. And the keynote theme is going to be closing the gap on hospital-based opioid use disorder treatment. Diane Santos will be our keynote speaker, and then we're going to have 6 leaders from Connecticut hospitals discuss how they are working to improve opioid use disorder treatment at their institutions, both successes and the barriers that they faced. So it'll be a very powerful night, and there will be research and free dinner.
would you be able to email that to us and we can share with the entire committee?
And I've got paper invitations as well.
You come prepared.
It's going to be really a blockbuster night.
Yeah.
I think it'll be powerful, and I think it'll help anybody who attends just understand how hard we're working on this and how much more we have to do.
Right. I so much appreciate your testimony and your help. You sent me an email, reached out. We had quite a few conversations. I'm glad Senator Slapp connected us as we worked on this. One of your recommendations is to have a training program for the ED doctors and staff in the emergency room. We may get a little pushback on that because at times, if we have programs like this, there's money involved with it, and that may be part of the challenge, but we'll approach that and see if there is a way to educate individuals without having a cost associated with some of that aspect. So that's very helpful.
Yeah, I think the cost does not need to be extraordinary at all. It's not incredibly difficult to start buprenorphine. I think there's it's really a matter of institutional will. Hospitals prioritizing this. It's as Dr. D'Onofrio mentioned, it's not terribly difficult to start it. There are some tricks of the trade these days with fentanyl and the pharmacokinetics of that. But really, it's an institutional will. The evidence has existed for many, many, many years. And Connecticut is a little bit behind the 8 ball. When I initially got out of practice in New Hampshire, this was 10 years ago, and we were experiencing a horrible opioid crisis. We were #2 overdose deaths in the nation. And we initiated a buprenorphine induction protocol at our medium-sized community hospital. It was not an extraordinary amount of training. And we cut our against medical advice discharge rates in half. We more than doubled our buprenorphine linkage rates to outpatient treatment. We more than doubled our rates of buprenorphine treatment at all. We reduced our readmissions by over a half. So think of the savings as well to the state, in addition to the reduction of the amount of suffering that we have in this state. So it was a real benefit, and that was almost 10 years ago. So we can do it. I don't think it's. I think it really is just moving all these levers in terms of education, support, legislative levers, potentially regulatory levers, as others in my field have written about. There's many levers that we can do, and activism as well. Activism.
My colleague, my co-chair has a question for you.
Yes.
Thank you, Senator. And thank you, Dr. Wang, for staying with us today. It was worth it because you have offered some excellent testimony and very substantive recommendations for us, as well as proof that this is working in the settings you've experienced. Just a very simple question. I don't have my computer up right now. Is your testimony online or have you submitted written testimony?
Yes, and it's a little bit more lengthy, what we submitted online. So yes, it's up there.
Wonderful. And thank you for sharing the information with us about that event. I think it will be really helpful. We're grateful to have you as a resource. Thank you.
You're welcome. Thank you for your time.
I'm going to put something on your radar. Majority of the people who are unsheltered now outside are using substances. We cannot get them to get a place. So we'll have a conversation. Maybe there's a project that we can work on to see how we can help them, because they cannot get hooked up to a rehab facility and there's sort of chicken and egg situation that they get stuck in.
It's all related. Housing, substance use disorder, mental health, other issues as well.
Thank you so much for your testimony. Thank you. With that, Tricia Cunningham, you're on. Welcome.
Hi. First of all, I want to say thank you and apologies. I didn't get the Zoom link, so here I am. So thanks. I'm sorry to be joining you at the tail end. Good evening, co-chairs, Senator Anwar and Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. I have paid attention throughout the day on and off, and it's noteworthy how thoughtful this committee is, and loving all the questions and how engaged you all are. My name is Tricia Cunningham, and I serve as Executive Director of Always Home. Our mission is preventing family homelessness throughout Eastern Connecticut, and I reside in North Stonington. I'm also a fellow fan club member of Jennifer Paradis. We at Always Home, we're a member of the Eastern Connecticut Coordinated Access Network, and we serve as a hub for the homelessness response system. And we are in support of SB 364. And the following testimony I have is really from the point of view of our CAN in our region, Eastern Connecticut, and was written with the help of Jamie Parker, our CAN manager. This winter, Connecticut activated a severe cold weather protocol for 46 days, requiring extended shelter hours, overflow coordination, transportation planning, late night intakes, and street outreach in below freezing conditions. Each activation relied on dedicated staff working around the clock to ensure no one was left outside in dangerous temperatures. For staff, activation meant canceled days off, double shifts, and constant schedule changes. Warming center staff, outreach teams, and hub staff routinely stayed far beyond scheduled hours, often through weekends and without additional pay, putting personal responsibilities aside to keep people safe. For clients, last-minute activation notices created confusion and stress. Many were unsure where they would go, how they would get there, or whether space would be available. These uncertainties understandably created frustration and erodes trust in the system, making it harder for our outreach workers to build the relationship needed for housing-focused work. When activation stretches across consecutive weeks, strain intensifies across the system. Staff worked tirelessly to secure warm spaces, food, transportation, and basic necessities, tasks complicated by clients' diverse and often complex needs, as you've heard today. Medication pickups, medical and housing appointments, transportation logistics, and frequent mental health crises fell heavily on a workforce already operating at capacity. SB 364 presents an important opportunity to bring greater structure, predictability, and support to extreme weather response. Clearer protocols and earlier planning will help reduce strain on frontline staff while ensuring that individuals experiencing homelessness receive timely information and consistent access to safety. Our staff are deeply committed to their work and to the people they serve, but they should not have to depend on last-minute decisions and extraordinary personal sacrifice to keep people safe. For these reasons, I and many others in our region respectfully urge the committee to support SB 364 and strengthen Connecticut's ability to respond to extreme weather in a way that protects both the vulnerable residents and the workforce designated to serving them. Thank you for your time and for your team in making sure I had the opportunity to testify tonight.
Thank you. Thank you. You were like on the dot. You're like probably have a stopwatch working that you used it perfectly and got all the message through. Yes. So with that, I don't see any questions or comments. But your testimony is very valuable to us, and it's going to help us make the best decisions. Thank you, and stay well. And you're our last speaker. With that, we will end our public hearing. We stand adjourned. Thank you.